to bring all the function, the endothelial cells that we denuded are not there. And if you look at the importance of the endothelium, what is the function? The most important one is intravascular regulation of thrombosis, inflammations, proliferation of small muscle cell, infection, and fibrinolysis. And the molecule most important of that is the nitrous oxide release. All the function, the endothelial cells that the nitrous oxide release are not has the function that regulates all those the importance of the endothelium. What is the function? The most important one like is endothelial mimicry can be done in many ways. But the utilization of nitrous oxide as an implantable device, most important of this kind of the function, the interventional device, we're going to provide as the area that regulates all the importance of the endothelium, all the element of the endothelium until the endothelium interaction regulation can be done in many ways. And but the utilization, special interest in nitrous oxide, working continuing work with molecular biologists is conscious of. And here is a summary of how it's in the liver. Nitric oxide, or the other is the biopolymer coating of the stent is done with endogenous donors that by in contact with blood produces NO transformation already chemical in blood that can elicit nitric oxide that will produce NO intrinsically. So these are the two ways that now is experimentation of the stent utilization of NO as an endothelial mimicry. And this is a diagram of that. Produces NO transformation already. There you have a chemical in blood that can elicit stent that you see will produce NO has so these are the potential delivery of NO and also utilization of the contact utilization which is denudated here as donors endothelial mimicry. And this is in that area. The NO will be delivered here, and then NO will have all the chemical functions of endothelial cells, namely action upon inflammatory cells, or has so these are the action upon platelets, action upon vascular contact utilization, and this is a beautiful picture of that in which we have delivered the stent, the NO will be delivered, and then NO will have the endothelium in that area, which is action thrombosis, inflammation, and immunological response. Action upon that area also we will have the capacity to deliver in that area. And this is in that area where the well decreases the possibility of delivering all the factors that will be delivered. And so in that area, in a cell area, in a wall, this is affected, and also inflammation, NO, and immunological response, proliferation and migration for the capacity to deliver small cells. And this is decreasing in that area well is decreases. That's a possibility of endothelial mimicry in this case. And this is an example of this is forced and also inflammation, NO, which this is a biometric stenting, which is 24-hour blood presentation, you can see the neonicotinoid hyperplasia, and here is the extent with donors mimicry the 28 and 90 days later. There is almost no inflammatory response. This technology has not arrived locally because there are several challenges of nitric oxide manipulation. 24-hour implantation, short half-life, and all those effects that can sometimes sensory, and so there are current challenges of nitric oxide polymers, but I think that will be overcome, and we will have the opportunity to utilize implantable devices in a way with 1, 2, or 3 biomolecules that will produce the called endothelial mimicry and increases the mobility of our nitric oxide. For that reason, we require a multidisciplinary team, and also will require imagination. This is a very famous picture from Blade Rene, which looking at an egg, he sees the future that this will transform into a bird. Well, biomolecular science is not so easy, but for that really we require a interdisciplinary team of clinicians and biomolecular scientists with imagination to produce a different methodology to protect the vascular ecosystem. Thank you very much.
Muchas gracias, Fernando. Realmente, como siempre, espectacular. Hacemos la presentación en tu lista hacia lo que se necesita, esa lista hacia el futuro. Tenemos un par de preguntas de la audiencia y las vamos a hacer en privada para que la gente ingrese. Así que te agradezco de corazón que hayas estado esta mañana con nosotros.
Toca presentar también un amigo.
Privada para que la gente
Está el doctor Iván de la familia. Así que bueno, creo que ya la podemos arrancar con la charla.
Hi, my name is Ivan Lilik from Manari Medical Institute and Clinical Familia, and today I will be sharing our experience with ophthalmic artery angioplasty for age-related macular degeneration. Age-related macular degeneration is the leading cause of irreversible blindness among the elderly in the developed world. This disease affects more people than cataracts and glaucoma combined. Part of the retina that is important for reading color vision becomes our experience with ophthalmic artery symptoms are gradual loss of ability to see objects clearly, distorted vision, gradual loss of color vision, and dryness of the center of vision, as you may see among the elderly in the developed world. This is how people a person who suffers from glaucoma actually sees. Compromised ocular retina, uveitis, and vascular discoloration contribute to retinal damage and vision loss. Symptoms are the earliest sign of AMD is characterized by lipid and protein-rich extracellular deposits called drusen deposits between the retinal pigment epithelium and Bruch's membrane in the central macula. Currently, there are no available treatments for non-exudative AMD. That's why Professor Rosenfeld, who had developed the treatment for wet AMD, and the group from the Martinez Center for Biomedical Imaging from Harvard performed an analysis on a 7 Tesla MRI in patients with non-exudative AMD. And from Professor Rosenfeld group, we developed a protocol, and all patients gave their written informed consent for habeas data. By the ethics committee approval, impairment related to retinal maculopathy. As a secondary endpoint, we analyzed visual impairment related to maculopathy.
Conectado al doctor Pablo Graf. Bueno, como cualquier segmento de innovación en un congreso de neurocirugía, no podía faltar el segmento de neurocirugía funcional. El doctor Pablo Graf es neurocirujano, miembro del Colegio Argentino de Neurocirujanos y la Asociación Argentina de Neurocirugía, expresidente de la Asociación Argentina para el Estudio del Dolor, miembro del Comité Ejecutivo de la Sociedad Argentina de Neuromodulación, y nos va a estar hablando un poco sobre técnicas de estimulación cerebral profunda para enfermedades neurodegenerativas. Adelante, Pablo, por favor.
Buenas tardes a todos, mi nombre es Pablo Graf, yo soy médico neurocirujano con orientación en neuromodulación. Agradezco al Comité Organizador y Científico de SIMI 2020 por la invitación y en esta oportunidad vamos a hablar del nuevo paradigma para estimulación cerebral profunda de características endovasculares. Antes de hablar de stent throat y de neuromodulación endovascular, vamos a dar los conceptos básicos que debemos tener en cuenta a la hora de pensar en neuromodulación para un paciente con enfermedades neurológicas crónicas. La neuromodulación es un concepto de aparición relativamente reciente que intenta concebir las modificaciones en la actividad del sistema nervioso por influencia sobre sistemas endógenos excitatorios y o inhibitorios mediante estímulos de diversos orígenes eléctricos y o químicos generados artificialmente y voluntariamente a tal fin. Clásicamente, la neuromodulación la podemos dividir en dos grandes grupos, el grupo de infusión y el grupo de estimulación. El grupo de infusión con diferentes técnicas, epidural, subaracnoidea, como la llamamos comúnmente intratecal, e intraventricular. Y el grupo de estimulación eléctrica, generada por estos subgrupos o diferentes ramas que son la estimulación periférica, la estimulación medular, la estimulación cortical y la estimulación cerebral profunda. La primera cirugía de Parkinson con estimulación cerebral profunda en el mundo fue realizada en Francia en el año 1990 por el profesor doctor Benavid en un paciente con temblor que ya no tenía respuesta satisfactoria a fármacos para control de los movimientos anormales. La primera cirugía de Parkinson que tuve la suerte de participar fue realizada en Argentina en el año 2000. Ya en el mundo tenemos más de 130.000 pacientes tratados con estimulación cerebral profunda aproximadamente. Este artículo lo traigo a pie porque resume cómo la estimulación cerebral profunda a través del tiempo ha impactado en las publicaciones. Eso quiere decir que es una práctica que se inició en la década del 90 con el primer artículo del doctor Benavid y vean cómo ya en el año 2000 empieza a tener una repercusión exponencial en la publicación de artículos. Para hablar de estimulación cerebral profunda y neuromodulación, tenemos que saber que esta técnica por lo general tiene 4 pasos. El primer paso es la colocación del marco de estereotaxia. Este marco de estereotaxia que nos será de brújula y de estructura fundamental para poder neuronavegar el cerebro. Luego de la colocación del marco, realizaremos adquisición de imágenes de resonancia de alta resolución y permitirán estas resonancias de características estereotácticas, luego realizar la planificación del target que hemos elegido para poder realizar la estimulación cerebral profunda en el target seleccionado. En esta foto vemos como un electrodo ya colocado en el paciente y previo a la fijación definitiva, realizamos macroestimulación intraoperatoria con control neurofisiológico para corroborar que la planificación estereotáctica anatómica tenga un correlato neurofisiológico satisfactorio. Una vez el control neurofisiológico y el neuroanatómico es el adecuado, colocamos el electrodo de forma definitiva y hacemos un control radiológico intraoperatorio. Existen en la actualidad múltiples targets para el control de los movimientos anormales, pero los blancos mayormente elegidos son 3. El núcleo ventrointermedio del tálamo, el núcleo subtalámico y el globo pálido. Cada núcleo utilizado para mejorar diferentes sintomatologías de pacientes con movimientos anormales. En este caso, el núcleo intermedio del tálamo será utilizado mayormente para el temblor. El globo pálido interno será utilizado para los pacientes que tienen disquinesia y rigidez y aquinesia en Parkinson, y para otro tipo de patología llamada distonía. Y el núcleo subtalámico, este núcleo que es elegido como target fundamental por el doctor Benavid, es utilizado para los pacientes que tienen temblor, rigidez, bradicinesia y en menor medida para los pacientes con sintomatología axial. Ahora bien, vemos cómo del año 90 al 2015 el crecimiento exponencial de los artículos ha sido significativo. Pero este crecimiento de artículos no han sido relacionados a enfermedad de Parkinson, sino que están relacionados, y vemos en este gráfico, al aumento de técnicas de neuromodulación relacionadas a estimulación cerebral profunda en patología psiquiátrica. He seleccionado un grupo de artículos para mostrar las diferentes targets que utilizamos en estimulación cerebral profunda para trastornos del comportamiento y para otros trastornos de enfermedades crónicas como la epilepsia en este caso, que utilizamos el núcleo centromediano y anterior del tálamo, podemos utilizar el núcleo subtalámico, áreas del hipocampo o áreas del cerebelo para aquellos pacientes de epilepsia que son resistentes a fármacos. En las demencias podemos también utilizar la estimulación del área del fornix, y lo vemos acá de forma bilateral, o también utilizar los núcleos basales de Maynard. En aquellos pacientes con trastornos de la alimentación, y en este caso en obesidad, podemos utilizar el hipotálamo lateral o el ventromedial, y en otros casos han utilizado el núcleo accumbens. En otros trastornos de la alimentación relacionados con anorexia, se utilizan también núcleos como el accumbens o áreas definidas del cíngulo. Podemos también utilizarla en adicciones, adicciones que son aquellos pacientes que ya han tenido tratamientos de neurorehabilitación y farmacológicos, y siendo estos deficientes, y llegamos a la utilización de la estimulación cerebral profunda para ver si podemos a este tipo de pacientes mejorar calidad de vida. Y en este caso, la utilización del núcleo accumbens. Vemos el núcleo accumbens utilizado para trastornos relacionados con el alcohol, con la nicotina, con la heroína y con la cocaína. El cerebelo, para aquellos pacientes, la estimulación del cerebelo, para aquellos pacientes a la rehabilitación post-stroke, ya se han realizado estudios de laboratorio y ahora ya estamos en fase clínica con algunos resultados satisfactorios y promisorios. La estimulación de áreas como la formación reticulada y el núcleo central y núcleo centromediano para aquellos pacientes con trastornos de conciencia y cognitivas por injurias postraumáticas del cerebro. Otros casos donde utilizamos, y estos son casos bastante severos, que nosotros en castellano lo denominamos dolor facial atípico, son aquellos pacientes que tienen trastornos de dolor neuropático facial difíciles de tratar, que han pasado por tratamientos percutáneos convencionales, como bloqueos del ganglio fenopalatino, como termolesión por radiofrecuencia del ganglio de Gasser o algunas de sus ramas, y que los tratamientos no han sido satisfactorios y han generado mayor dolor, y son en estos casos donde podemos utilizar la estimulación del núcleo ventroposterior o de la sustancia gris periacueductal para mejorar la sintomatología de los pacientes. En resumen, hemos hablado de estimulación cerebral profunda en dos áreas diferentes. Los ganglios basales para el control de los movimientos y la estimulación de diferentes áreas del sistema límbico para el control de los trastornos de personalidad y trastornos psiquiátricos. Y ahora van a entender por qué he dividido primero estos dos grupos para luego entrar en la neuromodulación endovascular. Les presento el stent probe, un electrodo de estimulación de neuromodulación que tiene capacidad de registro, o sea, de tomar información del cerebro y a su vez capacidad de generar estímulo en diferentes áreas del cerebro. Este es un trabajo presentado por el doctor Lozano y su equipo. El doctor Lozano junto al doctor Benavid, a los que hacemos neuromodulación y estimulación cerebral profunda, son los padres de la neuromodulación, son los líderes y los que tienen los equipos más consolidados a nivel mundial en relación a investigación y tratamiento clínico. Este trabajo se lo recomiendo para que lo lean. Está de libre acceso en PubMed y nos habla de esta relación de áreas vasculares con estructuras cerebrales a estimular. Y podemos como dividir en dos grandes grupos. El doctor Lozano y su equipo generó un software que permitió generar lo que se llama BTA, modelo de volúmenes de tejido activado durante estimulación cerebral profunda, endovascular, en este caso arterial, y que nos daría un marco teórico para la estimulación de ganglios basales. Por ende, estimulación cerebral profunda endovascular arterial tendría mayor relación con estimulación de ganglios basales. Y el modelado del volumen de tejido activado durante la estimulación cerebral profunda endovascular venosa tendría un marco teórico para la estimulación cortical y del sistema límbico, ya viendo en la foto estas estructuras venosas como están más cercanas a tanto a las áreas corticales como al sistema límbico que hemos detallado anteriormente. Otro trabajo donde se han tomado el estudio de las arterias y venas y sistemas venosos y de senos que están relacionados con estructuras. Vean acá la localización de target y los sistemas vasculares en cuestión. Y solamente para dar un ejemplo, vemos que, por ejemplo, la arteria basilar estaría relacionada con toda la estructura anterior del tronco Para nosotros los que hacemos neuromodulación y estimulación cerebral profunda, estaría en relación con el área mesencefálica, y colocar probablemente un stent throat en la arteria basilar permitiría recabar información y generar un estímulo en diferentes áreas para, por ejemplo, reducir los trastornos de los movimientos anormales. Y un ejemplo para tener en cuenta, los senos cavernosos y petrosos podrían ser utilizados para la estimulación de estructuras mesiales temporales.
We're building something we think is going to be transformative. Technology capable of streaming direct thought for people who through injury or disease have lost the capacity to move or speak. Brain-computer interfaces are a technology that record from a particular area of the brain called the motor cortex.
It's a progressive disease that will eventually cause me to lose my voice and the use of my limbs. But I've embarked on a trial using a stent throat device.
The promise and the hope of this technology is to regain independence for people who have lost their physical independence. What we're doing differently is using the blood vessels as the natural highway into the brain and lacing the inside of the blood vessels with electrodes or sensors that can record activity from the brain. Those signals travel through a lead that exits out the body through telemetry unit that goes into a computer, and those signals can be interpreted by the computer into different types of actions or commands. When the system's connected, we'll be able to see the neural signal flowing through, and we'll spend some time studying those signals while the participant performs specific movements or the participant thinks about performing those movements. We can translate these signals into switches or clicks. If a patient really wants to use the computer, for example, we can offer them a mouse click, and they can start using the mouse as they would have before they were paralyzed. That platform then is like a Bluetooth out of your brain to control a computer or a device where there is no need for a keyboard or a mouse. This is a truly hands-free, brain-controlled platform. So Graham can right now surf the web, write up Word documents, check his emails, do basically everything that a person normally can on a computer, using nothing but his brain and his eyes.
Even now, I find it a bit mind-boggling that he can do that. I sort of got the concept of what they're doing, but how it's working, I still find it a little bit awe-inspiring, actually.
The best way this goes is that someone who's had a severe injury, who has had the best part of their life ripped away from them in terms of independence, gets control back in a way that lets them be their best person. We've done the first step, and it's really exciting to think about where it's going to go next.
Bueno, el video es más que expresa todo este trabajo que generó tanto investigadores de Estados Unidos como de Australia para llevar a cabo la estimulación endovascular y esta nueva figura en neuromodulación. Estos pacientes, el primero fue intervenido en septiembre de 2019 en el hospital de Melbourne, en Victoria, Australia, y el segundo paciente fue intervenido en los primeros meses de 2020. Vemos acá unas tomografías en corte axial, coronaria y sagital. En esta imagen vemos un control pre y post procedimiento. En la figura A vemos el seno longitudinal superior en vista sagital, axial y coronal. Y en la figura B vemos el control a 3 y 12 meses del mismo paciente. Este es el paciente número 1. y vemos la colocación del stent throat dentro del seno longitudinal superior en el tercio medio. Acá podemos observar en la figura D un corregistro de una angiografía de sustracción con una resonancia magnética preoperatoria, y vemos el área a estimular, que en este caso es el gyrus prefrontal, que fue utilizado para poder generar una interfase entre el paciente y la computadora y poder el paciente así darle estímulos a la computadora y poder generar actividades y mejorar o empezar a tener independencia funcional, que es lo que buscamos y que es lo que se busca en estos pacientes con esclerosis lateral amiotrófica. Como discusión y para ir culminando la charla, la naturaleza invasiva de la estimulación cerebral profunda que debe atravesar el parénquima tanto para la colocación de electrodos definitivos como para las múltiples trayectorias generadas para el microregistro, la potencial fuga de líquidos cefalorraquídeo y el cambio que puede estar asociado a fenómenos como alteración del target, definido así, como también las complicaciones menores, pero en un porcentaje menor de un 1%, que pueden llegar a ser las hemorragias intraprocedimientos del neumoencéfalo masivo, nos permiten pensar que el stent throat nos daría más beneficio que la estimulación cerebral profunda. No, digo pensar porque todavía tenemos solamente 2 casos en investigación clínica, pero estos serían los pros y los contras de un procedimiento de estimulación cerebral profunda versus un tratamiento de neuromodulación endovascular. Del lado del stent throat, establecer la seguridad de los stents con respecto al despliegue, lesión vascular, prevención de trombosis e hiperplasia neointimal, ver qué efectos tienen qué efectos de la estimulación endovascular sobre la integridad del vaso, finalmente la seguridad y durabilidad a largo plazo de los stents en neuromodulación, y algunas discusiones están relacionadas si estos pacientes deben tener tratamiento de anticoagulación interplaquetario a largo plazo por el efecto que potencialmente podrían generar trombosis los stents en neuromodulación. Como conclusiones finales, la selección de pacientes, condiciones u objetivos quirúrgicos deben ser identificados. Quizás la neuromodulación endovascular pueda albergar ventajas únicas sobre las terapias ya existentes. La estimulación endovascular ofrece oportunidades novedosas y emocionantes, resultando tal vez a futuro una técnica complementaria más en el arsenal de la neuromodulación. Y si esta nueva técnica se suma a la neuromodulación, será una terapia eficaz, reversible y de baja morbilidad en aquellos pacientes meticulosamente seleccionados. Y he colocado esta flecha verde como flecha de esperanza para que la neuromodulación endovascular a futuro y en poco tiempo se sume a las terapias de neuromodulación ya existentes. Bueno, para finalizar, le agradezco al comité organizador y al comité científico de SIMI 2020 por darme este espacio a charlas sobre neuromodulación, y especialmente agradecerle al doctor Lilik y su equipo por estos encuentros SIMI que son tan importantes para los profesionales de la salud y de la neurocirugía. Les deseo un buen fin de año y un inicio 2021 mejor que este 2022. Hasta luego, muchas gracias.
Bueno, muchísimas gracias, Pablo. Realmente sí, estamos seguros que el 2021 va a ser mejor que el 2020, perdón. Realmente vimos un nuevo target para la patología endovascular, digamos, un nuevo target no solamente para la charla del doctor Graf, sino para la estimulación profunda, sino también, como vimos, para el tratamiento de enfermedades no vasculares como la hidrocefalia. Revisamos la innovación en robótica, revisamos la inteligencia artificial, revisamos la bioingeniería, Realmente fue una mañana, creo que extremadamente productiva, larga, pero extremadamente productiva. Damos por finalizado el bloque de innovación y los esperamos nada más que en media hora para el comienzo del bloque isquémico. Isquemia, ¿qué hay de nuevo en la isquemia cerebral en el 2020? que vamos a revisar en el transcurso de la tarde de hoy es la transferencia directa. ¿Podemos obviar el paso por la resonancia o por la tomografía computada? ¿Podemos obtener imágenes de perfusión en la angiografía cerebral? Yo creo que sí podemos, y este es el paso hacia el que nos estamos dirigiendo. La semana esta hicimos un caso con transferencia directa en el que tardamos desde la puerta de entrada del paciente hasta la punción 11 minutos. Así que creo que eso es algo sumamente importante para desarrollar y para trabajar. Estamos, Esteban, aquí en presencia de una mesa distinguida que me encantaría que la presentaras antes de presentar a nuestro primer invitado extranjero, que es el doctor Henkes, que creo que lo tenemos en puerta. Esteban.
Hola, gracias doctor. Buenas tardes, buenas noches a todos. Vamos a empezar con este panel de expertos, en este caso de derecha a izquierda. Primero las mujeres desde el servicio, la cumbre del servicio de neurología de Clínica Sagrada Familia, la doctora Selina Ciardi, neuróloga vascular. A mi derecha el doctor José Francisco Pepe Vila, neurólogo vascular de muchísima experiencia. Juan Sirio, otro gran neurólogo vascular, todos lo conocen. Y allá en el fondo Javier Lundquist, que es neurólogo intervencionista. Así que si ya está el doctor Henkes, vamos a pasar.
Yeah, ¿sí? Gracias. I think Hans is there, so we will go straight forward. You know, we are treating, I'm sure also it's your experience, Hans, more and more ICAT in the setting of the acute stroke. So we will be delighted to have your knowledge about it. So please, go ahead and show us your ICAT and stroke experience, please. El doctor Henkes está en la clínica de Stuttgart, en Alemania.
Again, I have to thank Professor Lillich for the invitation to present during this SIMI meeting 2020 and to talk about the intracranial atherosclerotic disease in the context of endovascular stroke treatment. These are my disclosures. If you talk about the frequency of intracranial atherosclerosis and atherosclerotic stenosis in acute ischemic stroke, we have to consider some numbers. So we know that about 10% of all ischemic strokes are due to or at least associated with intracranial stenosis. And on the other hand, the risk of an ischemic stroke in a patient with a symptomatic intracranial stenosis above 50% during the following years after diagnosis is between 12 and 14. Significant numbers. That's not a rare phenomenon. Intracranial atherosclerosis is a major issue during these treatments. When do we can find angiographic clues, of course. These are, first of all, extracranial atherosclerosis, and second, extensive leptomeningeal collaterals. This is a patient. He came with this symptomatic choroidal T occlusion on the right side, and it was eventually found to be due to a stenosis which
Hello? Hold on, Billy. Hold on. Billy, what happened? Okay. Okay. Yeah, that's a possibility. But with the eye, one thing you got to worry about, one of the only emergencies in the eye is, of course, getting an accident and puncturing your eye. But another one is what's called a detached retina. I think Kurt had it, and I had it too. What happens is one eye all of a sudden, like a curtain goes over it. Not quite like what you said. Most people come in and say, hey, I feel like someone's pulling a curtain over my eye. But the fact that you're on anticoagulants, you know, you didn't have a blood clot because you're on the anticoagulants. So there may be maybe a little bit of bleeding going on there or something. So anyways, you just need to don't fuck around with the eye. Make sure it's okay and go from there. The pulmonary emboli? Emboli? Oh, okay. Yeah. So the ophthalmologist saw you? Yeah, he saw me right away. Oh, you're kidding. You walked into his office? I was close to Jen's work, so I just pulled in the car and I called her, and then she took me over to the doctor. They called me. They said, "Well, he'll see you." You know, now I explained what had happened. You know, and he saw me, and then they dilated my eyes.
Try not to use balloon implantation for the A1 segment because there's always a risk of damaging the connection between the A1 segment and the distal internal carotid artery. We catheterize the target vessel with a portal wire or a synchro wire, exchange length 300 centimeters. And we sometimes use an Excelsior SL10 to stabilize the wire while we catheterize the target vessel. The first PTA we do with a small caliber or small diameter balloon. For the MCA and the posterior cerebral artery, we use typically a 1.5 millimeter by 10 millimeter or 15 millimeter pita, followed, and for the basilar artery, 2.5 by 15. And we use very slow inflation, let's say 1-2 minutes, very slow, very careful inflation, manometer controlled, not higher than 4 to 5 atmospheres. The second PTA, we use a larger balloon. We go with 0.25 or 0.5 millimeter increments to the point where we think we have reached something like 70 or 80% of the original diameter of the artery. This is a typical case. The patient presented with an acute occlusion of the right M1 segment. The first it was a known stenosis. The first PTA is done with a 1.5 millimeter balloon with 4 atmospheres. You see there's residual stenosis. So there's too much residual stenosis. It's not good to leave it like that. So we come back with a second balloon. Now we use 2 millimeter, again, 4 atmospheres. And we see here sufficient recanalization of the artery, no dissection, no elastic recoiling. And that's just fine. There's no need to do anything else on the patient at this little DWI spots, but no major infarct. What are the pros and cons of balloon angioplasty without a stent? It's technically relatively easy. It is there are infrequent issues of balloon passage, so we use typically P-type balloon, which has a very low crossing profile. There are several coronary balloons also available. The catheter kickback is very limited, so even if your guide catheter is not very stable, it may work. It's a very inexpensive procedure, and there is no long-term dual antiplatelet therapy required, 6 weeks or something like that. And follow-up examinations can be done with CTA or MRI. There's no need to go for DSA follow-up. And if you have to do a thrombectomy after the procedure, you can usually do it after balloon angioplasty. The insufficient, it can be insufficient in the case of vessel dissection. So if the underlying lesion is dissection, or if you observe elastic recoiling after balloon angioplasty, you have to go further and use a stent. And the frequency
The drug stance, which is the one which is used mostly within with our cardiovascular colleagues. The drug-eluting stent which is the one which is used mostly within with our cardiovascular colleagues. The drug-eluting stent drug-eluting stents, which is the one which is used mostly within with our cardiovascular colleagues. The drug-eluting stent act only in the intimate proliferation, but doesn't the drug-eluting stents, which is
So I took him directly for mechanical thrombectomy without lysis because of this hyperperfusion. And if you see here, you realize immediately where there is the occlusion, where we tried with one device, it did not work. So we took a combination, Tiger here, Solitaire there, to reopen this vessel. And you see here the before and after. Now everything is reopened with a patient that immediately recovered and was sent back home 2 days later. This is the early CT, and this is a CT of 24 hours. So part of those patients, 1/3 of the group had isolated distal occlusions. 2/3 of the group had remaining distal clots after regular thrombectomy. And this is a very frequent situation. You go on here to reopen the MCA. And mostly, but is there something missing? And well, difficult to see on those pictures. I must say it's not easy, but if you have a local anesthesia, of course you will miss it. But if you have the patient on a general anesthesia, you will realize that this is occluded here. And this is something which was already existing before we started treatment. And if you play with the windows to look at the parenchymogram, you see that a lot is missing there. And to go there with a small device and taking this clot out is not a big deal. Of course, under the condition that you have small devices, that you have a patient which is not moving, and that you can reopen everything. And the third group are patients where during elective procedures, we ourselves create a complication. When I treated this aneurysm here, this is before and after, and you see that something is missing here. So up there, and here I put again a tiger to take out, despite the fact that patient is on dual antiaggregation, and it was reopened. And fine, before and after, this is a CT showing that, did we create something? You have very often those kind of pictures, but there was no hematoma. Or this patient here with an AVM that we occluded, but still created some little material here, some little onyx, and this onyx may induce some further occlusion. So I prefer to take it out and to take here the device and to take this stuff away, because you don't know at this stage whether the vessel is going to remain open or to occlude. Okay. So out of those patients, half of them received intravenous thrombolysis before me, number of passes between 1 and 2, and most of the time it worked. I cannot pretend that all the time you can reopen, but in 3/4 of patients we had a good, successful recanalization. We did not have any difference whether patients received venous lysis or not. But of course, there are some complications, which is the reason not to do it, potentially. And if you look at the cold beam CT, the number of subarachnoid contrast media extravasation is quite frightening. It's 45%, which means every second patient, if you go beyond the Sylvian point, will have a little bit of contrast agent outside the vessels, which means there was some minimal bleeding. We have also some more important complication, SAH due to wire or with spontaneous resolution in 3, temporary coiling or definite occlusion, and 8 patients with symptomatic intracranial hematoma, which you can see here, the differences. Most of patients are like this, where you have a bit of something to be seen on cone beam CT, which is normal next day. This is a patient here considered to have a complication as SAH, which of course is clinically asymptomatic. And I think it's better to have this SAH without stroke than not to have this. And these are the ugly situations where you may have more of bleeding, which may not necessarily be symptomatic, but which definitely is a complication that was created. And here's some examples. A patient here coming with an occluded inferior division branch of the MCA. By the way, you see that there's also an MCA aneurysm. Have to bypass the division branch. We first had to stent here, the ICA, and after proximal M2 retrieval maneuver, this is still remaining. And do you really want to leave it? If you have small adapted material, you can go there and bring, the first pass did not work, but the second pass did it. You see those vessels here, this and this were reopened. And here is the clot, which is being stuck inside the small retriever, a little bit of something on the CT, so which we must describe. However, this is not something relevant. Here, a more important complication where we went into the distal part of the superior division branch of the right MCA, and immediate CT is good, but here we created definitely a significant complication. So we see various results. However, the number of complications hematoma remains quite low. And obviously, the benefit of doing this treatment is not the same than the benefit of opening a large vessel. So it's more risky to go into the smaller vessels, and you have less clinical benefit and also a potential efficiency of venous lysis. But the number of patients that we are treating that do not receive a venous lysis is increasing a lot. So to reduce risk of doing distal thrombectomy, certainly we need to have smaller devices, and miniaturization is the goal to achieve. It cannot work with large things, and aspiration is a great technique for proximal large clots. But if you need to go into small arteries, create a large device inside the small arteries. And of course, for all procedures, and in many countries, a lot of procedures are done without general anesthesia. I think it's not adapted to do this procedure without general anesthesia. So experience of the operator is also something that must be taken into account, and we see that in the team. Less experienced operators have more problems, so it takes a couple of years to feel comfortable to do so. And this is where I will stop. So I still believe it's a very important thing and very important evolution, but we need to be able to prove it in further studies.
I think we lost you. So thank you. Can you hear me?
I'm sorry for this.
No.
Hello?
Yes.
Yeah, sure.
Okay. So this is your last slide.
Absolutely. Yeah.
Okay. Thank you, René. You put things together in a very difficult topic, so we are really happy to see that everybody has the same problems, and we are facing maybe a next frontier. So thank you very much. We will skip the questions for. Please allow me to introduce Adnan, and after Adnan, we will have questions and answers and comment. We have a panel here. We have also joining your friend from Brazil, from Vitoria, Modenesi Freitas is with us virtually, so will join us on the discussion right after. But now it's my pleasure to introduce Adnan Siddiqui from Buffalo. I hope it's not too cold there, Adnan. And thank you for being with us in SIMI 2020. We are really exciting. As everybody knows, Adnan is a professor and is a director of neurosurgery at Buffalo. They are working in a fantastic place. I tell you, the Jacob Institute. They have it's a privilege to work there. And I was visiting there with Professor Hopkins. So great place, great experience, great team. We are looking forward to learn from you about the tandem and strokes setting, Adnan. Welcome, and thank you to be with us.
Thank you very much, Pedro. It's always my pleasure, and I am very much missing my steak and Malbec this year, but I hope that we'll be able to resume our in-person meetings in the not so distant future. And René, as always, a masterful talk. I always learn a few things from you every single time I listen to you. So my talk is on tandem lesions. So the lesions, here are my disclosures. So when you look at the data in terms of historical data for internal carotid artery occlusion, it was clear very early on, this is the meta-analysis done almost 8-9 years ago, that there was a significantly higher rate of favorable outcome when these occlusions were recanalized. Unfortunately, in the North American trials, these patients were excluded from trials, which was a major disservice, because when you look at the data from Mr. Clean, it is clear that one of the greatest amounts of benefit that could be imparted on these patients was when there was an intracranial ICA or extracranial ICA with M1 occlusion, and that was almost 1/4 of patients. So this is a large population of patients that are potentially amenable to endovascular therapy, almost 145 out of 500 patients in Mr. Clean were tandem occlusions. And when you look at the benefit, look at the amazing rate of benefit for thrombectomy with tandem occlusions. This is from the ESCAPE trial, which was the Canadian run trial, compared to all other cohorts. This is one of the greatest areas where we can actually impart benefit to patients. And I think this is a very sizable sort of value. Revascat, similarly, when you look at the benefit, it outpaced other areas of benefit when you had a tandem lesion. So what do? Well, stent retriever was the first one, and this is from Francis Sturgeman's group meta-analysis. They looked at 11 studies, 237 patients. They got in about an 80% recanalization rate, 44% favorable outcomes. Here's another series with about 83% recanalization, 46% good outcomes, with reasonable mortality and symptomatic hemorrhage rate. So there's no question that thrombectomy has favorable outcomes in the acute setting. And should we use TP in this cohort? The problem is what to do about stenting, what to do about loading these patients in dual antiplatelet therapy, what to do about intravenous thrombolysis. Is the addition of TPA to thrombolysis problematic from a symptomatic hemorrhage rate? And then when do you do this cervical stenting? Do you do it pre-thrombectomy? Do you do it post-thrombectomy? And then what kind of stent do you use, closed cell or open cell? So I can share with you what we do, and I'll share some cases with you as well from that standpoint, is we rely on the original CT imaging that is done on all patients. We have a very standard protocol for all cases. There's a plain head CT done. Intravenous TPA, if it needs to be given, is given on the CT scanner. And then immediately, if there's a hemorrhagic case, there's no TPA, and you do a CTA of the head. And if it's non-hemorrhagic case, if they're eligible for TPA, they get TPA, and then we do a CTA of the arch to vertex and CT perfusion at the same time. So when we do CT perfusion, we generate a 4D CT angiogram out of that multi-phase CTA data, and that way we can tell if this is a tandem occlusion or it's an ICA terminus occlusion, because if you just do a non-time resolved CTA, you will not get contrast going up the cervical ICA in a delayed fashion, and you will mistake ICA terminus thrombus with a cervical occlusion. And so it's important to have that 4D CTA available. And the moment we establish that there is indeed a cervical occlusion, we load the patient up with aspirin and ticagrelor in the emergency room, even prior to rolling him up. If the patient's intubated, as has been the case for the last year because of COVID protocols, we'll put an NG and give the thing. Otherwise, we'll give this orally if needed. And TPA is unchanged. Now, what do you do first? The integrograde option has the value that you're addressing the primary causative lesion, because when you have a tandem occlusion, it's a ruptured plaque, and the ruptured plaque is the source of the embolus that has gone to the brain. And by doing that, you're reducing the risk of distal emboli that may continue to occur as you're performing the intracranial procedure, similar to what you would do for a symptomatic carotid, where you have to be really mindful of all the manipulations you're making in the neck, because all those manipulations are resulting in progression of embolism to the brain. And you're also improving collateral circulation immediately by restoring proximal flow. The value of the retrograde first is that you might have a shorter angiographic time to revascularize the intracranial occlusive lesion, and you're dealing with the symptomatic lesion first. So there are pros and cons of both approaches. And so we try to look at, in our own institution, as well as a few other partners' institutions, to see what was the best way, what should be done first. And what we found was that there was no real difference we could establish, primarily because I think our numbers were somewhat low. And so what we have really migrated, and I personally have migrated, is a 9 French femoral sheath, which recently, because of a new balloon guide called Walrus, I'm able to now do this through an 8 French balloon guide. And then I use a balloon guide catheter. I used to use the MoMA device before we had good cervical devices, and then cross the lesion under flow arrest. If I'm unable to cross the lesion with the 014 wire, then I'll switch to more hefty 5 French 035 systems as well, and then perform angioplasty and stenting under flow arrest, followed by aggressive aspiration. I rapidly typically do intravascular ultrasound if there's intraluminal thrombus before I restore anterograde flow, and then perform the intracranial procedure as you normally would. The advantage with balloon guides being you can deflate the balloon and then go across the stent and displace it a little bit farther up. So here's some quick cases to sort of make that point. This is a tandem occlusion. You can see there's a very, very high grade stenosis along with delayed filling distally. So we are bringing our MoMA guide in this particular instance. We have extracranial access in the external carotid artery, and there we do an intracranial baseline run, and you can see there's some reflux, probably a tandem occlusion. The ECA balloon is opened first, followed by ICA common balloon, which is down here in your screen. And then we go up with stenting. I prefer to use plasty first now rather than stent first and plasty second, because I don't like the cheese grating that can occur because of inflating a balloon inside the stent. Obviously that, and now once you have done that, you can now deflate the balloon. With the MoMA system, the downside was that this external balloon becomes problematic. And so in this case, we are just going up with a 6 French long sheath through the structure. By using a simple balloon guide, we have eliminated that problem by not having to use 2 systems. And there you can see there's a terminus occlusion. And once we have identified the terminus occlusion, we can now go ahead and in this particular case, I'm using an aspiration system. And because the aspiration catheter was stuck on the ophthalmic, cross the lesion with a microcatheter and in standard fashion, go ahead and establish a microcatheter angiogram. There's a solitaire being deployed, being pulled into the stent retriever. It's important when you're using a stent retriever to make sure you don't pull it through the cervical stent because it can get entangled. Here, both of these are being locked in and then we are being pulled with a cervical guide. And once you have pulled this back together, you can establish flow with excellent revascularization established, and the patient ends up doing very well because of this, because you have now restored flow. I think this is a simpler way of doing it because you're dealing with, there's a cervical run at the end showing excellent recanalization of the entire circulation at this time. So this is another case which basically shows similarly. Let's see, I want to make sure I'm not missing. There we go. Yep, this is the one I just showed. So here is an ICA, another case with occlusion, slightly different technology here. This is my partner showing a case. This is now a 6 French guide, which is being brought. This is not a balloon guide. Initially, they do a run, and now you have a tandem occlusion, what to do in this particular instance. And now he switches it over to a balloon guide. This is not a MoMA, so there's advantage in there. And now he's treating this almost like a traditional carotid stenting, where he crosses the microcatheter system with a distal filter. There he has crossed it with a microcatheter, getting distal access. He had to use an MPA catheter to really direct the wire to go to the right place. Once he has that, he then exchanges it out for a distal filter system, such as the Spider, and then with the Spider filter establishing distal flow, then he deploys a distal filter, and with the distal filter in place, he's deploying the filter. You'll see in a second. Once the filter is deployed, then he does standard angioplasty followed by balloon, by stenting. And that is done first. He's going to follow that. You can see there's restoration of flow. There's some spasm in many of these cases. You can give verapamil as well. And that's why I like to do plasty first. Now you deflate the balloon, you have your wire, and now you can advance your balloon guide right through your previously placed stent. And that allows you to not have to exchange your system out like I used to have to. There you can see the balloon is up and it's being delivered right through the previously placed stent. Now you can do an intracranial. There is your M1 thrombectomy. You can appreciate that. And now that is being brought up to the lesion. Use a J wire to make sure we stay in the primary vessel. We are getting stuck at the level of the lesion. You continue to push till you have crossed it. Your aspiration catheter is right across, and now you can deliver your microcatheter run. You can do your stent retrieval, and this allows the very straightforward. This is the Trevo device being used here, and once you have it in place, again, sandwich technique with the aspiration catheter, and with that in place, you can now pull the whole system back. And again, with aggressive aspiration, pulling the back together, with balloon guide aspiration as well in place. And this is the immediate post-procedure run showing excellent recanalization established in this particular patient. And so this is another sort of case, a 60-year-old who presents with acute right side hemorrhage, last known well 6 hours. So this is not a TPA case. There is an M1 occlusion. The ICA looks like she has M1 occlusion. You can see there's distal occlusion as well. And when we do a cervical angiogram, we appreciate that there is good preservation. There's an old infarct already established. And here's a perfusion scan showing the entire MCA territory with a small core already established. And there is an intraluminal thrombus sitting right there in the cervical carotid. So what do? You could just say, hey, we can just go across this. My feeling is there you can see the glob of thrombus that's sitting in there. This is the kind of situation where with flow arrest, you are now able to place the distal filter if you wanted to. In many cases, I don't even bother with a filter. I think we have flow arrest with the balloon. We go ahead, trap the clot with the stent in place. And the advantage, again, I'm sure Renee is cringing looking at the awake patient moving around. I think with expertise, you're able to actually discern how to sort of deal with this fairly well and get the job done. And the stent is being deployed, making sure that we have we're just pulling back, deflating the balloon slightly to make sure that we can express the stent. The thrombus has already been trapped by this time. There you can see the stent is being deployed fully. And once the stent is fully deployed, then you go ahead and you look at the intracranial lesion, and now you can just go right across. There's the distal filter being pulled back, and once the distal filter is out, we again don't capture fully the filter because there could be thrombus sitting in there. Now we have gone through the stent. There is my balloon guide in there. There's my aspiration. Here is the microcatheter. And now it's a standard stroke case, nothing fancy. There you do confirm the microcatheter. There's your stent retriever. And now you have additional sort of occlusion that is still there. And you pull the stent back. And this is your final run after establishing flow. Now I have to say, I'm extremely impressed with the distal cases, such as the one that might be out here. I don't think I feel comfortable putting a 4 millimeters solitaire, but I think if we had the Tiger Retriever, the Mini Tiger, I think that would make a huge difference to the way we deal with these things. So in conclusion, really, almost 25% endothelial circulation alveoles are associated with cervical ICA. I think revascularization is extremely beneficial in these cases, more so than even standard anterior thrombectomy. particularly what that means in converse is that if you don't reopen them, they are much more likely to be devastated than other lesions. It's unclear which lesion to deal first, but I think of this the same way I think of symptomatic carotid. I believe we stent first and thrombectomy second. I'm not sure if TPA helps or doesn't. I'm ambivalent. I currently do not stop TPA in these cases. I think there's probably a slightly increased risk with the dual antiplatelet therapy, but overall, again, I think the benefit is much greater in these cases. And for this opportunity.
Was a presentation on tandem. So now we are ready for a discussion. We have a distinguished panel here. But before we start the discussion, we will share with you a couple of cases that we have for discussion ready here in Buenos Aires. So I want to make sure that René is also on. René?
Yeah, sure.
Great. Se Maria?
I don't know. René seems to be in a very precarious situation. He's at a very high elevation. Yeah. And from the angle, I'm a little nervous he might fall backwards, you know. It's a long distance to go down there.
Okay. We expect have you, René, you, Se Maria, everybody in Buenos Aires for next year. So I just want to make sure Se Maria is on also?
Yes.
Okay, great.
Yes, I'm here.
Okay, so Javier, would you like to show the case? Vamos a mostrar un par de casos para la discusión. El primero va a ser presentado, los dos primeros van a ser presentados por Javier y el otro por mi moderador, el doctor Escribano. Adelante, Javier, por favor.
Ok, hola a todos. Vamos a compartir un par de casos relacionados con las charlas que estuvimos viendo, con la manera de abrir la discusión. El primero es un paciente de 76 años con estos antecedentes, con un antecedente ya de ACV previo, y que ingresó con un stroke de 2 horas de evolución. Al ingreso se hizo RTPA endovenosos y una angiografía donde mostró esta estenosis a nivel de la bifurcación de la cerebral media. La resonancia, teníamos una resonancia donde nos mostraba una lesión frontal, como ven aquí del lado derecho, una mala opacificación de la cerebral media de ese lado. Y entonces en este caso teníamos esta lesión donde vemos una invasión de la placa a nivel de la rama superior de la cerebral media y una placa en M1 previo a esa bifurcación. En este caso, lo estudiamos con resonancia magnética. En ese momento lo habíamos hecho fibrinolítico, como le dije, y en la resonancia, en la secuencia de este T1 de sangre negra, podíamos ver, como ven acá, a nivel tardío, como importante de esto, este realce de contraste en el tiempo tardío de la resonancia, que nos indicaba por ahí una placa frágil, una placa complicada, ¿no? En este caso pedimos ayuda a los cardiólogos, como en muchos casos en esta lesión de estenosis. Aquí el doctor Londero nos dio su opinión sobre qué era lo más recomendable para este caso y nos mostraba estos esquemas, como pueden ver ahí, de kissing balón y kissing stem, y donde nos mostraba también qué no hacer, como por ejemplo no superponer a ambos balones a nivel de una arteria por la sumatoria de los diámetros de los mismos, que nos llevaría a una ruptura de la arteria o una disección. Lo mismo con los stent, tratar de colocar el stent primero en la rama superior, que sería la más compleja, y luego en la rama inferior, tratando de no superponer los mismos. Aquí lo que hacemos es ir con un microcatéter y una microvía, siempre, ya que el microcatéter nos ayudaría a poder pasar a la rama superior y cambiar la curva. Una vez que entramos a la rama necesitamos una curva bien cerrada para entrar, y para seguir necesitamos una no tanto, porque podemos lesionar la arteria. Entonces dejamos el micro, cambiamos la curva y podemos ir distal. Después, como pueden ver, otra cosa a tomar en cuenta son el tamaño de los balones y las marcas de los balones. Tengan en cuenta que muchos de los balones intracerebrales tienen marcas, algunos en el medio, algunos en los extremos, entonces es importante cuando a medida que se va subiendo tratar de tener una buena referencia de dónde a dónde va el balón, justamente para no lograr la superposición y evitar la ruptura de la arteria. Usamos las guías Asahi, que tienen un muy buen torque, nos permiten una relación 1 a 1 casi con la rotación. Y aquí pueden ver la angioplastia con balón arriba. La angioplastia con balón arriba y abajo la colocación primero del stent en la rama superior y luego en la rama inferior, siempre en estas estenosis menores a 3 milímetros preferimos usar stent farmacológicos. Y aquí pueden ver el caso terminado, la imagen en T prácticamente de ambas ramas y la tomografía de control. Podemos ver el control a los 3 meses y a los 9 meses, donde podemos ver, digamos, la misma imagen. Acá tenemos una T invertida que es igual a lo que vemos en la tomografía acá arriba. Muy bien. Pasamos al siguiente caso. El siguiente caso me relaciona a la charla...
Espera, si te parece adecuado, le preguntamos a nuestros invitados aquí y virtuales si estarían de acuerdo, si... Ahí se ven los controles, ¿no? El control de 3 meses y el control de 9 meses.
Y el control de 9 meses, donde podemos ver una leve hiperplasia, pero el paciente evolucionó bien.
Okay, guys, can you hear us well? Do you have the translation in your site?
Yes, we can hear the translation, but the pictures explain the case very well.
Okay.
Self-explaining, great case, fantastic treatment. Then not easy to have the stents just placed, just in contact. It's really a super treatment. Very nice.
Better be lucky than good sometime. No,
it's not luck.
¿Quieren, María?
Pedro, não, parabéns, o caso muito bonito, resultado perfeito, sobretudo para mostrar a eficiência dos stents expandidos por balões. Esse que é o tratamento correto, em minha opinião. A única coisa que para ganhar tempo, é muito raro em la cerebral média, temos um par de casos acá, é muito raro necessitar de fazer uma angioplastia com balão antes de pôr o stent, porque as placas não são muitas calcificações e se pode passar o stent com uma facilidade. Portanto, é muito raro necessitar de uma angioplastia previamente a implante del stent.
Sí, lo que pasa que era tan cerrada que no podíamos pasar si no hacíamos la plastia antes.
Pero, claro, em alguns casos vai ter dificuldade, mas a maioria não temos dificuldade de passar porque o perfil é baixo e é muito... depende do stent, nós utilizamos stent de coronário, sobretudo o stent é o Science, e há uma navegação muito boa e posicionamento muito perfeito dentro da estenose.
Tenemos aquí a 3 distinguidos colegas neurólogos vasculares. El doctor Vila, José Vila, que ustedes conocen, creo que quiere hacer algún comentario, alguna pregunta.
Sí.
Go ahead.
Tenemos un estudio de perfusión inicial.
¿De qué paciente? ¿De este?
En este paciente.
Sí.
Hay que presentarte. Para ver cuál es la fisiopatogenia del mecanismo que produce el déficit clínico.
Una hipoperfusión.
Ahí lo ves.
Perfecto.
Lesión isquémica frontal con...
¿Esto se modificó después del tratamiento?
El paciente evolucionó bien y la perfusión se mejoró, digamos.
¿Mejoró?
Mejoró.
Sí, mejoró la perfusión.
O sea que tuvo un evento agudo en una estenosis crónica y aparentemente casi no oclusiva.
Exactamente, un accidente de placas.
Que ustedes interpretaron como que fue una embolia a partir de la placa.
Exactamente.
Parte sí, parte no.
Igual tenía componente de
con componente hemodinámico,
la
¿no?
perfusión, ¿no? Que son tal vez las estenosis intracraneales más problemáticas y más desafiantes. Porque por más con tratamiento eso no va a mejorar con tratamiento farmacológico.
Estoy de acuerdo.
El punto, y tenía en la angioresonancia de pared que mostraron, tenía imagen de componente hemorrágico intrapared. O sea que...
Reciente.
Exacto.
¿Y el evento anterior fue en el mismo lugar?
En el mismo lugar el paciente venía con tratamiento completo, digamos, para estenosis intracraneales.
Porque fue en el 2015.
2015.
¿Y en ese momento
un par de años después.
tenía la estenosis o no?
No era estudiado por nosotros.
Ok.
Bueno, si te parece, seguimos con el próximo caso. We will go and show the second case, guys.
Ok. El siguiente caso, relacionado con la charla del doctor Chapot, es un caso, lo mostramos a propósito, una complicación en una embolia distal en un paciente relativamente sencillo, si podemos decir, ya que se trata de un paciente relativamente joven, con esta oclusión en el segmento M2. No mostramos a propósito, digamos, todos los datos del paciente y todo eso, porque es una cuestión técnica más que nada. Y vemos que es una arteria, si bien distal, relativamente grande, en M2, y en arterias bastante rectas, donde se decidió, el paciente estaba fuera de ventana para trombectomía, para trombolisis química, y se decidió hacer trombectomía mecánica. Lo que en este caso se usó un solitaire. Y lo que vemos es acá podemos ver el solitaire, las marcas distales en ese lugar y una extravasación de contraste en la inyección inmediatamente después del despliegue del stem. Más que nada mostramos esto porque estamos pasando, y más cuando estamos a nivel distal, en arterias ocluidas, no sabemos qué hay más distal, entonces hay una serie de, para los que recién comienzan, digamos, de protocolos a seguir, como por ejemplo ir muy lento con el microcatéter, porque no sabemos cómo es la anatomía distal a la oclusión, hacer un testeo con mínima presión y mínima cantidad de contraste una vez que estamos en el lugar que queremos que es correcto para ver que no hayamos lastimado, que no estemos contra una pared, y a la hora de hacer el despliegue del dispositivo, hacerlo siempre manteniendo fijo el stent y no empujando y haciendo... retirando el microcatéter solamente, porque podemos hacer un avance y ruptura de la arteria con el stem. Esta es la tomografía postprocedimiento con esa hemorragia. El paciente, si bien no empeoró el ranking, tampoco lo mejoró, digamos, con respecto a la entrada.
¿Te acordás del tamaño del solitaire que usaste?
Se usó un solitaire de 4, me parece, en este caso. Era un M1 grande y en ese momento no teníamos tampoco dispositivos más chicos. Eso es otra cosa a considerar, ¿no?
Yeah. René, this is your domain.
There are many causes for bleeding. First one, wire. So, I mean, for each cause, there are some potential things that may help, but of course this happens and we have this kind of problem too, but to try to reduce it, for instance, to bring in the microcatheter in the distal place, I mean up to the Sylvian, which was here the point of rupture, we put the wire with a J shape. So for instance, a Traxxas wire is a Portal wire. If you push it as a J, you will not perforate, never with a J. Then, once a microcatheter is in place, we make a micro-selective injection to make sure that we're not in a small side branch. Then the other thing is, if you go beyond the distal point, and here the rupture, obviously it's a distal point, then the material must be smaller. So this upper here is the upper limit, and if the solitaire was beyond, and that you pulled the whole MCA down, then it may not be the cortical artery which is damaged, but the small transmedullary arteries that go horizontally at this level, and those maybe these are arteries that have been pulled. So one of those etiologies probably the reason for this, and may explain what is happening.
Okay. Let's say you have already a rupture. You see the rupture. What you should do? And if you see the rupture, you are there.
Okay. Super important. Two things: put the blood pressure down, and second thing is deliver temporarily a coil.
Right.
And usually the bleedings are not as small bleedings, not major bleedings. It's usually a very small thing. So I think you can bring a balloon, but the time to prepare the balloon and to have it in place, usually the bleeding had stopped. So by placing a temporarily coil,
okay, let's see. The bleeding doesn't stop. The bleeding doesn't. After 5 minutes, you still have some leakage there. Are you leaving the coil there? You still waiting with the coil without detaching the coil?
So, very good thing. During placement of one microcatheter and delivery of the coil, then I wait. I bring a second microcatheter very close, because very often the difficulty is to be able to see the bleeding, to be sure that it stops or not. Here it's an important bleeding, but very often it's a small one, and if you make a no-lover angiogram, you don't see it. So the second microcatheter, which is shortly beyond the tip of, before the tip of the first one, will show you if it's enough or not. And then I wait 10 minutes, and again 10, and again 10, up to 1 hour. And I really wait a long time before I will occlude an artery.
Okay. Adnan and Jose Maria, would you do the same thing? Would you do something different?
So I do exactly what Renee has talked about. It's just great to see that I always cross with the U. When I'm going distal, I'm always using microcatheters. I am very nervous about putting a stent retriever in those insular sort of branches, especially when they start going around the frontal operculum, because invariably you will cause a hemorrhage. I believe that's where there is greater value for aspiration. The problem is we don't have very good systems for distal aspiration. We have 3Max from Penumbra. We have the MIBI Q3, which I really like very much for these distal locations. It's quite navigable. And then there is the Zoom 35, which is also good. So the farther out I go, the more likely I am to go to aspiration primarily. Now, I am extremely intrigued with all these mini catch and Tiger 10 and all these fancy technologies. Somehow everything new goes to Renee first. You know, he always gets everything new first, and then everybody else, you know, you or Pedro, maybe those two people get everything first, and we are in the backwoods. We never get anything like that. But I love the concept of a 10 system with a small device to go for these more distal occlusions. I think that'll make things safer. But as far as safeguard is concerned, this is exactly what I would do. And we use the same thing. I like a nice 2x8 coil. I always have a 2x8 ready in all thrombectomy cases, helical. Put it up there through the same microcatheter that you have for your stent retriever immediately. There's nothing faster than that. And then you have all the time in the world to try to figure out what you want to do. So exactly the same.
José Maria, do you have mini catch in Brazil?
Sim, nós temos acá. Mas assim, como disse eu anteriormente aqui, para as artérias distal, para M2, eu penso que também é interessante usar o Trimax, que é menos, eu penso que é menos risco para ter uma manipulação da artéria distal. Uma outra situação, quando queremos usar o mini retriever, é utilizar o mini retriever associado com o Trimax. É fazer uma aspiração com o Trimax e retirar o stent retriever, porque parece que tem menos complicações hemorrágicas porque sabemos que a tortuosidade do vaso são tamanha que vai ter um estiramento. Então, se utilizamos o Trimax junto com o stent retrieve, parece que vai reduzir as complicações.
Gracias. We have 2 minutes left, so we will show a last case. Dr. Escribano has I believe, tandem lesion to show. We will please keep in place for 2 minutes.
Pedro,
okay. Sí.
Pedro, somente uma pergunta para os exponentes. Para a trombectomia mecânica para a artéria distal, que indicação temos? Se é para todas as artérias ou somente para artérias em áreas eloquentes?
Did you get the question, guys? Se Maria is asking the indication of distal thrombectomy. Any distal thrombus or only in eloquent areas?
The more you do, the more you get greedy. The more you see that it works, and the more you enlarge your indications. Of course, you start with the super eloquent territory in a patient that did not receive lysis. As soon as there is lysis on board, you may have more risks. So that would be a reason not to do it. But then, I mean, all studies show, and we don't need a study for this, that TK3 is better than TK2B, which is better than TK2A. So why should we do the job? Not completely, because there is some risk, but this risk is luckily not so high.
I feel the same way, but I think, and I'd love to see what David Leveskin has to say about it, because I think the farther out you go, TPA becomes more effective. But what about, in my mind, is those people who are delayed presenters, who have no TPA is no longer an option, who clearly have eloquence which is affected. So if somebody's got, if you're a pilot and you've got hemianopsia, that's the end of your career. I think you should go for a P2, P3, P4. It depends. If you are 88 years old and you don't need to be out there driving Formula One, then maybe hemianopsia is okay. So it's qualitative. There's no clear data, but we need better tools.
Great. So last minute, Esteban, you have one minute to present the case, please. Stay with us just for one moment, please. I know it's late everywhere, but Esteban, por favor.
No sé si aparece acá. ¿Qué pasó?
Can we have the screen on?
Ok. Bueno, rápidamente, en un minuto, es un paciente con un stroke acá en agudo, donde mostraba... Ok. Donde mostraba 2 lesiones puntualmente, una intracerebral y una a nivel de los vasos de cuello ya en la angiotomografía. Este paciente venía o ingresó con menos de 2 horas de evolución, pero al ver que era una lesión en tándem o
bloque de colaterales vamos a revisar el trials, vamos a revisar un poco el futuro, las próximas fronteras, vamos a ver un poco de inteligencia artificial. Creo que tenemos con nosotros en UCLA a David. David ha trabajado, como ustedes saben, un pionero en las colaterales. Tiene una visión bárbara, porque hace 4 años está haciendo un meeting virtual como este, ya hace 4 años, así que cuando vino la era de la virtualidad ya estaba preparado. David, are you there?
Yes, do you hear me?
Yes, perfect.
Great. I wish I were there, enjoying steak and Malbec, but it'll have to wait till next year. But thank you very much, Pedro, and everyone, for the organizers of the meeting, for having me an opportunity to speak to this esteemed group. And I hope there's time for questions as well. So I'm going to speak to you a little bit about what's new and what's not so new from a collateral standpoint in this year. A lot of this you may have heard me speak about before, but I think it's good to discuss and have an interactive discussion about some of these points, because clearly things are not absolutely crystal clear in terms of what to do at every stage. So the focus, obviously collaterals are important in terms of blood flow, hemodynamics in the brain. What we're trying to do in ischemic stroke, of course, is to reestablish blood flow when it's missing or limited. There is in a history we have a mismatch, a difference between what we understand about the importance of blood flow and then what we do in practice on a daily basis for stroke. I think everybody would agree that hemodynamic approaches to stroke, whether it's restoring blood flow via revascularization or via collaterals, is the most logical, obvious strategy for ischemia of any kind. There's a lot of animal data now, and increasing in the last couple of years, in particular, on blood flow via collaterals and their effect and what happens not just before and after, but during stroke. A lot of very important information as to, here we're focusing on the peel or leptomeningeal collaterals and how they respond to whether it's induced hypertension or vasodilatory challenges as well. So I do want to speak about blood flow, but at the same time, we have to address some of the debate that we're having clinically. A lot of the debate has been about whether we need imaging or not, whether we need perfusion or not, and in which cases. And as you saw from just a moment ago and a few minutes ago, each case is a little different. The variables are different in terms of the nature of the lesion, the collaterals feeding that lesion, and the specifics of the case. We have had a lot of focus, obviously, in acute ischemic stroke on clot composition, this focus on emboli and where clots go to, but less so from a clinical standpoint on collaterals. That has increased over the last several years. And I think it's increased, however, because we understand the most basic fundamental concepts that we were told and we learned about growing up about stroke may not be that true when you start to add in the variables of collaterals. So that the main one I'm talking about is time. You hear more and more during this conference, as well as progressively, about how time is, not everybody keeps the same time, and not everybody's brain responds over the same time course due to, secondary to ischemia or when blood flow is interrupted. The degree of injury that follows is different in one person to the next. It's also important to think about collaterals in terms of the response to the tissue and the likelihood of that restoration of blood flow is going to reverse that process as well. And that has a lot to do with the amount of blood flow that's sustaining the tissue while that proximal artery is blocked. There's a lot that we can do in terms of blood flow. You just saw a moment ago a beautiful result in terms of the changes that you see right on the angio table. And we know this for a long time, that we don't necessarily need the fancy colored maps to show us the radical changes in terms of blood flow. in terms of a lack of blood flow and a restoration. When we want measures about perfusion and blood flow and via collaterals, that's where it gets a little bit more difficult in terms of the quantification, whether we're using a CT or MRI approach. And the bigger question has to do with, do we really care about those specific numbers or those thresholds? Do we care as to what we call, penumbral tissue based on the Tmax delay on a perfusion study? It depends. It depends on the situation, and it depends on the timing of that case as well. A lot of debate about whether you need to get information about blood flow early, or do you within the first few hours, or do you just skip altogether, which is an option. So when we speak about collaterals, obviously it's very specific, not just collaterals in the brain, leptomeningeal collaterals being the main focus. Really, we're not really talking very much about the circle of Willis in terms of the simple shunting of blood from one hemisphere to the next, or from anterior, posterior in reverse. And we're learning more and more about what happens in terms of the functional consequences of how these collaterals kick in, and how they may fail as well over time, that I'll speak about briefly. So this paper was very important from the Calgary group, showing how, once again, what we get from an imaging study about blood flow has to, oddly enough, be interpreted based on timing, that there are differences in terms of we can't just go blindly based on based on the clinical or the imaging. We have to integrate the two to understand what's going on in terms of collateral circulation and how it may sustain or fail. There's a lot that can be done in terms of measuring blood flow in terms of collaterals. The Tmax or other delay parameters tends to be the most obvious one. And this has a lot to do with the fact that, it's the delay in blood flow that is the best marker in a complete occlusion. But of course, blood volume, and as I showed on the lower right, the blood volume gradients may tell you how there's where that change is greatest in terms of the change in terms of blood volume from one area to the next, and may be able to predict where your infarct is going to grow outward and progressively from subcortical to cortical regions as collaterals fail. And it's this mystery about collateral failure that still remains unclear as to what the causes are. Why are collaterals so good initially? This being seen beautifully described in the literature 30 years and more before the present time. But then there's a subsequent compromise, subsequent collapse of collaterals. And it's intrigued us clinically because we know we may be able to treat patients at a later time point where they're sustained by collaterals. But at the same time, it doesn't mean that those collaterals are going to stay forever. Because this collateral failure is something that we have to offset and not wait for. So there's a lot that can be done in terms of flow heterogeneity, in terms of digging deeper and deeper in terms of the derivatives, literally, of the perfusion curves, understanding what's happening in the local microcirculation. But the goal is to figure out perhaps what those causes of failure is that may be the most clinically relevant. So we see collaterals all the time. For every occlusive lesion, there is a corresponding collateral blood flow pattern that we would expect to see. And not just that, but different degrees of how those collaterals are maybe manifest. It's also important because collaterals have been shown to be associated with better recanalization, more effective reperfusion, worse collaterals associated with hemorrhagic transformation, and worse collaterals associated with worse outcomes, as well as opposite being true, that even in a late time window, better collaterals equals better outcome. I mentioned this a moment ago about the circle, the dynamic change of the circle of Willis. And I don't think that this is as important, but I would just point out that it's dynamic as well. So the terminology about whether somebody has a fetal PCOM or not, to a certain degree, is irrelevant because everyone was once a fetus and can go back and develop a fetal circulation if need be, and it can involute as well. So the circle can be dynamic. It's just that it's a relatively simple system of shunting of flow. So this just showing this example of how PCOM, as you see on a daily basis, opens up beautifully. The vast majority of MCA occlusion cases will have an open PCOM, and that's not necessarily because that PCOM was shunting flow before, but the second that you occlude that MCA, you will divert flow to that PCOM, and the opposite is true as well. Effective reperfusion is very commonly associated of the MCA field will effectively reduce that shunting and involution of that PCOM flow. Reverse leptomeningeal flow is really the holy grail, the nut that we're trying to crack in terms of understanding this flow pattern. It's a highly unusual nature of flow where flow only comes in through single circuits, only certain daughter branches. And this is important because it's highly unusual. It defies the basic laws of physics in terms of what we would expect to happen in a vessel. Murray's law does not hold in reverse. And as a result, you get shunting of flow across those bifurcations, filling in reverse towards the parent vessel, and not as much filling in necessarily the other daughter vessels. So it's this very unusual backfilling pattern that we see. And we see this all the time, despite us seeing this very frequently. The fact is that we don't understand it. It's not been modeled well. Non-invasive imaging is important before we go to the angio suite to figure out who we want to take to the angio suite, perhaps, but also for planning, as well as perhaps to tell us about the degree of collaterals. Now, there's been a lot done with multi-phase CTA as well as CT perfusion, as well as MRI techniques in terms of predicting collateral flow. But you get to a very basic question here, which is how precise a definition do you really need in terms of your decision making? One can argue if you're going to go to angio anyway, you can quickly glance at this and, whether you see better collaterals or not, it may not really make that much of a difference. I'll argue that as much as planning is important in terms of the anatomy, in terms of access from a CTA, that initial look at the collateral status may also be important in terms of what you do sequentially in the angio suite. So going beyond the decision to just go and revascularize that patient. But there are cases where you may not want to, despite what Renee just said a few moments ago, you may not want to get a full TICI 3 reperfusion. In those cases with poor collaterals, prompt reperfusion may not be good. Now, it may change in the future what we do in terms of how far do we go with one case. Most commonly, it's a question of how far do we go after spending a lot of time with very resistant occlusions. But I think that decision-making in the angio suite is the next frontier. Now, we can tell a little bit about this from our non-invasive imaging done beforehand, and we can tell about this a little bit more about this in the suite. In terms of the CTA and CTP methods, these are all variations along the same type of approach, which is simply a non-contrast CT where you add contrast, and either you're tracking it at a late time point or you're tracking it throughout that injection to see how to get some dynamic views of perfusion. So when it comes down to collaterals and this question about does this patient have good or bad collaterals, we can dichotomize like this. And we tend to do this. We tend to split things and say, that things are either, partially good or partially bad. But like with a lot of other things in imaging, it's very hard in terms of where do you exactly draw that line. And partial filling, this grade 2 ASITN level of collaterals, is very hard to actually parcelate out. We can see some temporal information on static CTA. So single phase CTA, not multi-phase CTA, tells us about the temporal arrival of blood flow as well. We're able to color code this as well to actually tell something about the function of those collaterals, not just their appearance. We can also delve into the topography, the areas that are involved in terms of how collaterals may fill one area better than the next. And this goes without saying that this is the next frontier as well, another frontier in endovascular therapy. How do we know, as Adnan pointed out, what is the most eloquent region and most important region of reperfusing at that next stage? It may vary from one area and one person to the next. So speaking about collaterals in terms of stroke evolution in the last few minutes that I have here and leaving time for questions, we know that time is brain only because they run on the collateral clock, so to speak. Collaterals will determine the time course of the injury. We know that this is associated with lesion growth. It's been shown again and again. The distinction between fast and slow progressors, the distinction between who you need to treat early and very rapidly versus who you may have time at a very seemingly late time point. You'll be hearing more about this. We've presented on this in the past, but in terms of collaterals in the late time window, this is a curious problem because we know that people in general that were entered into DAWN and Diffuse 3 had relatively good collaterals, but not all did. There was still a distinction in terms of who had good and poor collaterals. And even in DAWN, that distinction was related to outcomes at 90 days. Perhaps a slightly different look at collaterals in the late time window. In terms of collateral failure, this is what we're trying to avoid, waiting too long and not knowing when those collaterals may fail. This is a little bit to do with pressure in the tissue as it increases, which then impacts that reverse collateral filling as well. There are very, very sensitive marginal differences in terms of collateral status that are influenced by pressure. This was shown very nicely by Daniel and his group several years ago now. I mentioned this earlier, collaterals may be important in terms of reperfusion injury, that the degree of collaterals, poor collaterals may beget reperfusion injury as well and lesion evolution. So I'm going to end here by just pointing out that collaterals are very important in terms of the precision medicine of stroke, the precision medicine of acute stroke, and what I think is the future in the precision medicine of endovascular therapy for acute ischemic stroke. Sequentially, stepwise, making those decisions in the angio suite, because obviously each case of endovascular therapy and with mechanical thrombectomy or other means is not the same as the next. And the goal is to figure out how we can further improve our outcomes overall. Thank you, and I hope there's time for questions.
Thank you very much, David. You know, collateral has been around, and I think it will be around as well as precision medicine. So please stay with us. We will have you for questions. Okay. I think we'll be also a friend of you from UCLA, Dr. Fernando Viñuela, with us for that roundtable discussion. So please stay with us. I will ask Dr. Mayank Goyal from Canada. Mayank has been around for trials and vascular neurology for a while. Unfortunately, we cannot have you in Buenos Aires, but I'm sure we will learn a lot about the new trials, what is going on with trials and strokes, and also beyond that. So it's my pleasure to introduce Mayank. He's working at the University of Calgary in radiology and neuroscience. El doctor Mayank Goyal es el próximo disertante de Canadá, trabaja extensamente en la Universidad de Calgary. Le vamos a agradecerle mucho al doctor Goyal, mucha de la evidencia en medicina en stroke, y está trabajando en eso y está trabajando en muchos trials nuevos que están por venir. Así que gracias por estar aquí, Mayank, and please go ahead if you have him ready, please.
Good morning, everyone. I want to thank the organizers, Pedro and the rest of the SIMI team for inviting me. I'm going to be talking about what are the current trials ongoing and where the world is going. These are my disclosures as expected to have run trials before and do consulting for companies. Here's the broad outlay of the trial, EVT in terms of where the world is and where it's going. Where is the world of thrombolytics and specific TNK going? And will we be using thrombolytics in the first place for patients with LVO? What about transport paradigms direct to mothership? What about neuroprotection? And what are the questions that we are finding it difficult to answer? And obviously, you're very much familiar with the data that is around this. The paper that we wrote in Lancet from the Hermes analysis had a phenomenal NNT, which is very well familiar to this audience. And then obviously the late window trials, which showed a phenomenal effect in the late window as well. In terms of this, it doesn't work only, so to speak, in a few countries. It works across the planet. This was Sheila Martins in Brazil, showing that it works very well in Brazil as well. And I've written extensively of this idea of denominator fallacy, which we have to keep in mind, that if we become super selective in the patients that we select for EVT, we end up getting good results, but that does not mean that is the way to go forward. We have to think about the patients that we did not treat along the way and how we can best optimize the overall outcome for the population, not just for a few patients. So that brings us to this question that at the current moment, with all the subgroup analysis that we have done, the question now is no longer which patient should be treated, but actually which patient should not be treated using the super powerful therapy that we have. And if you look at the fringes that we are currently looking at, there's the low aspects, there's low NIH, there's the MIVOs. There's also another question that is there, that in the late time window, are we being too selective? And that has been looked upon by Mr. Clean late, or many people are just walking with their feet and sort of making it more liberal on their own. So just to talk about low aspects, one of the problems we are thinking about from an aspects is that you can have an aspects territory which is completely dark. For example, here, you can have an aspects territory that is faintly dark, or you can have an aspects territory that is patchy. And we looked at it from the point of view of what we call nuanced score, where this is like a 0, but this could be like a half or a half this way kind of thing. And this is from the Escape Anyone database. And what we found was it actually matters. If you look at areas that are moderately affected, they do much better. Which also brings us to this point of that when we think about low aspects, are we thinking about it the same problem as uniformly? And there could be an area which is clearly a 0 and completely dark, and there could be an area which is subtly dark, and how do we sort of solve that problem as we move forward with the trials? When we looked at the Hermes database and we published the trial on the imaging, which was published in Lancet Neurology, we were able to show that in patients with aspects 3 to 5, there was benefit of treatment over here. So you can see this over here, this benefit of treatment. While in 0 to 2, there was a tendency for harm with very few patients. So now that we have this data, how do we use this data? How do we change guidelines? We did this survey, which was a worldwide survey across 38 countries kind of thing. And we presented different kind of questionnaires related to 72-year-old with an aspects of 3, 33-year-old with an aspects of 2, so on and so forth. But the interesting part was that the majority of the people did say that they would treat the patients depending on what the scenario was. Especially if the patient was young, more than 50% of the people wanted to treat it, even with an aspects as low as 2. So there is this issue when we look at things in isolation of just aspects as opposed to combining aspects with age, it changes the decision making. And it's across the world, and as expected, the aggressivity of treatment is higher in Western Europe and North America compared to certain other parts of the world. There are multiple trials running in this, in extremis tension, 2 trials running in Europe. Hopefully we'll find out the results. But even when we do find out the results, we'll run into this complexity of a sort of a tunnel vision kind of approach to aspects. So if the trial is positive, does that mean we treat an 85-year-old with an aspects of 3? If the trial is negative, does that mean that we not treat a 44-year-old with an aspects of 5? And that is a problem we have to sort out. Moving over to low NIH trials, there is this issue which is with low NIH, there's a risk of making things work. But at the same time, there's a high rate of early neurological deterioration with medical management. And once again, we did this worldwide survey across 38 countries. And what we found was that a significant number of the population of people who responded across different countries, more than 50%, wanted to treat these patients, even though we don't have a good data set. And again, once again, as expected, this was maximally in Western Europe, North America kind of thing. But there's also the practical issue that at the low end of NIH becomes problematic. So for example, this patient who presented with NIH of 0, but could not do her job. She was a high-end, high-functioning financial advisor, could not answer a simple tax question. And whichever way you look at it, the NIH was 0. There was this perfusion deficit, as expected, was green because NIH is 0. There was an occlusion of ICA M1. And finally, when we opened the vessel, which we decided to after a lot of discussion, instantaneously, she knew the answer to the tax question and our brain could function. So that also takes us to the issue of is NIH the right way to think about this problem? And again, there are trials running in this mode. ENROLLO is starting soon as well. So we'll find out the answer. And once again, we'll run into this problem of that the trial results, will they be generalizable or not? Talking about medium vessel occlusions, we've been writing on this extensively. We sort of defined it and called it the next frontier. This was published in JNIS recently. And this is how sort of we're defining it A2, A3, M2, M3 in terms of P2, P3 in terms of where the geographical location is. But in addition, it has to be combined with a substantial clinical deficit that is relevant to the artery of that is occluded. And there's this issue of primary versus secondary MEVOs, which many people have written about, that did the clot move to the M3? And we've been talking about it. We wrote this extensive detailed analysis of sort of outcome of discrepant infarct patterns, how to recognize secondary MEVO. And that will become a big issue when we start to do a trial. For example, here, this is the area which is occluded, but this is the area where the infarct is. So how did this infarct happen? It's probably unrelated to the occluded vessel, which means either there is a second clot or the clot was more proximal at a certain stage. And that is something we'll have to be cognizant of as we move forward. And the degree of discrepant infarct, so to speak, are not rare. So we looked at all the databases that we had in terms of sort of MEVOs, and a phenomenal number of them had actually discrepant infarct, which means that there's a component of the MEVO which was secondary, or it was multiple MEVOs sort of put together. And the other part that is there is the outcomes of secondary MEVOs are much worse than the outcomes of primary MEVOs, which is in a way expected finding because of the fact that there are other parts of the brain that are affected. So we think 20 to 40% of all MEVO strokes may be secondary MEVOs, and that is something we'll have to be cognizant of. What about the clinical course of MEVO? So one of the things that people talk about is, oh yeah, it's a small vessel, TPA will work, let's get it open kind of thing. But we found that 50% of the patients do not end up with MRS01, which is sort of super important to remember here. And obviously TPA does improve the recanalization, but in spite of the recanalization, 55% of the people had MRS01 versus not kind of thing. So that's something to keep in mind. The TPA, while it's a great drug, does not work like magic. There's still 50% of the patients that do not open with alteplase, and that is something we'll have to sort of keep in mind. Now, obviously, there is no level 1A data from it. There is limited data from M2, which we published in JNIS, that in M2 occlusions within Hermes, there was benefit of treatment. Now, it's important to remember that within Hermes, a lot of those M2s were such that they were M1-looking M2s. There is this issue that people talk about that MEVOs may be challenging to detect on imaging, especially if the readers have limited experience. And from that perspective, it's likely that future technologies, for example, color coding of multiphase CTA maps like this one will help in it. So here, for example, you know by this different color that there has to be an occlusion over there and makes it very easy. There's also these kind of maps which will soon be available from multiphase CTA or from CT perfusion, which will help in detection of MEVOs. So, different people are thinking about a trial in this regard. This is not an easy trial to run. We are thinking about it as well. Is tenecteplase knocking on the door? We've seen the results of the Extend-IA trial, Extend-IA TNK from the Australian group, which showed benefit of TNK over TPA. There are higher recanalization rates and better functional outcome. The dose did not seem to matter. There is this issue of in patients who are going for EVT, does TPA really add anything or not? And I worked with the Dutch group and the Chinese group, led by the Chinese people in Pengfei and Jianmin. It was a sort of a pleasure to work with them. That showed the non-inferiority of EVT alone. Mr. Clean, no IVS finished enrolling, and the results should be out soon. The other part that is there is IV thrombolytics in the extended time window, and Goetz-Tomala and team in Hamburg did this trial in terms of MR-based. There's also a trial time that's running, which is enrolling quite well, and we should know the results soon. We ourselves are running a trial in Calgary, which is the ACT trial, plain and simple, alteplase compared to tenecteplase in all comers that are eligible for alteplase. The stroke transport paradigm, there's obviously the issues of direct-to-mothership, drip and ship, flying neurointerventionist mobile stroke unit. And this is a question that we've looked at in detail and did all kinds of modeling around it. The RACE-CAT results came out recently, but at the same time, there was no difference in outcome, whether you went direct-to-mothership or with a drip and ship situation. There is the issue of mobile stroke unit. This data was presented at the last ISC in the Berlin area, where mobile stroke unit had higher chance of receiving IV thrombolytics and shorter time to needle with MSU. But at the same time, there was lots of complexity of setting it up, the cost associated with it, and I'm not sure too many people will be able to replicate this in terms of a resource allocation point of view. There is a lot of work going on in terms of pre-hospital LVO detection. There are many different technologies that are being tried and things like that. We are working with this device called Forest Devices. We looked at all possible devices and we found this one had the best balance of practical utilization in our context versus their ability to detect LVO. The trial is called Segway trial. We should be starting it soon. Michael Hill and I are leading it. Now, in terms of neuroprotection, this is, in our opinion, probably the biggest story. That is where we are focusing our energy. You know the results of the ESCAPE NA1 trial. It was a phase 3 trial looking at this drug NA1 in all patients who were going EBT. It was a worldwide trial. The main results did not show any benefit of NA1, but in the subgroup of people who did not receive alteplase, there was approximately 10% benefit that was seen. There was a benefit of mortality as well. And obviously, as expected, this was a subgroup analysis of 446 patients. We need to go and repeat this trial and see whether this was a chance finding or not. So that is what is called ESCAPE Next. And that is what we are focusing all our energy on. We hope to have the first patient randomized within the next 1 month or so. And it will be on all those patients who do not receive alteplase. And as you know, the alteplase story is moving along because of the direct empty trial, and hopefully Mr. Clean No IV trial will confirm those results. So there will be a shift away from alteplase. There are questions that we should be thinking about but are difficult to answer. For example, what is the denominator? What is the total number of patients with an EVT eligible occlusion in the total population? And how many of them we are able to treat and how many of them we are not? And the ones that we are not, what are the reasons for non-treatment? Is it related to patient education? Is it related to transport? Is it related to imaging criteria? And so on and so forth. The other part that is there, which we've written extensively about it, is that, what is our technology capable of from the point of view of calling dead brain? Is that brain truly dead? And we have strongly said that we should not be calling it dead brain or should not be using the word core, but we should sort of be further studying this idea of dead brain. And right now we have proposed this term SITUV, severely ischemic tissue with unknown viability, and that unknown viability is going to be dependent on how fast and how well we open the vessel. So here in the last 20 minutes or so, I've rushed you through all the stuff that is going on in our world. We are at a very, very exciting phase. We are moving towards more and more evidence-based medicine in the world of acute stroke. Hopefully we'll move in that direction in the hemorrhagic stroke side as well. But the next few years are going to continue to be exciting, where this field is going to expand and we will have a much better idea of how to help our patients from this otherwise devastating condition. I'm going to stop here. Thank you. And open it up for questions.
Y en cuidados neurocríticos, es el director del servicio neuroendovascular de Emory. Quisiera en el Grady Memorial, así que quisiéramos invitarlos a que nos acompañe en este periodo de la tarde. ¿Se puede predecir que realmente una recanalización será infructífera, será fútil, como dicen los sajones? Realmente sería muy bueno que supiéramos eso, porque se podrían evitar mucho trabajo realmente y mucho daño para el paciente. Es nuestro placer introducir a Raúl Nogueira. I hope you are there. Raúl, please go ahead. Bienvenido. Parabéns.
I'd like to thank the committee for the opportunity to discuss this fascinating topic. Here are my disclosures. So, how to predict futile recanalization in stroke using imaging? I believe that at this point, we actually can't predict futile recanalization with imaging. More importantly, at least in the early window, you should not even try to. It's important to acknowledge the possibility of futility. It's a concept that has been there since the foundation of medicine. There are limits to what we can do for any given patient. However, futility represents an unacceptable likelihood of achieving an effect that the patient considers a benefit. There are two components to it. One is a quantitative component, where that likelihood of a benefit is exceedingly poor, less than 1% chance. So it's not low, it's very, very low chances. Moreover, there is the qualitative component of futility, where the quality of the benefit is also exceedingly poor. These concepts are not adequate because it's hard to get a consensus on what these two components are. However, exceedingly low probability rather than uncertainty and unpredictability define futility. The other important concept is that medical futility should not be confused with healthcare rationing. This is not about how much does a treatment cost, but rather do the advantages of this treatment outweigh the disadvantages in this particular patient. In terms of common wisdom, it's simply to give the patients the benefit of the doubt. How do we define benefit in acute ischemic stroke? And I think there was a lot of confusion in our history where you would dichotomize things in the good and the bad, right? And you got more sophisticated with the ordinal shift analysis where you acknowledge that there is a benefit in going from the different steps of the disability scale. But we then got even more sophisticated and you start acknowledging that the movements along of the scale had different weights, right? So I think it's important that you understand that this is not about having a good outcome, but rather about having better outcomes than without treatment. There are many other benefits that you can't measure with our typical metrics, like there are cognition and performance benefits that are not properly captured by the modifier Rank scale. One can prevent a hemicraniectomy with aggressive reperfusion, a procedure that actually rescues ischemic brain and prevents cerebral edema versus the hemicraniectomy that only rescues the herniating brain. It also can shorten length of ICU and hospitalization stay and potentially cut costs as such. Another important notion is, at least with the way thrombectomy is currently performed, we improve quality of life rather than quantity. Very modest improvement in terms of mortality, but you do not increase the amount of people who are living with a high degree of disability. The bulk of the improvement is with good quality of life. How do you quantify benefit in acute ischemic stroke? And here I think you use two weights with two measures and a double standard when you compare endovascular treatment with intravenous treatment of stroke. Here are good examples. We have the recent EXTEND trial. We see here a treatment effect size of 6.7%, and that was a highly positive and celebrate study as it should. It is another study that was highly positive and celebrate as it should, the CAS3 trial, treatment effect size of 7%, 5%. The investigators for the PRISM trial consider a benefit that would be significant if it was more than 6%. The most investigators have lowered it to 4.5%. When you ask stroke experts, the median minimal clinically important difference for us to notice across treatment, no treatment with a novel and safe therapy is as low as 1.3% in the opinion of stroke experts. So maybe you have a bar that is too higher for endovascular therapy. The expectation is too higher because our early trials have been so powerful, but they were so powerful because you really over-select the treatment population. You are not treating a lot of people who could still benefit. Like the BASICS trial was considered a recent failure, again, with numbers very similar to the numbers that I just demonstrated to you, 6.55%, very similar. True that it didn't reach statistical significance, it was underpowered, but the treatment effect size is as good as celebrated trials in intravenous thrombolysis. Other thing is why the concept of reperfusion futility based on image is a bad idea. one must to be very careful to avoid the misuse of imaging, which we are doing more and more. We tend to think that as you do more imaging, more complex imaging, we gain accuracy despite losing time. You have to be careful. As you look the data on CT perfusion, diffusion, post-aggressive and fast reperfusion, things are very confusing. You can have a patient with a core of 91, as you see here, that with rapid endovascular perfusion has absolutely no core on DWI post-mechanical thrombectomy. This is what you call the GOAT score and has been reported by our colleagues from Barcelona. Predictor early reperfusion treatment, right, for patients treated in the first 3 to 6 hours. So the message here is that you should never exclude a patient from treatment based on CT perfusion findings alone. This is our experience at Grady. We have looked at, within the first 24 hours, almost 10% of the patients will have a GOAT score with a reversal greater than 10 cc's. If you consider the first 6 hours, is actually almost 15%. These lesions can be quite big, 20 cc's. In a quarter of the patients was over 33 cc's. The predictors of GOAT score include early onset to reperfusion time, less than 6 hours with an odd ratio of almost 3.5, but also poor collateral scores. Okay. But what is really important is the presence of a GOAT score was an independent predictor of lower disability. It's actually a good marker if you actually correct for the patients that have the real core, obviously. How about DWI? Is it a lot better? Well, it's a very good way. It's easier to see, but you still can have cases like this where you have with aggressive early reperfusion, remarkable DWI reversible. How common is that? Turns out that approximately 15% of the patients you have a permanent DWI reversal greater than 10 cc's or so. It's not that uncommon. Okay, so GOAT scores with both CT perfusion and DWI. So in my opinion, the only real marker of necrotic tissue, reversible damage, is loss of gray white matter differentiation on contrast CT. It's the most reliable biomarker. So why waste time with more imaging in patients if you can't trust that? The other thing that's very important to understand is to refine the idea of not only the quantity of infarct, but also the quality of infarcts. Not all infarcts are made equal. It's a heterogeneous process. This paper in Nature, it's absolutely fascinating. They essentially disembodied a pig brain. They kept it in normothermic conditions for 4 hours, and after that, they hooked it up to a perfusate that had the oxygen and nutrients. And by doing so, they document preservation of cytoarchitecture, attenuation of cell death, restoration of the vascular dilatory response, and glial inflammatory responses. 4 hours of a disembodied brain. You see, again, reperfusion bringing a lot of the brain tissue back. It's absolutely amazing. So reperfusion is very, very powerful. And futility in reperfusion is something that we need to question more and more. Why? Because you need to start understanding the concept of selective versus diffuse tissue death. The neurovascular unit, it's not composed only of neurons. You have vascular cells, you have glia, and these cell lines have a differential vulnerability to ischemia, right? So while you have normal brain, there is actually a spectrum with several shades of gray going from selective gray neuronal necrosis to progressive neuronal loss with glia preservation before you can get into the necrosis. And probably people in this spectrum here will do a lot better than this spectrum. Okay, so it's the idea of an incomplete infarct, which is what you have here. This is a patient that you reperfuse after a ACA, MCA clots, and you can see this pattern that almost look like cortical lamina necrosis with sparing of the white matter in a lot of the brain scaffold. No loss, but we still have a lot of the elements right? Holding this scaffold together. It's very different than a patient that has pannecrosis with cystic encephalomalacia like this. I think these patients will have different outcomes. Another reason why excessive imaging in the early window is a bad idea is that most people, about 85% of the patients, have favorable imaging within the first 6 to 8 hours. So why waste time looking for bad imaging if 85% have good image? And here is a paper with about 85% in the first 6 hours. Here's another paper with about 85% of the patients with favorable imaging in the first 6 hours. So what about if one does not have a favorable imaging profile, 15%? What happens then if I do reperfusion? Can I harm them with endovascular reperfusion? Well, let's look at that. And when you look here, less than 70 versus greater than 7 mmol on CTP and MRI in the Hermes meta-analysis, you don't see more symptomatic intracranial hemorrhage in these patients. Not only that, but this 15% of the patients with the not so favorable imaging profile actually seem to benefit. It is the Hermes 3-5 analysis, 186 patients, and you see that they do have a higher likelihood of having less disability and a higher likelihood of being functionally independent at 90 days, both statistically significant. Looking at core size now, greater than 70, it's not statistically significant, but you can see here that there is an idea of a benefit. Even if you look not only at CTP, but also at TWI, you can see, again, the numbers are small, but there is an idea of a potential benefit. So not surprisingly, when you look at the first 6 hours, most patients will benefit from treatment, right? So the conclusion here is, right, in the early window, you are wasting the precious time when we know the vast majority of the early patients have favorable imaging. In order to identify 15% of the patients with unfavorable imaging, when you do not even really know if they don't benefit, right? We don't even know if there is futility. It should be less than 1% chances of benefit. So it just doesn't make any sense, right? The other problem that you need to understand is this confusion in our field between predictors of outcome and treatment effect modifiers. This comes from the fact that we start with single-arm, uncontrolled trials, so you are comparing thrombectomy with thrombectomy, treatment, no treatment, yes. Younger patients do better, lower NIH strokes patients do better, higher specs do better, right? However, if you actually compare not different patients in terms of this, but similar patients in terms of these characteristics, treatment and non-treatment, which we now can do through randomized clinical trials, you see that neither age, stroke severity, and it seems not even aspects, stroke size, are treatment effect modifiers, okay? Here is the answer for who does well with treatment, but this is the more important question. Who does better with treatment? Who has any chances of benefit? And imaging markers are predictors of outcome, but not necessarily treatment effect modifiers. Look at this beautiful analysis from the Hermes data. Greater than a third of the MCA doesn't modify treatment effect. Aspects doesn't modify treatment effect. So where is the futility here? Excessive imaging leads to over-selection. More selection in these trials, better outcomes in endovascular group, but also better outcomes in the controls. You're just filtering patients out to the point that if you compare the endovascular treated patients in Mr. Clean with the controls from Extend-IA, the controls in Extend-IA are better. So again, CT perfusion, excessive images, filtering people out that could still benefit from treatment. This is over-selection. And here is how you can even illustrate this better. CT perfusion, 100 patients, they are selected. Very high treatment effect size. Number need to treat is 3. 70% are function independent at 90 days. This is very much like Extend-IA. This other group is selected more inclusively with non-contrast CT. We end up treating a lot more people. The benefit is not as good. In fact, half of this treated population has these outcomes, right? And you go like, well, I would rather be here than here, but look at the denominator fallacy issue here. When you look at the overall population, 10 out of 100 here benefit as opposed to 16 out of 100 patients here benefit. So this is the issue of over-selection. Some final basic concepts here, treatment power and time sensitivity. How big is our treatment effect size? It's one of the largest in medicine, probably because you are over-selecting so much. It's almost like antibiotics in sepsis, right? So how do other fields in medicine deal with time-sensitive conditions that are very severe? Right? STEMI, go straight to the room, you don't do a myocardial scan. Sepsis, bacterial meningitis, you do antibiotics, you don't wait for lab results or scans. So why, in the face of a large vessel occlusion stroke, high stroke severity, early on, we are not taking these patients straight to the angio suite? I think that's a mistake. You need to rethink this concept. Endovascular treatment is one of the most powerful treatments in medicine, at least by the number you need to treat you currently have. So you have to have a very strong reason not to treat these patients. You can harm patients actively or passively. Not offering a very powerful treatment, it's a way of harming patients. Let's think about how other fields in medicine think about the futility and costs. Have you ever seen anybody excluding a patient with a large ST elevation MI, maybe in cardiogenic shock, because they have poor prognosis or the costs are high? Doesn't happen. Cardiologists will treat these patients aggressively despite almost 40% mortality in a cardiogenic shock. How about a sepsis, severe sepsis? Poor prognosis, treatment costs. You see emergency room physicians or critical care specialists with not offering aggressive treatment in the presence of sepsis. That doesn't happen. 40% mortality in septic shock, right? So why we think so differently in the face of a stroke? Trauma is another model, right? Where you treat first and you ask questions later because it's just a bad disease. So I think part of the problem has to do with this, like how the patients look. A stroke patient doesn't trigger as much empathy, right? The other problem is cardiogenic shock, septic shock, large stroke. Maybe you should change the name to cerebral ischemic shock to see if you can change our behavior in relation to these conditions and treat them more aggressively, rapidly than what you were doing without this over-selection and wasting time. Look at cancer, right, and futility and costs. Moreover, when you don't treat STEMI, sepsis, trauma, and cancer, people will die. When you don't treat a stroke, most of the time they don't die. They stay alive, but with a higher degree of disability. And because of these people stay alive, unlikely these people, they are actually consuming healthcare resources and being a burden to society. So if anything, from a financial standpoint, you should be more aggressive with stroke. Finally, we need to understand that not all the benefit of stroke treatment, reperfusion, can be explained by shrinking the size of the infarct. In fact, this analysis suggests that it only explains 12% of the functional outcome benefit. It seems that reperfusion of large strokes also seems to reduce cerebral edema. You see one paper here, another paper here, third paper suggesting that. How is that possible? Again, it's by rescuing how the other cell lines in the neurovascular unit, the astrocytes, the endothelial cells, the pericytes, they may be able to abort that cerebral edema, which confers yet another opportunity for a benefit. So I believe the future is you need to understand that time is brain and imaging takes time. Therefore, time is brain, image is time, imaging is brain. We need to start thinking like cardiologists. You shouldn't reinvent the wheel. And acute MI is not equal to a fast perfusion scan. Go straight to the angio suite and fast reperfusion. And the brain cells are even more vulnerable to ischemia than the heart cells. So you need to act as fast as the cardiologist, or potentially even faster. And you do have the EKG for the brain. That's called the NIH stroke scale equal greater than 10. In fact, the rates of false positive cath lab activation using this versus this, it's pretty similar as if you look here at these ranges. So I believe this will be the future. Within the first 6 hours, you're going to be bypassing the CT or MRI suite patients. You'll come straight to the angio suite. You're going to be acquiring simple imaging. What you need to do is that you have published on some of our initial findings with that. We just need to see there is an occlusion. Maybe you can look for degrees of collaterals. I think we're doing some pilot work here, but it's unnecessary. Okay, we just need an occlusion in early time and treat everybody. And with that, you're going to save time. And I think you're going to have better outcomes. This has been reported by many other colleagues, direct to angio. And in particular, this work from Mark Riba in Barcelona shows very promising results with improvement in functional outcomes at 90 days, as you can see here. There is now finally a trial for that. It's called We Trust, where you're going to, again, randomize patients for conventional imaging versus direct to the angio suite. And if they fulfill criteria for treatment, they're going to go into an intention to treat analysis for us to look at their functional outcomes. So to conclude, current selection paradigms are too restrictive and time-consuming. Be aware of ghost scores, false scores on both CT perfusion and the WI. Be aware of patient over-selection. Okay, and the high time sensitivity, mostly in the early window. Imaging takes time, and in the early window, it only increases the chance of futility. More time you waste, you are only increasing the chances of futility. And you are trying to do image to look at 15% of patients when you are probably hurting 85% of them. Doesn't make sense. The current technology allows us for the proper selection in the angiography suite, and you can behave like cardiologists and achieve STEMI goals. Very important, there are likely much more patients being harmed by no treatment than treatment in both the early and late treatment windows of reperfusion therapies. The final message is select faster, select less, and treat more. Thank you very much for your attention.
Bueno, impresionante, Raúl. Realmente, como siempre, aprendemos y aprendemos con tus charlas. Creo que esto es casi una charla filosófica. Al principio directamente no seleccionábamos tanto, ¿no? Dejamos tanta gente atrás, no tratamos tanta gente. Por supuesto que cuanto menos seleccionemos y más rápido tratemos, es mejor. Pero bueno, esto lo veremos en las discusiones y creo que deja un montón de material para la discusión, teniendo tantos neurólogos con nosotros, intervencionistas. Venimos bien con el tiempo, quisiera presentar a alguien que ha trabajado bastante en inteligencia artificial, AI. El profesor Gregory Albers es neurólogo vascular, es director del Stanford Stroke Center, es profesor de neurología y ciencias neurológicas de la Fundación Coyote de la Universidad de Stanford en Medicina, en California, y es alguien realmente que es un placer tenerlo hoy con nosotros. Es más que un placer, en realidad es un honor. Alguien que ha trabajado tanto en este campo que ahora está booming, ¿no? Thank you, Gregory, and welcome to SIMI 2020. Thank you for take some time to spend with us. I know you are always busy, so please share with us the artificial intelligence in stroke. We are delighted to have you with us and ready to listen to you. Thank you again. Welcome.
Thank you so much. It's really my pleasure to be here. Certainly wish I could be there in person. It's been since 1992 since I was able to visit Argentina. I'd love to come back when the world is in a slightly better place. But it is a pretty exciting time for artificial intelligence and stroke, and thank you for asking me to cover this topic, which, as you mentioned, is really exploding. This is a list of the AI stroke software that has been approved by the FDA, and this list is growing every few weeks. What you can see is that there's a huge number of approvals for hemorrhage detection software. There are 4 for detecting large vessel occlusion. There's 1 for automated aspects, and there's 1 for an automated thrombectomy indication. So AI software is clearly arrived. And what I'll point out is that the vast majority of these clearances are what are known as notification clearances. And that's very important to understand that this software at this point is not making a definitive diagnosis. It's basically saying, hey, take a look at this scan. I think there's a brain hemorrhage. Or, hey, take a look. I think there is an occluded large vessel. So it requires the combination of the software and the human for the most definitive diagnosis. What we've seen in a number of studies is that this software can improve the performance of the human, but it cannot replace the human. And that's why these notification clearances are very clear. They are not making a diagnosis. They are bringing your attention to these scans, but they can prevent you from making errors. So if we talk about the one that has the most clearances, such as the brain hemorrhage detector, you can imagine if you're about ready to give a thrombolytic to a patient, you've looked at the scan and you don't see a hemorrhage, but all of a sudden you get a notification that says, hey, the software sees a hemorrhage. You may take a look and say, hey, I missed something that is really going to help me decide that I shouldn't treat this patient. Also, many places, the scans in the ER are not being looked at immediately. There's a long list for the radiologist. So this is a flag that, again, says, hey, I'm going to move to the top of the list because there may be a brain hemorrhage here. And here's just some typical examples where you can see that intraparenchymal, subdural, subarachnoids, and intraventricular hemorrhages can be identified by the software. The sensitivity and specificity is in the range of 95%, which is quite good for these softwares. But what that means is that there is going to be 5% of the time where a brain hemorrhage is missed. So you can't take an absence of brain hemorrhage as definitive. And there's going to be about 5% of the time where the software alerts you, hey, I think there's a hemorrhage, but you take a look and then you say, nope, that's a false positive. The software got fooled because the software, still can make mistakes. I think it's going to be that way for many years to come. So it's a combination of the human and the software that gives you the best performance. These brain hemorrhage softwares can also measure the volume of these intraparenchymal and intraventricular hemorrhages, which can allow you to get automatic stability information and help you decide if somebody is eligible for a clinical trial, or if you're using a prognosis algorithm that depends on hemorrhage. This is a much quicker and easier way to get the hemorrhage volume than measuring it out yourself. Okay, let's move on to LVO software. This is large vessel occlusion software. There are 4 that are FDA approved. This is the example of the rapid one, which has the highest sensitivity and specificity, 97% and 96%. Again, meaning it's very good, but not perfect. It's going to miss a few, and it's going to false positive notify you sometimes. So it's, again, going to be up to the physician to take a close look. So what the software does is it provides these MIP images, and then there's a vessel tracker that looks for an occlusion. And you can see if you're suspecting an LVO, you get an output that looks like this, which makes it very easy to identify where the large vessel occlusion is. In addition to this, what you can get is blood vessel density assessment, which can allow you to find more distal occlusions. So on the left, where you have a proximal MCA occlusion or mid-MCA occlusion, you have a severe reduction in vessel density, giving you the red mask. And then as you move progressively to the right, you have less severe reductions. So you can pick up high-grade stenosis from intracranial athero or more distal occlusions. Even if you're not in the LVO category, you can still pick this up from the software, which can be quite helpful. And these are softwares that will give you the answer in less than 2 minutes. Next, we have automated aspects. This is the only software in the US that has what's called a CAD approval, which rather than just notifying you, it is a computer-assisted diagnosis. But it still doesn't mean that it is the computer making the diagnosis alone. What we found as we did the studies that led to the FDA approval was that the performance is best when you combine the software and a physician. And basically with this software, you can take a typical neurologist or a general radiologist and get them to read aspect scores in the same accuracy that we see from a neuroradiologist. The software places the 10 aspects regions on the brain, and then it identifies the regions that are abnormal. It can be particularly helpful when you're at the border zone of the indication for thrombectomy. Obviously, in the 6-hour window, most guidelines still recommend an aspects 6 or more. There are some reasons why you might want to treat patients with aspects less than 6, and Raul mentioned some of those earlier. But here's an example of one where the software is helping you to identify those regions and identifying this patient as eligible for early window thrombectomy. There's a study from Munich showing that this could perform better than even interventional neuroradiologists, and then one from the GAME study published in Stroke, where we were able to show that the software was particularly good for picking up these very low aspect scores and outperformed typical clinical readers. Also, out of a plain CT, you can often get a hyperdense MCA identified by an automated software, and this can tell you if there's a high suspicion of an LVO. And what we've seen recently from this software is that about 60% of LVOs can actually be detected on a non-contrast CT. So if you're screening a large number of patients just with a plain CT, this can immediately identify, hey, this is somebody who really needs a CTA. Even if you weren't clinically highly suspicious of an LVO, we've identified that hyperdense vessel, and this patient again needs to move to the top of the list of attention because they may have a treatable large vessel occlusion. Basically, we're including that 20% of patients with a completed infarct. These patients do not benefit from reperfusion, and they dilute the treatment effect. That's why when you look at Extend IA or Swift Prime, you get a much more robust treatment effect. And Diffuse 3 and DON, by capturing the 50% of patients with favorable collaterals, also had a very robust treatment effect, in fact, larger than the treatment effect seen in many of the early window trials. This concept does not only hold for thrombectomy, but recent data shows that this concept holds very true for IV thrombolysis. This is an example of where we have been hitting our head for 2 decades against this curve. This is a curve of treatment benefit for IV thrombolysis over time. It's fading away as you get beyond 4.5 to 5 hours. But if you use imaging-based selection with CT perfusion, you can break that curve and show benefit all the way out to 9 hours. So this is a trial from the Extent, which Raul also mentioned, showing that we can successfully treat patients out to 9 hours. But the more important data is from this Lancet paper that Bruce Campbell published right after Extent, where he combined the data from ECAS-4 and the EPIPHET trial, which were all trials that had perfusion imaging and treated patients with IV thrombolysis between 4.5 and 9 hours. When you pool the patients, we see an even more robust benefit in patients who have a mismatch on CT perfusion. But the key finding is this part of the graph. These are the patients who did not have a mismatch. And most of these patients weren't ones with a big 4. They were ones who had a completed infarct. And once you complete the infarct, then reperfusing the patient can lead to harm. Let's take a look. Here's the death rate, 17% on TPA versus 4% on placebo. The rank in 5, 8% versus 4%. So when you mix a subgroup that's harmed with a subgroup that benefits, you dilute the treatment effect and you can wind up with a negative trial. And that's why it's taken so long to break the time barrier for IV TPA. Okay, CT perfusion has become very popular since Diffuse 3 and DON because it's part of the late window guidelines. So one of the things that we need to do is make sure that people understand how to interpret these images. So this is showing that the images can be automatically
Esto sería la tomografía con perfusión posterior al tratamiento y la resonancia magnética a las 48 horas. El paciente había ingresado con una fase de una hemiparesia derecha. Se ve ahí en FLAIR las lesiones residuales, pero bueno, había bajado puntualmente el NIH. ¿Okay? Final.
¿No tenés un control posterior? No.
6 años de seguimiento, donde casi no tenía lesiones en la resonancia. Acuérdense que a este nivel tenía lesiones puntualmente ahí a las 48 horas posoperatorias. Seguía obviamente con la oclusión distal, pero sin trastorno a este nivel de colaterales, ¿no? Ya eso progresó debido a la plasticidad neuronal que tenía con la poca edad que tenía él, ¿no?
Well, I'm not sure if you have the translation, Professor Albers, David. Have you heard the case?
Yes, we did. I tried to listen at first in Spanish, and that was a real test of my language abilities, but much better in English. Yeah, no, that's a fascinating case of neuroflow. Pedro, your group and others were large champions of the neuroflow device, and we've talked about this on many occasions, but an interesting tool because it intrigued many of us, because partial aortic occlusion, a remote endovascular approach, was able to change blood flow in the brain. Now, as much as it intrigued us, it also disturbed some of us that wanted to go up and treat the actual arterial lesion. The improvement in flow is something that mechanistically we debated, as you know, Pedro, for a long time. And rather than describing it as popping open collaterals, arterial collaterals, the soundest and the most logical argument is the elevation in blood volume. And that elevation in blood volume can facilitate flow in that region. So mechanistically, there's a lot more on the venous side that's important than on the arterial side. That being said, this is a dramatic case. My only question back would be, are you still using neuroflow? Do you still have it? Because it was limited, obviously, here. Most things ended after the Centis trial was done.
Well, as you know, we had some, but we are out now. I tried to convince many companies to start again with that product. We are having some, but unfortunately, we don't have more devices. Going to the Centis trial, I would like to know your opinion, both of you. What do you think that failed? What happened? I know you wrote some papers about David, but I think maybe we did some mistake during this trial.
No, I don't think there was any mistake. I mean, I think that Centis was the largest stroke trial, interventional stroke trial done at the time, randomized control trial. It was very successfully done, but this gets into the contentious point of this debate or topic, which is how was imaging used and how was the imaging ascertained? And I'll be the first to say that we've looked at the imaging post hoc in many different ways, and it still exists, but it wasn't done standardly. In a rigorous fashion. It was much more, it was somewhat done on an anecdotal basis, showing a series of cases one after the next. And I would actually argue that a systematic imaging evaluation, if it were possible to do Centis again with Greg's imaging, or Greg's favorite imaging, you would be able to make a lot more conclusions. Done today.
I mean, I think that's true for so many of our failed trials. As the Extend IV trial showed you, you can try and try and try without the right imaging, and you fail until you identify patients with salvageable tissue. The case that you showed clearly had a full hemisphere of salvageable tissue and did great. But it also brings up the point that even with how excited we are about our current tools, we're still only seeing good outcomes in 50% of the patients or 60% of the patients, which means there's a lot more for us to do, that we need to be able to preserve penumbra on the way in. We need to use the neuroprotective agents in that capacity or neuroprotective strategies so that when you get to the cath lab and get that clot out, you have salvageable tissue to reperfuse. In your case, you had somebody with good collaterals and you were able to help them. But that's how you get a trial done with a couple hundred patients rather than 1,000 patients. You get the right patients, and then afterwards, you can expand and try to push the frontiers, which is exactly what's happening now with thrombectomy. We fully believe that patients beyond who we enrolled in Diffuse 3 can benefit, and now the challenge is to figure out who they are and how best to identify them.
All right, okay. Thank you, both of you. Any comment, Profesor Vila?
Sí. Hace muchos años el profesor que era el jefe de neurología del Mass General siempre mostraba a un paciente que tenía los 4 vasos cerebrales, era chofer del Amtrak, tenía 4 vasos tapados y por la espinal anterior tenía la irrigación completa del cerebro. Y eso un poco fue enseñando que en realidad lo que muchos pacientes que vemos con defectos de perfusión es porque el cerebro falla, el sistema de colateralización falla. No vemos las personas que tienen un sistema de colateralización perfecto. Tal es así que nosotros hemos visto los preparados de corrosión cerebral vascular en Suiza, y cuando tiñen un vaso, gotean un vaso, se llena todo el cerebro, si las colaterales son buenas. Es decir, uno está tratando pacientes donde ya hay una falla en el sistema de colateralización. Por eso es que es tan difícil predecir la evolución, a tal punto que la idea del doctor Nogueira se contrapone a otras ideas donde dice todo lo que tiene menos de 6 horas hay que tratarlo. Independientemente si tiene mismatch, no tiene mismatch, si el infarto es grande, el infarto chico, esos pacientes andan mejor. Entonces, creo que el biomarcador del flujo cerebral ha llegado a tener ya un aporte tremendo para el conocimiento y el tratamiento de estos pacientes, pero necesitamos otro biomarcador, que no sea solamente el flujo. Sabemos que sin flujo el tejido no se recupera, pero con flujo a veces tampoco.
La idea tuya era buscar algún otro marcador.
Nosotros necesitamos un biomarcador especialmente que podamos disponer para valorar la energía del tejido, ya sea por el oxígeno, por la actividad mitocondrial o por la actividad del fósforo. Sé que lo que pedimos en el Carolinca, bobina. ¿Te acordás? Queremos la bobina de fósforo, que todos se hacían, miraban para otro lado a ver, no la podían hacer, no la han podido resolver. Pero la energía necesitamos porque el core está mal definido y hay otras estructuras como es la denaturalización proteica, que es temprana y es mucho más eficiente como marcador que la isquemia. Nosotros inferimos que un nivel de isquemia va a producir denaturalización proteica, pero a veces eso no hay una concordancia. Es decir, nos queda un camino muy lindo y un gran desafío para la búsqueda de otro biomarcador que ayude a comprender lo que no podemos.
Did you get the translation, guys?
Mejor.
Yep. Yes.
Okay.
Yeah, I think it's a very good point that it would be wonderful to have a perfect marker of ischemic core, which we don't have. I think the best one that we have that's widely available is diffusion imaging, where you see cytotoxic edema because you have energy failure. And what we've seen is that there's really quite limited permanent reversal of a diffusion lesion. We see a lot of transient reversal. When you raise the blood flow, you can get a transient increase in apparent diffusion coefficient. But when you really look closely at patients who have follow-up imaging beyond that time of transient reversal, that basic DWI with a low ADC is a very nice marker of core. So we can always refine it, but we prefer MRI at Stanford. But for the real world who's out there, you know, in community hospitals across the globe, we have to translate it to CT perfusion. So I think the closest that we can get at the moment is to be using very carefully done perfusion imagings with the appropriate thresholds.
I agree. I mean, the only other comment I'd make is that we have to be practical. We have to choose whether we're going to be practical or not. Whether we want to understand the exquisite science of what's happening at the cellular level, or we want to be able to make prompt, very fast decisions. And this is different in different types of strokes. So obviously when you have a large vessel occlusion, the best treatment in the majority of cases is going to be revascularization. So we want certain information out of the biomarkers, but as Raul argued, in certain scenarios, we don't want any biomarkers. We just want to be able to move forward and not waste any time. And I do agree with that. But I think there is a happy medium in between where, you know, as Greg was pointing out, that there's two dimensions. One is you can do the imaging quickly, and you're not relying on the imaging alone. On those markers alone, you're still there's still the element of bringing back the individual who's making those decisions.
One of the problems is we don't truly have the EKG for stroke yet. So if we had great biomarkers, and I know some are being developed from finger sticks that may be fantastic, that'd be really helpful. But we see plenty of stroke mimics. We see strokes that don't appear like a typical stroke, that you wouldn't be rushing that person off. But if you get the imaging and you see it's a stroke, then maybe you can treat them where they would have gone to the back of the line without the imaging. So I think that it is complicated, that our jobs are secure, that you need somebody with a detailed knowledge of vascular neurology to be assessing these patients so we can feed the right patients to somebody like Raul to do his procedure, but not send everybody to the cath lab. There's going to be so many false positives if you send everybody that you think has a stroke to the cath lab, and you're going to miss a bunch that have a stroke mimic or have a what we call a stroke chameleon, right? They don't really look like a stroke, but they are.
Okay, fascinating, guys, but we have to move on.
Okay,
thank you. Can we show you one case short, Selena?
Yes.
Just one. Okay. Give us a couple of seconds. We are very happy with Rapid. We just got it, and we are really happy with the communication, with the improvement of the software. So Selena is going to show you a case. Please, Selena.
Sí, pasamos de hace 10 años a ahora a tener toda la tecnología. Es una paciente de 45 años, hipertensa, tabaquista, que tenía tratamiento solamente valsartán y ingresó a la clínica a las 9:25 de la mañana con 4 horas 25 minutos de evolución, por lo tanto ya estaba fuera de la ventana terapéutica para tratamiento con fibrinóticos. Tenía un NIH de 24 puntos y en el tiempo de COVID cambiamos nuestro protocolo, siempre hacíamos resonancia y ahora empezamos a hacer tomografía, primero de tórax y después de cerebro. Así que a esta paciente, perdón, ahí está, le hicimos la tomografía de encéfalo,
si querés,
la cual tenía 3, le hicimos la perfusión y tenía un volumen de core isquémico de 137 mililitros. Acuérdense que la paciente tenía 45 años, o sea que, y menos de 6 horas de evolución, o sea que en cualquier protocolo estaría excluida de algún tratamiento. Le hicimos la angiotomografía que impresionaba tener una oclusión a nivel de la carótida interna. Por lo tanto, era una mujer con déficit neurológico focal, con menos de 6 horas de evolución, con un NIH alto y un volumen de core isquémico elevado. Decidimos tratarla, o por lo menos hacer la angiografía digital, el cual evidenciaba, acá estaba lentificado, pero se lentificaba a nivel de la carótida y impresionaba tener una placa. Y arriba tenía un trombo a nivel de M1 proximal. Por lo tanto, se le decidió hacer trombectomía. Le hicimos trombectomía mecánica. Y la paciente evolucionó favorablemente. Dentro del estudio para continuar el protocolo del mecanismo del stroke, nosotros hacemos primero una tomografía de tórax simple, como dije antes, y en la tomografía de tórax simple, 5 minutos post-angiografía, se evidenció ya un infarto de cara anterior que se pudo comprobar con la angio-TC cardíaca. Esta es la tomografía de ingreso entonces, y esta es la tomografía, la resonancia, control. La paciente ingresó con un NIH de 24, ¿sí? Y post tratamiento tenía un NIH de 9 y se externó con un NIH de 3 puntos. La paciente hoy en día solamente quedó con unas anomias y una fascia leve, pero la paciente tiene un ranking de 1, un ranking modificado de 1.
It's really remarkable how well a patient can do without one hemisphere of the brain. It certainly attests to the fact that young patients sometimes can recover much better than we think. And this is the point of ongoing trials. As I mentioned, we certainly believe, and we treat patients with cores bigger than 70 at Stanford as well, particularly younger patients. We like to look where the salvageable tissue is. Maybe you salvage some of the motor strip. I think that may be one of the key areas where there was mismatch. But the important thing that is happening is randomized trials. The SELECT trial is requiring CT perfusion. Somebody like this would be randomized, so we can see how much better they do with thrombectomy than control. And there are several low aspects trials that this patient would have been eligible for. So no question, patients like this can benefit. This patient did remarkably well with such a huge infarct. Very fortunate. Oftentimes we don't see that type of incredible clinical recovery. I don't think you salvaged any of the initial core, but again, some of the penumbra that was present looks like it had some critical tissue, and then probably the other hemisphere played a role in such an excellent recovery as well in this young patient.
Well, yeah, I would chime in and underscore the role of age. Being young is far better in terms of the recovery and outcome. The other comment is this is posing a great challenge now as we deal with COVID on a daily basis. The question about relatively younger patients that are coming in with these large extensive thromboses. And we know that they have multi-organ complications. They're very sick. And the questions about do we treat or not have come up for thrombectomy. And a lot of debate about that because outcomes can be very poor. On the other hand, even the smallest potential of a good outcome in a young patient means a lot.
Well, thank you very much. That was just the introduction for the next topic, which will be COVID and stroke. So thank you for your help. I know how valuable is your time, so thank you again. Hope you see you next year in Buenos Aires.
Okay.
With the Malbec. Thank you very much. Gracias. Bueno,
great conference.
excelente, Celina, muy bueno. Les pido que se queden y continuamos ya porque estamos, por supuesto, un poco atrasados con el próximo bloque. El próximo bloque es stroke y COVID. Tenemos distinguidos participantes. El doctor Paul Bogal de Inglaterra será el primero de ellos. Nos va a ilustrar acerca de stroke y COVID. Paul, I know probably you are there. We are just about with the timing. So if you are there, Paul Bogal es neuroradiólogo intervencionista del Royal London Hospital en Londres. Así que, if you are there, please go ahead.
Hello, my name is Paul Bogle. I'm a consultant interventional neuroradiologist and a research lead over at the Royal London Hospital. I've been asked to give a short presentation on some of my thoughts around stroke and COVID-19 infection by Professor Lilik and the team over in Buenos Aires. So I'd like to start by just talking about a few of the studies that have been published on the disease process, what we were seeing on both the arterial and venous sides. Then I'd like to talk about what I think is the underlying pathophysiology of what's occurring, and finally offer up a few suggestions on where we might focus our efforts on the disease. So as everyone knows, this is a pandemic the likes of which no living person has seen before, realistically. Over 60 million cases so far worldwide and over 1.5 million deaths, with no obvious let-up in sight. So just briefly, it's similar. The SARS coronavirus 2 is essentially similar to SARS and MERS. There is a spike protein on the coronavirus that facilitates entry via the ACE2 receptor into human cells with association from other transmembrane proteases. So I think when we're talking about stroke, it's important to recognize that the majority of the strokes that we are seeing are essentially thrombotic rather than hemorrhagic. But there's disease affecting both the arterial and the venous sides to the circulation. So there have been reports of significantly higher rates of stroke associated with COVID-19 relative to seasonal flu. In addition to this, you've got several case series of mechanical thrombectomy, et cetera, that demonstrate perhaps that the clots are a little bit more friable and easier to fragment. The pattern of the arterial strokes is different to what we would expect, often multiple emboli, multiple territories. And the severity of the stroke is worse than we would expect for the level of clot burden seen. So the Parisian group compared their results to the same time period in 2019, and they showed that the patients coming in with large vessel occlusions that were COVID positive were generally younger. They had larger infarct core volumes. They had more severe strokes with a lower clot burden, and as may be expected from what I've just said, higher levels of mortality. And other groups have essentially shown something very similar with bizarre clot locations and associated clots, such as subocclusive disease affecting the subclavian arteries in association with MCA occlusions, etc. Other things that have been seen is essentially, normal-looking arteries, but with large floating thrombi in the ICA, in the CCA, in the ECA. People were seeing thrombus within the heart. So just thrombus pretty much everywhere in bizarre places for what otherwise appeared to be healthy vessels. On the venous side, people have been reporting cerebral venous sinus thrombosis and cortical vein thrombosis in young patients with no obvious underlying cause or reason. And often these patients are coming in with associated hemorrhages because there's large degrees of sinus thrombosis seen. So what does this tell us so far? Well, we're seeing thrombosis on both the arterial and venous sides of the circulation, which means that both high and low shear stress states are involved. And it seems to be, although I haven't mentioned this, but several of the studies, as has generally been reported, demonstrate that there's a link between hypertension, diabetes, et cetera, So how can we begin to try and explain this? So what I want to do now is go back to the basics of clot formation and start right at essentially the very beginning. So von Willebrand factor is a molecule that is essential to hemostasis, and it's produced and stored in the endothelial cells and megakaryocytes only. During its biosynthesis, it undergoes significant multimerization as well as post-translational processing, and it's packaged within what are called the Weibel Palade bodies. There are differences in the synthesis of the von Willebrand factor within the different vascular beds, with the lung and brain expressing higher levels compared to, for example, the similar sized vessels in the liver or kidney. The stored von Willebrand factor multimers are enriched into what's called ultra-large von Willebrand factor, which is very prothrombotic, and that's released upon stimulation of the endothelial cells and stimulation of the platelets. It's basically ultra-large von Willebrand factor. It consists of hundreds of single or small von Willebrand factor monomers joined together. And the biological function of von Willebrand factor depends largely on the size of its multimer. So the ultra-large von Willebrand factor multimers, the longest molecules are the most biologically active in inducing platelet aggregation. So that's the prothrombotic nature of it. Obviously, the body has control mechanisms to limit this, otherwise we would thrombose off all of our vessels very quickly. And the mechanism that controls that is a cleaving protease called ADAMTS13, and that basically cleaves von Willebrand factor at the A2 domain and chops up the large multimers into smaller, less biologically active multimers that are then excreted by the body. So when ultra-large von Willebrand factor is released, it's sort of curled up in a ball. Part of it will stay adhered to the endothelial cell, and then it will unfurl with the flow, basically, on both the arterial and the venous sides. And as it uncurls, as it unfolds due to the blood flow, the different binding sites, so the binding site for platelets and the cleavage site for ADAMTS13 are exposed, hence allowing, for example, the enzyme to come and chop up the molecule and make into smaller multimers, and also allowing platelets to bind. So these ultra-large von Willebrand factor molecules can also self-associate, so you can have one end-on-end or intertwined to form long strings or rope-like structures and even nets that allow platelets to bind and leukocytes to translocate. And this picture just demonstrates what I've just described. So you're seeing end-to-end attachment of the strings. You're seeing intertwined strings up in the top left. And then the scissors represent ADAMTS13 enzyme. And you can see the small circles on the von Willebrand factor string are representing the different A1, A2, and A3 domains for platelet binding and enzyme cleavage. And here's just a fluorescent labeled study showing in the top a very long string with fluorescent labeled platelets bound to it that's actually over 3 millimeters long under flow conditions. In B, you're seeing a similar platelet string, which then dissolves after infusion of ADAMTS13 over the surface of it. And here, again, just as I sort of aforementioned, the von Willebrand factor molecules can form rope-like structures or sort of a hammock or a spider's web type structure that is even more biologically active and can capture platelets better. Okay, the platelet binding site is called it's in the A1 domain, and it's called the GP1B receptor. As I mentioned earlier, this is normally hidden when the molecule is curled up in its globular form, but with shear stress, the molecule unfolds, the binding site is exposed, so platelets can bind via the GP1B receptor to von Willebrand factor. After binding, this switches the conformation of the GP2B3A receptor into its active conformation, which then means platelet binding can occur, further platelet activation can occur, and then you have essentially the whole cascade of platelet-rich plug forming. Okay, why have I mentioned this? Well, von Willebrand factor is a key component in both venous thrombosis as well as arterial thrombosis, and perhaps most importantly is it's very, very, very important for high shear stress states. Okay, so now turning our attention to what's called an endotheliopathy. So an endotheliopathy is inflammation of the endothelium. And this results from any cause, from trauma to sepsis to ARDS, and as I will show, secondary to COVID-19 infection. This results in the release of von Willebrand factor. And there's an excellent review recently published by Sean Gu et al. This picture on the left simply demonstrates that the epithelium of the airspace, the alveolar airspace, shares a common basement membrane with the endothelium of the lung capillaries. Therefore, any damage to one results in damage to the other. You can't have damage to one without damage to the other. Okay, so have we seen evidence of an endotheliopathy in COVID-19? Yes, we have. There is autopsy data to suggest a widespread endotheliopathy that affects virtually every vascular bed of the body. And in one of the studies, the authors reported most of the small vessels appeared congested. Okay, well, we've talked about von Willebrand factor release, how this is very prothrombotic, how platelets could form. So, how platelet plugs could form. So have we seen evidence of microthrombosis as well as the endotheliopathy in COVID? And the answer is, again, yes. So numerous studies have shown platelet-rich microthrombi in the lungs of patients with COVID-19, as well as elsewhere, actually. And in the recent study of Karsana et al., microthrombi were seen in vessels smaller than 1 millimeter in close to 90% of cases. Okay. Have we seen then evidence of deranged von Willebrand factor in patients with COVID-19? Again, the answer is emphatically yes. The first case that I'm aware of was by Escher et al., who was published a case report that showed the von Willebrand factor antigen levels were 500% of normal. So a huge, massive release of von Willebrand factor. The excellent case series published from the group in New York by Goshua again showed massive spikes in von Willebrand factor levels. And the von Willebrand factor level was associated with disease severity. So the higher your von Willebrand factor antigen level, the more severe your disease. In Europe, the French group published by Rauch et al. Looked at the prognosis and progression of patients with COVID-19 in relationship to their admission von Willebrand factor. And they showed that on admission to the emergency department and to hospital, you could predict which patients essentially were going to require more intensive oxygenation and more intense levels of medical management based on your von Willebrand factor levels, as well as associated things like factor VIII. In the small population that attended hospital but had normal levels of von Willebrand factor, those patients essentially did not require supplemental oxygen or any real medical management. In Manchester, Kieran South and his group published are in the process of publishing data that suggests there's a 6-fold increase in the levels of ultra-large von Willebrand factor for patients with COVID-19 compared to healthy controls. Okay, so we've shown a spike in the von Willebrand factor, we've shown microthrombosis, we've shown endotheliopathy. What about the regulatory components? What about ADAMTS13, the enzyme that breaks down the ultra-large von Willebrand factor? Okay, again, studies are now showing some mixed results, but certainly some patients have significantly dropped off levels of the cleaving protease. With Ladecue et al. From Brighton demonstrating a 50% reduction. And they said that they think that this is at least in part related to consumption of the enzyme because of the surge in the release of the von Willebrand factor. Very recently, a group out of Italy have published effectively saying that the von Willebrand factor to ADAMTS13 ratio is very strongly correlated to disease severity, which obviously makes sense given everything that I've said. And I think one of the perhaps most important things to recall or to remember is that this pathway, von Willebrand factor and ADAMTS13, this is important in disease pre-COVID-19. So if you have an abnormal ratio, a high von Willebrand factor to ADAMTS13 level, and you have large vessel ischemic stroke, you are more likely to have a poor outcome, irrespective of whether you have COVID-19 or not. So realistically, we need to be targeting our thinking, our efforts towards this axis. So how can we do this? On the right here, we have a flow diagram that's slightly adapted from one that I published several months ago. But essentially, it documents the steps that I have discussed. So where can we potentially intervene? We can stop platelets binding to the GP1B receptor on von Willebrand factor. There's a couple of drugs. Caplazizumab is produced by Sanofi and is in human use. And that inhibits binding of the platelets to von Willebrand factor. And Fibotide does the same thing. We could alternatively assist the body in breaking down von Willebrand factor. So we could give recombinant ADAMTS13 to patients, and we could base that on their von Willebrand factor ADAMTS13 ratios when they come into hospital. As I said earlier, the GP1B receptor binding results in activation of the GP2B3A receptor. Therefore, it makes more sense to give GP2B3A antagonists than, for example, aspirin to inhibit platelet-platelet interactions. Because of the nature of this talk and the amount of limited time, there are many things that I've not been able to discuss. Thromboinflammation, the associated effect that this pathway has on leukocytes. I haven't been able to discuss how von Willebrand factor response essentially is linked to your blood group, and this is why people with non-O blood groups, so type A, type B, blood groups are at increased risk, and this comes back down to the fact that your interaction with von Willebrand factor varies, and also that in longitudinal studies, your von Willebrand factor and ADAMTS13 ratio are associated with increased risk or decreased risk, depending on which way your ratio swings of cardiovascular disease in general. These are just some of the papers which discuss some of those topics that I've mentioned. So I think there's lots to do. I think it's really imperative that we start looking at this problem in our patients. I think we need to start looking at the von Willebrand factor and ADAMTS13 ratio in patients coming in with strokes. I think we need to remove clots and send them for histopathological analysis, but we need to be looking for the amount of von Willebrand factor within those clots. Don't forget that these clots could, for example, form within the heart or elsewhere and still appear embolic. But this is the likely pathway by which these these clots are actually forming. I think partly we could maybe explain the worse outcome and the larger strokes we are seeing with relatively low clot burdens down to potentially a micro thrombosis of the peel vessels. So are we getting a macro plus micro thrombosis and loss of, or at least decrease in your potential peel collateral supply? I think we should strongly consider use of GP1B antagonists in these patients, as well as considering advanced antiplatelet medication. So should we be putting people on GP2B3A antagonists perhaps earlier than we would normally consider if someone has come in with a stroke? I'd just like to invite everyone watching to Brain Conference, which will be running next week. I'm the lead organizer. It's free to attend, and there are 28 CPD points available. Lots of great speakers from around the world, and I really hope that you can attend. And I'd like to thank Professor Lilik and the fabulous Buenos Aires team for inviting me to speak. It's been a real whistle-stop presentation through some of my thinking around COVID-19 and strokes, and I hope you've enjoyed it. If you have any questions, please feel free to email me at the email address below. Thank you.
Well, thank you very much, Paul. I think you get around a very specific points on the relationship between stroke and COVID. I know you are very passionate about it, so we are looking forward to meet you in the BART meeting in December. I think you made really a good point. Also, it's a good point to consider the 2GB3A, I think, will play a specific role in the treatment of COVID and stroke. So thank you for pointing that. We are going to go back to this. But certainly to keep on the schedule, I think the next issue on COVID and stroke will be, well, guys, what happened in the early reports from the New York people, Mount Sinai people special, that emphasized that what important was the venous thrombosis. So I'd be delighted to focus that on venous thrombosis. Yo decía, muchachos, Bogal realmente puso el foco muchísimo en la relación de las microtrombosis von Willebrand, como ustedes escucharon, con stroke. Y realmente creo que apuntó muy precozmente a esto, justo cuando disparaban los primeros reportes de la gente de Nueva York, del Mount Sinai, que hablaban de la mayor incidencia de trombosis en gente joven, trombectomías en gente joven y trombosis venosas en gente joven. Así que al mismo tiempo escuché una charla fantástica de Alberto García de la Fuente, ustedes saben que es de Monterrey, y él justamente dio una charla de trombosis venosa profunda, así que nos encantaría ahora escucharte, Alberto, y ver qué opinas de esto y que nos muestres un poco esa charla. Creo que es muy específica. Alberto trabaja en el Centro Médico Christus Muguerza. Cuando hablo de Alberto, hablo del doctor García de la Fuente, de Monterrey, México. Trabaja también, es profesor de la Universidad Autónoma de Nuevo León, en Monterrey, México. Así que gracias por estar con nosotros, Alberto, y estamos listos para escucharte. Tenemos un distinguido panel, acá intervencionistas, neurólogos, esperando por tu charla. Adelante, por favor.
Muy buenas tardes. Es un honor para mí estar en este tan prestigiado congreso organizado por el doctor Pedro Lilik, al cual agradezco muchísimo la amabilidad de haberme invitado a este congreso. He modificado un poquito esta plática de acuerdo con cosas y circunstancias que pues ocurren en nuestro medio y que trabajamos principalmente con problemas vasculares a los cuales enfrentamos. Y bueno, pues la patología venosa, la cual se considera relativamente poco común, ocasiona alteraciones neurológicas serias que pueden ser potencialmente reversibles y que pueden, si se diagnostican a tiempo, pues resolverse completamente y evitar las consecuencias a veces fatales que ocasionan. Los estudios de imagen son esenciales para el diagnóstico y tratamiento. Y los síntomas más importantes, sobre todo el dolor de cabeza, es algo muy frecuente, aunque muchas mujeres lo utilizan.
Tranquilos, no pasa nada.
Lo utilizan para alguna disculpa, pero sí hay que tener mucha atención, sobre todo en estos tiempos donde el COVID está ocasionando tantos casos de trombosis que como estamos viendo. Hay otras alteraciones neurológicas que pueden presentarse, como alteraciones de la conciencia, visión borrosa o crisis convulsivas. Los signos más frecuentes que encontramos son el papiledema, aunque puede presentarse un déficit neurológico focal, parálisis de algún par craneal o alteración de los movimientos oculares. Los signos que encontramos en imagen, pues el más frecuente de todos es el signo delta o el signo del triángulo vacío, aunque podemos encontrar otros como el signo de la cuerda, la presencia de venas medulares, o los signos de hiperdensidad o hiperintensidad tanto en los senos transversos como en la vena yugular y algunas otras venas del organismo. Pueden presentarse en algunos casos infartos corticales que pueden ser uni o bilaterales, y el 40% de los casos presentan hemorragia cerebral. La incidencia anual en Estados Unidos es de 2 a 7 casos por millón de habitantes. Era subestimado, aunque actualmente con la tecnología reciente es mucho más fácil diagnosticar cada vez más trombosis más finas de vasos más pequeños. La exactitud y el tiempo de diagnóstico es crucial para efectuar una terapia rápida y reducir el riesgo de las complicaciones y secuelas, como habíamos dicho. Las causas de las trombosis venosas cerebrales pueden ser locales, como disminución en el flujo, ocasionado por muchas cosas, desde disminución del flujo por hipertrofia de los vellosidades de Pacchioni, trauma cerebral, mastoiditis, que puede ser también por alguna infección de otro seno, como el frontal o el seno esfenoidal, invasión neoplásica o compresión, y algunos otros factores sistémicos como alteraciones de las proteínas de la coagulación, pero sobre todo lo que incrementa 6 veces el riesgo de trombosis, sobre todo en mujeres, es el periparto en el puerperio, por ejemplo, el uso de anticonceptivos o de restablecimiento hormonal. Hay múltiples causas a las cuales añadimos el COVID recientemente como una causa importante de trombosis venosa en toda la economía. Y los métodos de imagen que utilizamos, pues bueno, podemos usar la tomografía, que puede ser simple o con contraste, y la venografía podemos hacerlo tanto por resonancia como por tomografía, y pues la resonancia magnética en todas sus secuencias, y sobre todo pues la angiografía por su extracción digital cuando nos disponemos a hacer alguna intervención. Y el sitio más frecuente de las trombosis en todos los pacientes, pues habitualmente es el seno longitudinal superior, seguido por el seno transverso, aunque podemos tener el sistema venoso profundo, el cual es muy importante para el tratamiento. Hay cambios en la imagen que pueden ser secundarios a edema citotóxico, edema vasogénico, a hemorragia cerebral. Y bueno, ¿qué encontramos ocasionalmente? Por ejemplo, en esta tomografía, hiperdensidad del seno transverso, al mismo tiempo en esta imagen coronal, hiperdensidad del seno longitudinal superior de la vena de Galeno, aquí la vena basal y la vena de Galeno hiperdensas por trombosis. Los pacientes pueden tener hemorragia y edema perihemorrágico secundario a trombosis, que en este caso es unilateral, pero en este otro pues es bilateral, y pues bueno, esto ya es un poquito tardío, ya a veces aquí no logramos resolver todas las secuelas, aunque no está contraindicado en estos casos el uso de trombolíticos locales. La resonancia magnética pues tiene diferentes intensidades de acuerdo al metabolismo de la hemoglobina. Lo que más frecuente nos encontramos es los pacientes con resonancia magnética en un tiempo de un estadio subagudo, que va de los 6 a los 15 días, y aquí tenemos hiperintensidad tanto en T1 como en T2. Y aquí tenemos algunos casos de trombosis venosa, como en este caso, que aquí vemos llenado, es una resonancia con contraste, falta aquí el seno longitudinal superior en estas imágenes, aunque vemos acá sí el llenado de ambos senos transversos. En el T2 pues es hipointensa la señal, es un coágulo agudo, y áreas que pueden presentar hemorragia, por ejemplo, como en este caso. La difusión presenta alteraciones también, y sobre todo el flare aquí en este T2, estas imágenes bilaterales que nos demuestran hiperintensidad. También la espectroscopía con incremento aquí discreto en el lactato, como vemos aquí en esta imagen, cuando tenemos aquí pues trombosis del seno longitudinal superior, algunas imágenes que muestran hiperintensidad y otras imágenes con el llenado negativo aquí del seno y pues otro tipo de imágenes. También podemos ver cambios en todo el eje del seno longitudinal superior y el sistema venoso profundo, con alteración aquí en el angioresonancia, un incremento importante de la circulación colateral, lo cual es un patrón común en este tipo de pacientes. Y bueno, todo esto viene a alterar también los patrones metabólicos del cerebro, o sea, si disminuimos la salida del flujo venoso, pues también afectamos el líquido cefalorraquídeo y también el flujo del sistema linfático cerebral con alteraciones metabólicas en esto que repercuten de alguna forma, a veces precipitado por alguna hipertrofia de las vellosidades de Pacchioni, que disminuyen ya de por sí el flujo de los senos, lo hacen más lento y promueven la trombosis. En los adultos, aquí hablando un poquito del sistema venoso cerebral, pues todos van a ir, todo el drenaje del sistema venoso profundo cerebral, tanto de la parte periventricular como de la parte cisternal, van por un lado a la vena cerebral interna, del periventricular, y el cisternal a la vena basal de Rosenthal. Entonces, voy a presentarles algunos casos, por ejemplo, este caso de una paciente que pues había iniciado con algunos periodos de olvidos, alteraciones de la memoria, pero sin embargo les llamó la atención pues que la paciente continuamente presentaba cefalea, y hay algunas áreas de hiperintensidad, sobre todo en el drenaje del sistema venoso profundo cerebral. Entonces, lo que vimos nosotros aquí, el sistema venoso profundo en este caso drenaba básicamente al seno transverso izquierdo, y vimos este defecto de llenado que se presentaba hacia el seno transverso izquierdo. Aquí lo estamos viendo en esta imagen coronal también, y en esta imagen axial también vemos esta imagen que se presenta aquí, que pensamos nosotros que afectaba el drenaje, sobre todo de todo el sistema venoso profundo, y podría ser causa de todas esas imágenes que estábamos viendo. El angioresonancia pues demuestra esto. El drenaje aquí se iba hacia esta parte, el seno transverso izquierdo adelgazado, y en esta paciente solamente se instauró un tratamiento anticoagulante oral asociado con algunos antiagregantes, y esto fue suficiente para quitarle el dolor de cabeza y mejorar la memoria de la paciente. No tenemos un estudio neuropsicológico de la paciente, esto es una evaluación clínica pura propiamente, pero bueno, en lo sucesivo tendremos que evaluar mejor estos pacientes para ver la respuesta, no a ningún otro medicamento, sino a los anticoagulantes. Y aquí otro paciente también que, igual, un paciente con estado confusional, empezó con inatención, después tenía vértigo también, después somnolencia hasta llegar al estupor, y pues al hacer el estudio de imagen encontramos aquí en la difusión algunas áreas de restricción de la difusión en diferentes partes, sobre todo la correspondiente al drenaje aquí en el flare, hiperintensidad, en la correspondencia del drenaje venoso profundo, periventricular, aquí en partes más altas, la restricción, la difusión aguda, por supuesto, y el angioresonancia arterial normal. Sin embargo, en el angioresonancia, aquí todo el sistema venoso profundo drenando a el seno transverso izquierdo con un área de estenosis en la salida, sobre todo el seno recto que corroboramos aquí. Igual, esta paciente solamente tuvo tratamiento médico con anticoagulantes y eso fue suficiente para observar mejoría en la paciente. Ahora les presento este otro paciente que sí empieza con vértigo, dolor de cabeza, tenía pues 2 días de evolución, después a semiparesia, después pérdida de la conciencia y finalmente es intubado. Aquí en la difusión hay pues algo de restricción, en la difusión sobre todo hacia el tálamo del lado izquierdo, una discreta restricción de la difusión también aquí en los ganglios basales alrededor de los ventrículos. Sin embargo, aquí en el FLAIR ya vemos cambio en la intensidad, sobre todo en el territorio correspondiente al sistema venoso profundo, cambios aquí a nivel de la vena de galeno, y más arriba encontramos mayor hiperintensidad aquí periventricular a consecuencia de isquemia por afección del sistema venoso profundo. Vemos aquí lo mismo en la imagen coronal, la alteración de la intensidad, y aquí está isointensidad aquí en el seno recto. Y cuando hacemos la angiografía, pues encontramos ausencia del seno recto y de la vena de galeno, de la mayor parte del sistema venoso profundo. Entonces, pues hicimos cateterismo aquí, primero el seno transverso, ya observando algunos coágulos, vamos al seno recto y a la vena de galeno, ahí instauramos un bolo de trombolítico, tenecteplase, y empezamos a hacer algunas maniobras mecánicas y continuamos ahí tratando de repermeabilizar esto con algo de aspiración también, hasta que tuvimos ya cierto flujo y entonces dejamos una infusión continua. Y al día siguiente, cuando hacemos la angiotomografía venosa, pues ya nos encontramos con la permeabilidad de todo el seno recto, la presa de erófilo y el seno transverso. En este mismo momento, pues ya tenemos algunas transformación hemorrágica aquí del acumen septi, de la cabeza del núcleo caudado, sangrado intraventricular. 7 días más tarde, la resonancia ya nos muestra resolución parcial de la transformación hemorrágica. El paciente fue mejorando, de tal forma que llegó a ser completamente independiente gracias a esta intervención, pues más o menos temprana, que logró sacarlo adelante, ¿verdad? Ya en un cuadro que de todas, de haber continuado así, pues es mortal, ¿verdad? Y aquí les presento otro paciente también que tenía 3 horas de evolución, había empezado después de un estornudo bastante fuerte, con cefalea, náusea, vómito, ataxia y disfagia. Y en la difusión encontramos aquí restricción de la difusión en la parte posterior lateral del bulbo, y con esto pensamos que era algo arterial, pensamos que la arteria cerebelosa posterior inferior estaba afectada, y cuando fuimos a hacer la angiografía pues la encontramos normal. Entonces pues aquí nos llamó algo en el seno transverso, y aquí les muestro la angiografía. Como tenemos aquí pues una estasis con reflujo, acá mejora el flujo del lado izquierdo, pero aquí tenemos estasis con unas imágenes que nos parecían coágulos aquí. Entonces, pues fuimos a la parte venosa y empezamos a hacer una maniobra trombolítica, instilamos un bolo de medicamento, maniobras mecánicas, por supuesto. La sintomatología se dio inmediatamente y dejamos una infusión 24 horas, después volvimos, no había todavía flujo de la vena yugular, hicimos aquí una angioplastía de la yugular y finalmente restablecimos completamente el flujo, el paciente quedó finalmente asintomático. Y aquí les presento otro caso también interesante de una niña, una joven de 15 años que tenía historia de paraparesia de 2 días y pues no encontrábamos nada importante, entonces pues no sabíamos por qué la paraparesia, que ya era prácticamente paraplegia de la muchachita. Entonces hicimos una angiografía de la arteria espinal anterior y lo que nos llamó la atención, la arteria pero era perfectamente normal, era que había estasis en la arteria y retraso en el flujo de la vena espinal anterior. Entonces cuando hicimos la angiografía pues encontramos aquí algo de estancamiento en el flujo de la arteria espinal anterior y pues retraso o estasis también en la fase venosa que llegaba pues hasta más de 17 segundos. Tuvimos que continuar aquí en otra secuencia con la parte venosa. Después de la trombolisis aquí fue suficiente con 15 miligramos de dactilice para hacer que llegara perfectamente, que se restableciera completamente la circulación con una un llenado de la vena espinal anterior en 7 segundos. Les presento otra mujer que tenía 40 años de edad, con cefalea intensa, papiledema, y había tenido crisis convulsivas, y lo que encontramos fue esta edema con algo de hemorragia en el lóbulo parietal derecho, y cuando hacemos angioresonancia, pues vemos aquí falta de llenado del seno longitudinal superior, algo de incremento en la circulación venosa colateral, falta de los senos transversos, aquí vemos el signo delta en el seno longitudinal superior, y también este defecto de llenado en la vena yugular derecha. Cuando fuimos al seno, pues encontramos todos estos trombos, también aquí el seno longitudinal, llegamos finalmente a la parte distal, hicimos trombolisis, también algo de aspiración y maniobras mecánicas, y dejamos una infusión continua que logró, pues, hacer permeable la mayor parte del sistema venoso. Esta es una imagen de un año después, donde ya vemos hemosiderina y con, pues, más o menos buena imagen de la corteza cerebral. La paciente está intacta, está íntegra, y el angioresonancia de un año después, pues con permeabilidad del seno longitudinal, seno transverso y la vena yugular contraria también. Y otro paciente de 48 años de edad, igual, la misma sintomatología, pues con una trombosis difusa de todo el sistema venoso cerebral. Entonces, lo mismo, hicimos un bolo de infusión, dejamos una infusión continua desde la parte más rostral del seno longitudinal superior, y finalmente pues ya encontramos permeabilidad en el estudio de control, que logró resolver el problema completamente. Y aquí les presento finalmente otro paciente de 75 años de edad también, que empezó con vértigo severo, tinnitus, confusión, y bueno, cuando llegamos fuimos por el lado derecho, había alguna circulación colateral hacia la vena yugular del lado izquierdo. Cuando fuimos al tronco venoso brachiocefálico izquierdo, estaba completamente coagulado, no llenaba la vena yugular. Hicimos maniobras de aspiración, utilizamos un dispositivo de angioaspiración, y logramos pues permeabilizar aquí durante todavía la utilización del aspirex, y finalmente la restitución del flujo de la vena yugular, y las imágenes de control ya con mejor permeabilidad de todo el sistema venoso en la fosa posterior y de la vena yugular. Y pues finalmente la trombosis venosa cerebral pues es una entidad multifactorial que puede, por supuesto, poner en riesgo la vida, y presenta un amplio aspecto de manifestaciones clínicas, y sus principales causas son distintas en países industrializados y en países en vías de desarrollo. Y el mejor pronóstico se obtiene pues mediante una adecuada evaluación y una pronta intervención. Muchas gracias.
Bueno, fantástico, Alberto. Realmente ya conocemos el problema, no tenemos los fantásticos ejemplos que nos mostraste. La verdad que estábamos charlando con los neurólogos. ¿Qué es lo que pasa si está subdiagnosticada las trombosis venosas en nuestro país? ¿Qué opina Juan?
En realidad subdiagnosticado es difícil. A veces es real que el paciente da vuelta por consultorios por un cuadro de cefalea hasta que desarrolla todo el cortejo sintomático, pero es difícil creer que pase mucho tiempo sin llegar a que se llegue a diagnosticar. Lo que pasa es que la incidencia, como nos mostraba el doctor, realmente es baja, ¿no? Menos de 10 casos por millón. Hace poco presentamos de la Sociedad Neurológica un registro de varios centros del país y andábamos más o menos por esa incidencia. El tema sin duda es difícil, y muchos de los pacientes tal vez no nos llegan a nosotros por referencia de lo endovascular, pero se ven.
Alberto, ahora en época de COVID, ¿viste aumentar específicamente el número, el N de trombosis venosas cerebrales? ¿Es tu experiencia también?
Sí, hemos visto eso con mucha frecuencia, pero nosotros hemos visto una entidad que ha tenido mucho, o quizá no la hemos tomado muy en cuenta, que es el vértigo, y eso nosotros hemos trabajado mucho con los otorrinos y los neurólogos, sobre todo empezamos con los otorrinos, porque ellos ven pacientes que, pues es un juego de voleibol entre los neurólogos y ellos, pacientes con vértigo, cefalea, tinnitus, etcétera, que siempre están yendo de un lugar a otro, y hemos encontrado en ellos con mucha frecuencia estenosis, sobre todo de los senos transversos. La mayor parte de estos pacientes, cuando reciben un tratamiento anticoagulante, tienen mejoría importante. Eso lo hemos logrado constatar, aunque no hemos hecho un estudio estadístico de esto. Sí, simplemente con el hecho de solo dar anticoagulantes y quitamos en parte los medicamentos antivertiginosos y los analgésicos, y con eso se resuelven los problemas. Y en algunos pacientes que no responden al tratamiento médico, hemos decidido hacer pues un tratamiento endovascular, y también tiene una mejoría inmediata. Entonces, pues yo creo que por esa parte, por ese lado, sí estamos subdiagnosticando las trombosis venosas, que pueden ser pues aceleradas por otras patologías, sobre todo la hipertrofia de las vellosidades de Pacquiao. Y sí, en este momento, como dice el doctor Lilik, sí hemos visto muy incrementada la incidencia de efectos trombóticos asociados al COVID.
Gracias, Alberto. Hablando de subdiagnosticada, quizás una de las cosas que también que tiene que ver con las enfermedades venosas estemos subdiagnosticadas son todo lo que tiene que ver con la hipertensión venosa idiopática, pequeños ventrículos, ¿no? ¿No les parece a ustedes también que eso pasa? Por suerte tenemos gente de la Clínica Mayo con nosotros, tenemos al doctor Wojciech Wijiński, que es profesor asociado de radiología y neurocirugía, es consultor debe tener bastante frío ahora en Rochester, pero ya debe estar con nosotros, así que el doctor nos va a hablar acerca de la angioplastia del lado venosa en la hipertensión venosa idiopática. ¿Qué les parece? ¿Lo escuchamos? Gracias, doctor. Please go ahead, Wallet. We are ready.
Hello,
for
my
you.
name is Walid Ranjikji, and today I'll be talking about stent therapy for idiopathic intracranial hypertension, highlighting our multidisciplinary approach for treatment of this disease at the Mayo Clinic. Here are my financial disclosures. So first, just a little brief overview of the epidemiology and natural history of IIH. So the predominant risk factors for idiopathic intracranial hypertension include female gender, obesity, and being of childbearing age. So the typical patient of idiopathic intracranial hypertension is a woman that's obese between the ages of 20 and 45 years old. And basically, there's about a 4 to 5-fold increase in the prevalence of IIH among obese patients when compared to patients with a normal BMI. Regarding the natural history of this disease, it's important to point out that we're not just treating headache here. Patients with IIH have about a 20% incidence of significant permanent vision loss. The patients do have headache though, and essentially, with the severe nature of their headaches, they are known to have a poorer quality of life as reported by a number of studies. Regarding diagnostic criteria, there's a few different criteria out there. The classic criteria for diagnosis of this disease are the modified Dandy criteria, which include symptoms and signs attributable only to elevated intracranial hypertension or papilledema, elevated ICP greater than 25 cm of water, normal CSF composition, and no evidence of hydrocephalus, mass, structure, or vascular lesion on cross-sectional imaging. More recently, we've been using the criteria put forth by Friedman et al. In Neurology in 2013. I think it's an excellent article and very good criteria that account for our more modern approach with MRI. But essentially, if you have papilledema and normal neurological exam, normal brain parenchyma on MRI, normal CSF, and an opening pressure above 250 millimeters of H2O, then you have definite IIH. Now, you can have IIH without papilledema. If you don't have papilledema, then you just need to have greater than or equal to 3 of these 4 imaging findings: empty sella, flattening of the posterior aspect of the globe, optic nerve sheath dilatation, or transverse venous sinus stenosis, which is found in basically all IIH patients. So here are just some of the imaging findings. Here we see our classic empty sella, where you just basically see the flattening of the pituitary gland. Here we see the bilateral transverse sinus stenoses. Here is a normal person for reference. Here we see, temporal occipital lobe herniation into the groove of the transverse sinus, and you can actually make out the temporal occipital lobes that are compressing the sinus here on this venogram. And actually, this is an important point to something very important to point out, is that actually what's causing the venous sinus stenosis in these IIH patients is not any type of thrombosis or disease within the wall of the sinus itself. Oftentimes, and you can see this on MRI, it's essentially the brain becoming too boggy because of retention of CSF and interstitial fluid, and the brain is basically compressing and herniating into the groove of the transverse sinus and compressing the sinus, causing the stenosis. And you can actually see that here because you can see the undulations of the gyri and the sulci, compressing the sinus here. Here we see the dilated optic nerve sheaths as well as flattening of the posterior aspects of the globe. Now, a vast majority of IIH patients are managed without stenting, with medical therapy and weight loss. This is something I want to make sure that everyone's clear on. About 90% of patients respond to medical therapy alone. So this treatment that we can offer, it's for those patients that cannot tolerate medical therapy or do not respond to medical therapy. So typically when you see a patient with IIH, you review their medications, make sure that there's not any particular medication that's known to cause symptoms of IIH. Then you screen for comorbid conditions, obstructive sleep apnea, PCOS. These are associated with IIH. Then what we always do is encourage weight loss. Typically just a 5 to 10% reduction in the patient's weight can actually get rid of the disease of IIH. If this is unsuccessful, and this is the most effective but hardest treatment is weight loss, then we use medications to lower CSF pressure, whether that's acetazolamide, Diamox, Topamax, in some extreme cases, furosemide. And then historically, patients with IIH would then go on to receive surgery, either VP shunt or optic nerve sheath fenestration. The efficacy of acetazolamide was established in this trial called the IIH treatment trial. They basically gave patients 500 milligram BID and titrated it to about 4,000 milligrams a day. And patients were all treated with diets as well as personal weight loss coaches. And essentially, the use of acetazolamide significantly improved papilledema grade and also, improved, headaches and quality of life. Now, when do we offer surgery, including stenting for these patients? So this is offered in three main scenarios: either fulminant IIH with vision-threatening disease, an extended period of maximum medical therapy and weight loss with persistent disc edema, or severe papilledema and no headaches. There was one trial that looked at VP shunt versus optic nerve sheath fenestration versus medication, but this actually was stopped early due to poor enrollment. So now I'll talk about stenting. So unilateral or bilateral stenosis of the transverse and sigmoid sinuses is the radiological hallmark of IIH. It's seen in over 90% of these patients. And essentially, what we think is going on in these patients is, there's something that's causing them to retain more interstitial fluid, whether that's dysfunction in the lymphatic system, whether that's fluid retention related to, hyperaldosteronism or some sort of, androgen hormone that causes fluid retention. We don't know. But you have this increased ICP, and then the brain compresses the dural venous sinuses. The problem then is when the dural venous sinuses are compressed, they are under high pressure. There's going to be a pressure gradient. And then the arachnoid granulations in the transverse sinuses, which are resorbing CSF, which depend on that gradient, which depend on having a lower venous pressure, they're unable to resorb the CSF. So then the ICP goes up more, the venous stenosis increases, and you have worse CSF resorption. It becomes this vicious cycle. So when we decide that a patient is a candidate for stenting, we basically load them on aspirin and Plavix, 325 of aspirin, 75 milligrams of clopidogrel, and then we continue it for 3 months if a stent is placed. And the need for any type of surgery in the 3 months following stenting is a relative contraindication. The procedure is done under local anesthesia with IV sedation. The anesthesia team is present and they offer heavier sedation during stent placement, because sometimes when we actually place the stent, it can be very painful for the patient. Regarding our technical setup, we use ultrasound access transfemoral, 6 French ballast, no short sheath. We often use a 5 French Sophia for pressure measurements. And then we use an exchange length transcend or V18 wire. V18 wire is a very stiff 18 wire that is sometimes helpful for delivering the Zilver stent. And then we obtain pressure measurements from the left IJ through the torcula to the right IJ. Regarding the decision to stent, it's based off the presence of an angiographic stenosis. They need to have a gradient of 8 to 10 millimeters of mercury or more across the stenosis. And, you know, we used to use the wall stent, and I'll show you an example of a wall stent case. But since, you know, maybe this past summer, we switched to using the Zilver stent. And this Zilver stent that we use is the Zilver 518, which can actually be delivered through a Navian catheter, through a 6 French catheter, and goes over an 18 wire. And then we measure a post-stent gradient. So here's kind of just a classic case of IIH stenting, and this is back when we would use the carotid wall stent, and this is like at 4x. So you know we don't actually shove our wires that fast, but you know, so basically we get our exchange wire as far as we can to the contralateral jugular vein, and if it's not possible, we don't do it. The worst thing that can happen is that you rupture a vein while doing this. So if it's not possible, we just focus on the dominant sinus. Then we get our catheter, and then we do a venogram on the contralateral side, and then essentially just measure pressures from the sigmoid sinus, the transverse sigmoid junction, from the transverse sinus, and then essentially work our way, from to the torcular to the contralateral sinus. And then if there is a significant gradient, then we go ahead and do the stent. For the wall stent, you do need a lot more support because it is harder to deliver. But you can see here we're advancing our ballast catheter past the point of stenosis. And then we just deliver the stent over the exchange length transcend wire and deploy it to treat the stenosis. So here you'll just see the standard stent delivery technique. And one thing to point out here is that these wall stents are about 36 millimeters long. So they there is some precision that's needed when deploying them. And we try to make the stent to be, in the middle of the stent at the site of maximum stenosis. So there's that. Now, some cases are more difficult. When you have an intrinsic stenosis, like in this case, this patient actually had a history of prior dural venous sinus thrombosis, so they don't really meet IIH criteria, but they did have papilledema and all the other symptoms that are associated with IIH. And you can see here that we're trying to cross this lesion of the left transverse sinus, and it's actually just very, very difficult to even get through there with a wire, which is not typical of the stenoses that we see in patients with IIH. Here you see we're crossing it with the microcatheter. Now we're getting the Navian through to basically help us deliver the stent. And now we're getting our ballast through. And I'm sorry, this wasn't a Navian, this was a 5 French Sophia. And now we're trying to get this catheter all the way through past the stenosis, but it's actually very difficult because the stenosis was just so tight. And because of that, we said, well, let's just try to deliver the stent. And we're advancing the stent, and this is the wall stent, and you can see here that it's just hitting the wall of the sinus, and we're basically having an extremely difficult time trying to get the stent to cross the point of stenosis. So then we just got a 6 French Navian across the lesion, which comes in very handy, and this is before we were using the Zilver stent. And then through the 6 French Navian, we were able to deliver a smaller wall stent, like a 6x22 wall stent, to treat this focal stenosis. Now what we would do is basically just deliver a Zilver stent through the Navian if we can get the Navian across the lesion. So I think the Zilver stent is actually a huge using the silver stent has resulted in a huge improvement in our practice. And here, you can see the stent just being deployed and the stenosis being treated. And then here's a case where we use the silver stent, and this kind of just goes to show how nice this stent is for using for the treatment of venous sinus stenosis. But we have our Sophia. We're just advancing our V18 wire into the superior sagittal sinus. It's a very sturdy wire. And basically, we just have our ballast parked in the sigmoid sinus, and we're able to deliver this very large silver stent. I think this one was a 8 by 60 silver stent that's going to cover the whole transverse sinus in one swoop. And it's actually a very handy tool for treating these stenoses. So here you can see the deployment of the stent. And nice smooth deployment, and then the postoperative venogram showing the stenosis resolving. So having done a lot of these cases with the wall stent and recently switching to silver, I can't speak highly enough about that switch. So we discharge the patients home the day of the procedure. It's common to have localized pain at the site of the stent or ipsilateral headache for the first 2 to 3 weeks after placement. And this we typically treat with oxycodone. If patients have grade 2 papilledema or better, we stop the Diamox. But if they have grade 3 to 4 papilledema, we continue Diamox until there's documented improvement in the papilledema. And then we get a venogram at 3 months. And if there's no issues, we discontinue the clopidogrel and do aspirin for life thereafter. Overall, the results for IIH stenting are excellent. Papilledema improvement in over 90%, headache improvement in 80%, pulsatile tinnitus improves in 90%. Hemorrhage rate in recent meta-analyses is about 2%. We've had one out of our 78 cases so far. Recurrence retreatment rate is about 10% though. And I think that's going to be better when you start using longer stents, like those longer silver stents. These are just typical findings. Well, not typical findings, but things to look out for in the CTV. So here, this patient just has a little bit of thrombus on the wall of the stent, so we treated them with anticoagulation. This was incidental. Sometimes you can see extrinsic stent compression, and sometimes that needs to be treated with angioplasty or more stenting. A new contralateral stenosis can pop up, and in those cases, you should consider possible stenting of the contralateral sinus. And I guess that's it. This is kind of our treatment algorithm, and I'll leave this for you to look over on the video if this is of interest to you. Thank you very much. And if you have any questions, feel free to shoot me an email or send me a tweet or a message. I have a longer talk that goes into more depth about technical challenges and complications, and be happy to share that with anyone at any time. Thank you very much.
Well, thank you very much, Walter. That was excellent resolution for a important problem that we have. We were discussing that is underdiagnosed, at least I think in our country. I don't know the neurologist's opinion about that. We already spoke about that in the blog before, no?
Yes.
Any thoughts about that, Pepe or Juan o Celina? ¿Piensan ustedes que vieron digamos, la presentación excelente? A mí me da la sensación que hay muchos más casos y los que nos llegan últimamente nos llegan bastante tarde. El enfermo ya tiene papiledema o está casi ciego. Así que me parece que los criterios de inclusión están claros. Me parece que también el estudio del paciente, el algoritmo es bastante claro. Insistió en el gradiente de los 8 o 10 centímetros de agua. No sé si quiere alguno de ustedes opinar al respecto.
Yo creo que la fisiopatología o el contexto de estos pacientes para la neurología en general no es muy conocido, o que se haga el screening de los senos venosos en casos de hipertensión endocraniana. Entonces, o en este contexto uno puede ir a buscar otra cosa, una trombosis venosa cerebral, pero este tipo de estenosis, donde justamente mostraba que son compresiones extrínsecas, muchas veces uno lo ve a diario en las angioresonancias venosas y lo considera como algo normal. Entonces, Eso en el contexto clínico de este tipo de pacientes sin duda es importante. Y uno lo ve cuando en la práctica cotidiana, no tan cotidiana, pero en los pacientes que cree que tiene este cuadro va a medir las presiones. Y realmente hay diferencias, gradientes de presión muy elevados que con el tratamiento mejoran y uno ve claramente cómo va mejorando de a poco cada uno de los síntomas. Tal vez la cefalea al último tiempo, al principio el edema de papila, pero yo creo que no está dentro del neurólogo general el screening de la estenosis de los senos y otras veces es saber valorarla, ¿no? Cuando la ve en la resonancia.
Quizás tenemos que ir a buscarlos a lo de los oftalmólogos.
¿Cuándo deciden la apertura de la vaina del óptico? Es una pregunta. Y otro es la importancia de los ventrículos laterales pequeños cuando no hay trombosis venosa.
I hope you can get the translation, Wallet. Are you still there?
Yeah, I'm there. I don't have the translation yet. Wait, one second. Interpretation, English. Okay.
So the question...
Yes, now I can. Yeah.
Did you get it or you didn't?
I have not heard the English translation yet.
Okay. So the question was, when are you indicated the surgery? I think you already covered that point, but the question is when you indicated the surgery of the optic nerves, what was your indication for go for that?
Yes, so I will say that prior to stenting, we were doing a lot of optic nerve sheath fenestration, but since we've started doing stenting, we've basically reserved optic nerve sheath fenestration only for cases where patients have fulminant papilledema with permanent vision loss within 2 weeks. But otherwise, we just go to stenting because usually the patients have improvement within 1 to 2 months. But if somebody has very, very, very severe papilledema, we will do optic nerve sheath fenestration.
I see. And the second part of the question was related to the ventricular size?
Los ventrículos pequeños.
Sí, pero ¿qué le querés preguntar acerca de eso?
Que se asocia frecuentemente de esta patología cuando no hay trombosis venosa. Small.
Yes, you get it.
Yeah, so you're saying that these patients often have small ventricles even without venous sinus thrombosis. And that is true, that the idiopathic intracranial hypertension patients do have very small ventricles, and that's another reason why we don't like to do shunting in these patients, because these shunts are difficult to place in these patients. And there is a high rate of shunt failure in patients with idiopathic intracranial hypertension. It's on the order of 20 to 30%.
Maybe we will have some solution from the endovascular point of view soon for that. But I want to ask you a question. What is, you mentioned that you have some rate of restenosis with the stent. Have you seen more on stainless steel, or you see more stenosis on nitinol stents? Or that doesn't matter?
No, so the stenosis, I've only seen one case of an in-stent stenosis. It was the one that I had showed you in the slides. Most of the restenosis is actually juxta-stent. So it's in a segment of sinus that has not been stented. And what is happening, I think, is that, because the brain is retaining the interstitial fluid, the brain is actually compressing on the sinus where the stent is not present and causing the restenosis. So in those cases, we will go and place an overlapping stent to take care of that compression. And one of the reasons that I like using the Zilver stent is that you can stent the whole transverse and sigmoid sinus with one 60 to 80 millimeter long stent, and that gets rid of the restenosis.
I see. Well, thank you very much, Wallet. We are running, as usually, with a shorter time. So thank you very much. It was a fantastic presentation. We enjoyed a lot. And I hope next year you will be with us in Buenos Aires instead of virtually in Rochester. Thank you very much for your contribution.
Yeah, that would be lovely. Thank you very much for the invitation. I'm very appreciative.
Thank you. So we're going to move forward for the last presentation in this block. Professor Jens Filler. It's another presentation for Germany, guys. Professor Jens Filler is director of the Department of Neuroradiology in the University Center in Hamburg. He's visiting professor of neuroradiology also in the University of Oxford. So, la próxima presentación va a ser el profesor Jens Filler, realmente un amigo de Latinoamérica. Lamentamos mucho que no esté este año con nosotros aquí también en Buenos Aires. Es profesor de la Universidad de Hamburgo, es también profesor visitante de la Universidad de Oxford. Así que esperamos escucharlo a la brevedad. Creo que está en línea, así que vamos con el profesor Filler, por favor.
Buenas tardes, dear colleagues in South America, wherever you are. My name is Jens Filler. I'm recording this in Hamburg, Germany. Unfortunately, I cannot be with you. So I would love to. I love Buenos Aires. I've been there a few years ago. That was a wonderful experience. So my subject today is next frontiers in stroke treatment. It's a very interesting task, and I'm trying to give you as good as an overview as I can. So these are my potential conflicts of interest. And where did we come from? We had all the inconclusive studies within the first 6 hours, and the major reasons were we included just all patients, even the ones without occlusion, which was a stupid idea, and not we, but some. And we used the wrong tools within the studies. And then with the advent of stent retrievers and the proper patient selection, meaning patients with actual arterial occlusions, we had good outcomes within the first 6 hours, and it's a huge amount of evidence for this one. And then also beyond 6 hours, and then specifically with the rapid software. This year we had another very important randomized trial with the Brazilian study, which is also a huge success. This is what I mentioned. We have about it works in Brazil and other countries. So we have this confirmation from Resilient. We have this year the BASICS trial on posterior circulation, which I will not cover here. The BEST study from China, also on the same subject. Then we had a direct MT on skipping IV TPA in mothership patients, and the actual SKIP study from Japan, and the ESCAPE NA1 trial. I will cover this briefly in my talk. And just very recently, a few days ago, the Mr. Clean no IV trial stopped enrolling patients, so we will see the results in a few weeks and very few months, I hope. My talk is about the next frontier. So this is what we achieved and what's going to happen next. And it's really hard to predict what's going to happen. But I think we have three very important trends that I'm personally seeing. And that's one is gaining higher efficacy for the treatment. So standardization versus individualization. So both are more or less mutually exclusive. Then we have higher efficacy adjunct therapies, neuroprotection. And then a very important trend is also access for more patients. Not all patients who could have a benefit from thrombectomy get it because of problems with transportation and availability of trained interventionists. I will cover this also in my subject, in my talk. So let's start with this part. So obviously we all take great pains to standardize the treatment. So we have guidelines, but they are at times inconclusive. And something that emerged within the last 2 years is the importance of the first retrieval and the success of the first retrieval. And this is a study that is going to be published very soon in Stroke. You haven't seen it from the German Stroke Registry. What you see here is the rate of reperfusion success per retrieval. It goes down. So first retrieval 40%, then second retrieval 20%. And this is from 1,800 M1 occlusions. So it's not only the superstars. Maybe you all have much better results, but this is across all of Germany. Let's say everybody is included here. And what you see here, the reperfusion rate increases. The more you retrieve, the better the reperfusion, obviously. So after 6 retrievals, you have included 83% reperfusion, but the clinical outcome doesn't improve. So we have the best outcome with the first retrieval, the second best with the second retrieval, and so on. So we need to invest in a technology that gets it right with the first retrieval. And this is something to think about. So I think many folks are thinking about, let's try aspiration first. And if this fails, we can still try a more complicated method. But the data that I just showed to you suggests that this might not be the right answer. So we should try to actually really get first pass recanalization. And the idea was first retrieval, distal aspiration, second retrieval maybe, or second therapy, combination therapy. And my feeling is that we will have a combination therapy as a standardized first approach. Of course, we have budgetary limitations and so on. So the individual choice could also be made between stent retrieval and distal aspiration based on some reasoning. And this, so that's what I was trying to say. So you have all these different combination techniques, Solumbra, ART, SAFE, Captive, Protect Plus, which are more or less similar with some subtle differences that might change something. So Protect Plus and SAFE here with first pass TK3 of more than 70%. But this is in the hand of the masters who more or less established these techniques, and it's not clear that it works everywhere. So this randomized trial, I think it still hasn't been published yet, the ASTA-2 study. It analyzes frontline contact aspiration plus stent retriever versus frontline stent retriever only. And the combination therapy has a seemingly higher first pass effect, TK3 after first pass, but it's not significant, and it's a randomized trial, so that's not very conclusive. So it's all that are the p-values of nightmares. So it's just not significant. But yeah, it looks quite convincing that the combination therapy is also better than stent retrieval alone. But there could be another way to approach this problem, and this is if we have an individualized approach on the reperfusion technique. This is a regular occlusion, and this is an irregular occlusion. So some call it, they give it other names like the claw sign, irregular phenotype, clot meniscus sign. There are quite a few studies in the last 2 years on this subject in anterior and posterior circulation. And the interesting part is that this was one of the first, and they observed in a relatively small sample, but with very convincing results, that ADAPT seems to work best in the regular and stent retriever best in the irregular / claw sign, whatever. So it might be a way to still justify using non-combined therapy in the first attempt. And I think this is something that needs to be worked out in the coming time. So I think this is an interesting thing. So this standardization, so put everything in one basket versus individualization, I think this is undecided for the moment, but this is something we will closely monitor in the next few months. Then we have another approach, which is higher efficacy by neuroprotection and adjunct therapies. This is an example of experimental studies, and what you see here is, just as an example, normobaric hyperoxia on infarct volume in mice. So neuroprotection, does it work or not in stroke? And the red dots represent a huge effect on decrease in infarct size, and the blue dots not. And what you see, there is no effect, almost no effect beyond the 3rd hour. And that's animal studies, obviously. But there are plenty of other indications that the requirement for neuroprotection to work is an open artery. So first, it's strongly time dependent, and second, we need recanalization. So thrombectomy will create a renaissance for neuroprotection. We could call it thrombectomy-enabled neuroprotection. That's a very interesting development, and one of the first very important studies is the ESCAPE NA1 trial. They randomized more than 1,000 patients to NA1, neranetide versus placebo. And they didn't find a real effect. So if you look at this, placebo versus neuroprotective agents, nothing, no difference. So neuroprotection doesn't work even with recanalization. But if you look more closely, in the patients who didn't receive TPA, alteplase, you have a therapy effect of 10%. So there seems to be some strange and unexpected interaction between alteplase and this neuroprotective agent. So the next study is already starting, ESCAPE Next, and just exclusively on patients without alteplase. So it seems, so I would bet that this is the first study with positive effect of neuroprotection in stroke. This is a huge breakthrough. There are other developments that are not pharmacological. So this is an injectable implant to stimulate the sphenopalatine ganglion here, and it's seemingly easy to inject. And it has been published last year in the Lancet, and same thing, almost an effect within 24 hours. Why is this important for us? It could use to be freezing the penumbra. If patients are transported from remote places, this could be a very good strategy to keep them thrombectomy able. So to freeze the penumbra, to freeze the growth of the infarcted brain. And that's interesting way. So they will invest more in this technique as well. And we will see other technologies like this that increase the number of patients for thrombectomy. And this brings us to the next subject, which is access for more patients. So there are some metropolitan regions where almost all thrombectomy patients are treated according to the protocol. But there are regions where this doesn't apply. And we have this famous comparison. Is it better to send the patient directly to the hospital or give the patient in a more remote hospital IV TPA first? And I will not go into this deeply. There has been lots of meta-analysis. This is one of them, and it shows there is probably not a big difference. And this is due to the selection of patients. And just also a few days ago, the RaceCat trial, a randomized study on this subject, has been presented, and it also didn't show a difference. But the problem is it applies for Catalonia, which is a very, let's say, well-organized region in Spain. and doesn't necessarily apply to more remote regions. So I think I'm really looking forward to the publication to see. So we have all these paradigms. So essentially what we need to do is we need to bring together the patient, the interventionalist, and the angio equipment. And there are different ways to do that. Bringing the patient to the angio with IV first through another hospital, mothership, drip and ship. But another option is drip and drive, meaning we bring the interventionalist to another hospital where the patient receives IV TPA. And this is one study from Hamburg, and we started this with Group A, where we had a drip and ship, and Group B, drip and drive. It's not exactly correct. And then you see what's going on. This is the drive the doctor to the patient, and this is the other way around. And what you see here is the time from CT to DSA, and the difference is 2 hours. So we are 2 hours quicker if we drive to a remote hospital and do thrombectomy there, then do it the other way around. It has something to do with logistics. It doesn't necessarily apply to other regions, but to Heidelberg, they do the same. They started even a little earlier than we did. And we combined our forces to have a prospective study, which is called the NeuroSquad trial. And we found essentially the same thing. So we had a time improvement of 54 or 75 minutes, depending on onset to groin puncture and imaging to groin puncture. So that's really very convincing data. But as I said, this applies to Hamburg and Heidelberg, not necessarily to other regions. And you can do some simulation stuff based on very elaborated models. And this is what you see here. Let's say you have this non-endovascular center and you have an endovascular center. And as a patient, you are here. Then it makes total sense to go first to the non-endovascular center and then to the endovascular center. But if you are closer to the endovascular center, no questions asked. But this changes dependent on different assumptions. And this is what we did. And we used this software from Destin Health. And it has been published this year in Stroke to model drip and ship versus mothership versus drip and drive. And dependent on the transportation time, how long it takes, the door to needle time and the door to groin time, image to groin, and so on. And you see if a patient has a stroke in this region, we need to go to the hospital by car. And if the patient has a stroke here, patient can come to us by mothership approach. And the drip and ship only makes sense in very remote regions here. And if you change your settings, let's say you have a delayed drip and drive doesn't make much sense anymore, so no violet regions anymore. And if you have an overload of the comprehensive stroke center, we have a low processing time in our center. It makes much more sense to drive to other hospitals. And we just did an analysis where you see this with the time of the day. So it changes if you are early in the morning or late at night. So obviously it makes a difference as well. But the final approach, and I think that's also very interesting, could become very important, is telementoring. So we would mentor a less experienced interventionist to do the procedure. So this is a part of the survey that we did this spring in the beginning of COVID. And what was interesting is that in Latin America, video streaming from angio to angio had a very high rate of interest. 50% of the participants were interested in this kind of technology. How does it work? We have a camera system. It's specifically dedicated with a specific streaming architecture. It's not so simple to stream live from an angio suite to an experienced proctor, and this proctor, in case of complication or something goes south, can help. And during COVID, it has achieved a huge adaptation. So you see some tweets here where it's used. So Dr. Galdames, for instance, here, you probably know him. He is really very excited about the system. These are actual images done with the system, and we published the first experiences here with the web device. You can zoom in even more closely to see what's going on. Then you can switch to the angio. It's even better than being in a room as a proctor, and you can help your colleagues who are less experienced with thrombectomy procedures. And we just started the Texas study. We call it Texas teleproctoring enabled clot extraction in acute stroke to help colleagues in Romania. So we proctor the colleagues in Bucharest. So that's supported by Medtronic. I think I'm really looking forward to the results of this study. So it looks very good. So if I may summarize the next frontiers, from my perspective, high efficacy, my prediction is we will have standards for patient groups. So something like this claw sign and maybe other methodology to determine what's the best therapy for the individual patient. Neuroprotection, adjunct therapies. There will be many studies, and I think the key challenge for us is we need to stay involved. We shouldn't leave the field for others. We definitely need to keep our fingers in all this kind of stuff to maintain our role. And finally, my prediction for access for more patients, we need more patients to help more patients with stroke. I think this remote proctoring thing is turbocharged by COVID. This is what we observe. So participate, and if you're interested, reach out to me. Thank you very much. And yes, muchas gracias to Buenos Aires and vielen Dank aus Hamburg. Next year, I hope I will be able to come. Bye-bye, and thanks for the invitation.
Thanks, Jan. Actually, I think we would like to go to Hamburg, but we are expecting you in Buenos Aires. No problem with that. Saying that, thank you very much. That was we clearly see that we have frontiers, but I think I'm very optimistic about the future. So in regards of that, we are not having any more time. We are going to skip that, and we're going straight to the Guillermo Dabus, who is waiting for us and at the Baptist Memorial in Miami. Hola, Guillermo, ¿cómo estás?
Hola, Pedro, ¿cómo estás? ¿Escucha bien?
Perfecto, perfecto. Te estamos esperando aquí. Sabemos que nos vas a hablar acerca de la angioplastia carotidia, el CAS, versus la endarterectomía, los resultados del CREST, que nos interesan a todos, y cuál es tu enfoque, cuál es el enfoque de tu grupo acerca de la angioplastia carotidia. Así que estamos deseosos para que hables con nosotros. Puedes hablar en portugués, español o inglés, lo que tú prefieras, pero por favor.
Sí, claro. Como los otros representantes están hablando en inglés, yo creo que es más fácil para que también todos los se comprendan. Voy a dar la charla en inglés, ¿ok?
Okay, go ahead. Yes.
Perfect. So, Pedro, thank you very much for the invitation. It's always a pleasure to be here and participate in your activities. One of the true masters on our field. So it's really an honor to be here. And I'm going to be talking about the status of CREST-2. We're going to go through some data. And what will CREST-2 tell us? I mean, we don't have the results yet because the study is not completed yet. And it's going to be taking a while, but we're going to go through some of the specifics and the reasons why this study is going to be extremely important. So these are my disclosures. Specifically to this talk, I don't have any very specific disclosure. So, as a background, I think it's very important to understand where we are when we're talking about carotid angioplasty and stenting. And you can see here on this table, it's a very busy table, but what it shows is that over the last 30 years, pretty much, we did a lot of studies in regards to carotid angioplasty and stenting, okay? Even from the early days, first, of course, in terms of carotid disease, started with the NASCET, which compared medical management at that time in the 90s to carotid endarterectomy. But then following all the stent studies, you can see like that the stents or carotid angioplasty stent has been extremely scrutinized in the literature. We studied it through all sorts of angles. symptomatic, asymptomatic, high risk, low risk, standard risk, anatomic risk, medical risk. So, I think, it's probably one of the most scrutinized procedures like that we have in medicine. And, I can tell you, like, as everything that we do, when you look into the progression over the last, it is like a little bit older, but, that's when a lot of studies in regards to cardiac stents actually were published. But so from the 2000, 2008, a lot of the studies that were published actually showed a significant improvement in outcomes specifically for carotid angioplasty and stenting when using the composite outcome of death, stroke, and MI, which is used for a lot of the trials. Or if you do only composite of death and major stroke, you can see there's even lower. And, the reasons for this, as with everything that we do, that, we gain experience throughout the years, that explains that. So more experienced operators, better patient selection. That's the other thing that's extremely important. We're going to talk a lot about it because that's a very, very key component of CREST-2. We need to make sure we're selecting the right patients for either for endarterectomy or for the carotid stent. And we're going to talk a little bit more about that. And also, of course, improved technology. The technology evolves. The filters are better. The stent designs are better. The support that we have to do them are better. So all this come together to really facilitate improvement and result in improvement of the outcomes of carotid angioplasty and stenting. Before we go to CREST-2 specifically, I'm just going to touch upon some of the basic aspects of the CREST-1. So CREST-1, as we know, it was a study that basically compared endarterectomy to carotid angioplasty and stenting, specifically in symptomatic patients with greater than 70% stenosis. And the result, the overall outcome, the primary endpoint was very similar. So the overall composite of death, any stroke, and MI was very similar in both groups. Now, when you break up the stroke and MI, it's when it gets a little bit more interesting, right? So on the angioplasty and stenting group, there was a little bit higher risk of stroke. Now, most of this stroke happened because of minor stroke. So it was not major stroke. Actually, if you compare the endarterectomy arm to the stroke arm, to the stent arm, on the major stroke, the results are very similar, not statistically different. Now, when you look into the minor stroke, indeed, the risk of a minor stroke was greater in the angioplasty, or actually the risk that it happened more compared to the endarterectomy arm, 3.2 to 1.5%. This was statistically significant. However, in the other hand, the risk or the occurrence of MI was also statistically significantly higher in the endarterectomy arm, 3.4% compared to the stent arm. So this has been a matter of debate throughout these last years. Here in the United States, where there's still a lot of regulation in regards to carotid stenting, mostly in regards to payment by the Centers of Medicare and Medicaid. So that's something that is taken into consideration. So that's important to understand that the risk of CAS, which is said by the vascular surgeons to be greater for stroke, it's true, but it's for minor stroke. And on the other hand, endarterectomy had higher risks of MI. So when you look into this graph here, which basically shows the freedom from all-cause mortality. So what does that mean? That means that if you had a minor stroke, you were way more likely to be alive, later on, than if you had an MI. So in other words, MI is associated with long-term mortality, while minor stroke is not. So the CREST-1, basically, again, what demonstrated is that endarterectomy and stenting are very similar procedures. There's a slightly higher chance of a minor stroke when you look into the stenting arm compared to the endarterectomy. However, the risk of an MI, like a myocardial infarct, or ischemia, was greater in the endarterectomy arm, and that is associated with long-term mortality, while a minor stroke was not. So the other thing that the CREST-1 showed is that there's specific age limit, basically from 48 years old to 79 years old, where both procedures are very similar. Now, most of the problems on the carotid angioplasty and stent arm actually happen in patients older than 79 years old. So that shows that potentially these older patients, maybe stent is not their best option. So now talking specifically about asymptomatic disease. And when that comes in mind is when we go to CREST-2. So, I would like to acknowledge we have a very cohesive group. It's almost like a quality assurance group. We review all the interventionalists that want to be part of CREST-2. We review at least like 30 to 40 to 45 cases they each submit, and each one of us review, and then we have a thorough discussion in regards to this person should be or not part of CREST-2 in the stent arm. So special thanks to Dr. Rubin, who's the chair of our committee. Now, what CREST-2 wants to answer is like a question somewhat like that. This was actually a real questionnaire. So if you have a patient who is a 67-year-old and has 70% asymptomatic carotid artery stenosis, how is this patient treated according to what the answers were, depending on where you are in the world? And you can see here, the answers vary. A lot of people go through like asymptomatic just for medical management, but in terms of treatment, which is in a lesser degree, it changes in their atherectomy and stenting. It varies according to where you are in the globe. So that's the main question that actually CREST-2 is set to answer, is this. If you have a patient that is asymptomatic and have a greater than 70% stenosis, which is better? Intervention with either stenting or endarterectomy versus medical management. So CREST-2 was actually, it's an NIH-funded trial. First patient was enrolled in December 2014. Several centers are now part of it. So again, it's like two parallel arms on CREST-2, okay? And the primary endpoint is any stroke or death within 44 days of randomization, or an ipsilateral ischemic stroke thereafter up to 4 years. So we exclude the MI from this. So basically death and stroke. So those are the two arms. Why? Because again, the CREST-2 is a study comparing intervention, either with stenting or endarterectomy, versus medical management. And the decision about if the patient intervention would be endarterectomy or stenting, it's according to center expertise. So the center decides if you think it is a good case for endarterectomy or for stenting, that's what's going to be done, versus or randomized to medical management. In regards to our interventional management committee, as I mentioned, we reviewed like almost 400 interventionalists. So here in the United States, cardiologists, interventional cardiologists, interventional radiologists, interventional neuroradiologists, neurosurgeons, interventional neurologists, and vascular surgeons are the people involved in carotid stenting. So all of them, as long as they have a good track record and good volume, can be part of CREST-2. You can actually see here of this 400 interventionists reviewed, 50% were reviewed immediately, or actually even with like the follow-up reviews. 33 have been right now conditionally approved, which means that they need to submit a little bit more cases and then they will be approved. But there's a good amount of cases that have been denied or deferred. So that's important to know. We've been very strict on the people that can't participate in the study. In regards to the stent arm, those are the stents that were FDA approved. So those are the stents that are part of the protocol. They can use any of these stents, and any of these protection devices can be used. In regards to the endarterectomy, the endarterectomy can be done in a straightforward endarterectomy technique or an aversion technique, as you can actually see here. So it really totally depends on operator expertise, as long as it follows the rules of the protocol. The medical management is very straightforward and standard. The patients need to be on statin. The endarterectomy arm, they need to be only on aspirin, and on the angioplasty stenting arm, they need to be on dual antiplatelet therapy for at least 1 month after the treatment, and then aspirin the same way as the endarterectomy part of the trial indefinitely. Primary risk factor targets: systolic blood pressure less than 130 and LDL cholesterol less than 70, and secondary risk factor target: non-HDL cholesterol less than 100, hemoglobin A1C less than 7, smoking cessation, target weight management, and greater than 30 minutes of moderate exercise 3 times a week. So similar to what happened in Sampris, we're really optimizing medical management in a way that has never been done before. So even if you compare the NACET, which was done, in the 90s, medical management at the time was not like this. So it's possible that even NACET at the time would be different. So who knows? But, so there's a very strict risk factors and control. So right now, at this point, about a month ago, we have that going about 70% of the cases for the systolic blood pressure less than 130, and for the LDL less than 70 in about 70% of the cases. So a pretty good compliance on that part. Of course, still needs rooms to improvement, but it's actually doing pretty well on that. Now, the enrollment in CREST-2, had a big hit when COVID started, like everybody else, right? We were like really good track. The black line means what was expected, And then the red line is the surgical part with endarterectomy versus medical management. And the blue one is the stent versus medical management line. And you can actually see here that when COVID started, this really get a drop because, a lot of places stopped enrolling. It was very difficult to put patients on trials. The systems were shut down. The hospitals were shut down. So it makes it very difficult. So the prediction now initially of enrollment when the trial started was it would end in December 2020. However, we know now that this is more likely to happen actually in December 2022. And then, of course, there's 4 years of follow-up. But, at least at the time, we're going to have preliminary results. This is an interesting thing, just out of curiosity. We sent questionnaires to all the trials, to all the sites participating in the trial to see how affected they were in regards when COVID started. You can see here that they all reported really significant their systems being very affected in regards to their research enterprise, making it very, very difficult to enroll patients or to participate in monitoring visits. So that of course, it's a big, big problem. And, because of that, you can actually see the reason why the study kind of dropped in the most recent months. In regards to the total numbers, so on the carotid stent versus medical management arm, the study is 66% complete. There's like 821 patients already enrolled. And on the endarterectomy versus medical management treatment arm is 73% complete. So, those numbers are very, very good considering everything. I mean, it's a lot of patients. I mean, in terms of neuro studies, those are like some of the largest studies to date. Now, CREST-2 trial is what we discussed right now, but there's also something that we call the CREST-2 registry, which is a little bit different. And the reason to have a CREST-2 registry is to facilitate rapid initiation and completion of enrollment in CREST-2. Why? Because this gives access to a lot of people to do carotid stent, to get expertise, get better experience, and with that, increase the enrollment on the CREST-2 trial, because a lot of these patients may fall into the same criteria. So if you have a patient that is asymptomatic 7%, it can be treated in the CREST-2 registry. However, preferably you need to put this patient on the trial. Now, if the patient refuses to be on trial, he can be on the registry. But the registry also involves asymptomatic patients. So pretty much in the registry, you can treat everyone. You treat everyone in a controlled way, in a way that people know what's going on. Those cases are adjudicated, and the CREST-2 registry executive committee look into everything. And we actually have been able to review some of the data. I'm going to show some of the data on that and see that the reason why we think it's actually doing very well. So in CREST-2 registry right now, which includes stenting and some TCAR case, which is a new procedure, we have enrolled almost 8,000 patients. Just think about it. I mean, which other study has 8,000 patients enrolled? None, as far as I'm concerned. This is just for carotid angioplasty and stenting and for a TCAR. You can actually see here too on our CREST-2 registry, the interventions that we approved in the beginning started very slow, but then as experience was improving and expertise improving, more people are approved. And right now we have 329 interventionists that are either totally approved or conditionally approved in over 200 centers. And centers now include mostly North America, but there are some centers in Europe, in Barcelona. There's some centers in Australia, and there's few centers now being started in Israel. So it's very interesting. Now, again, as I mentioned, the interventional committee and the CREST-2 looks very carefully at the results, making sure the cases are being done for the right reasons by the right operators and are being well selected. We published a couple papers on that. More interesting, this is a very interesting, I think this shows exactly what I was saying. When you select the right operators that are trained, because all the people that enter either CREST-2 trial and the CREST-2 registry, they need to participate on a webinar where basically they're told what we believe in terms of interventional management committee should be the best technique for the carotid stent procedure. And they're obligated to sign a paper saying they acknowledge that they will follow those guidelines. And actually, if you look into this, and this is a study that was published about 1.5 years ago and taking data from 2 to 3 years before. So as I mentioned, we have over 7,000 patients now. This study was done when we had 2,741 patients. But you can actually see here, the numbers of the registry are showing are second to none in terms of outcome. The outcome has been extremely good into like all patients, but if you split into asymptomatic and asymptomatic, those rates are better than the first CREST, the CREST 1. And those numbers in terms of like complications are actually spectacular when you compare to any other study that was done. So we're very excited about that. And I think this really proves the point that when you have patients that are, or patients that are well selected by physicians, interventionists that have the expertise to do it, I think that's really like the key for success. The other study that is very interesting as part of CREST 2 is what we call like CREST Age. So CREST Age is looking to cognitive assessment of patients. So let's say that a patient, maybe the stroke difference is not going to be high between medical management and treatment, either by endarterectomy or carotid angioplasty and stenting. However, what about if cognitively they are better? So this is what like CREST hemodynamics or CREST Age is trying to assess. So the patients, 500 patients, they're supposed to have perfusion and a neurocognitive assessment on baseline and then be followed for 1 year and see how they perform. So that's going to be very interesting to see if there is really an improvement in cognition or their better outcome in terms of neurocognitive compared to their neurocognitive baseline. I think it's very, very interesting what it's going to potentially show. So I'm going to just share with you like some of the reasons why we think like this case should be very well selected and people should be trained and making sure they're entering the correct case in CREST 2, because you want to potentialize the chance of the study going well and doing well and demonstrating the results that they're supposed to show. So if you start putting like crazy cases, I mean, that's going to be a disadvantage for whatever technique you're using to treat those carotid disease. So I'm going to show some cases. There's some specific carotid angioplasty and stenting exclusions, and there's also some specific endarterectomy. I'm not going to mention the endarterectomy ones. We're going to look into specifically the exclusive like carotid angioplasty and stenting exclusions. So those are some of the exclusions, severe tortuosity, for example, proximal common carotid disease or innominate stenosis on the right side if you have the problem, or if you have a severe intracranial stenosis. So everything that can potentially make the procedure more difficult or potentially masquerade like a bad result, I think that's important to exclude. Lesions that are extremely calcified should also be excluded. Why is that? Well, because those may be more difficult or more prone for thromboembolism. We don't know that, but we know that they respond poorly to carotid stenting. That doesn't mean that it cannot be done in an endarterectomy arm. So if you have that, instead of doing medical management versus carotid angioplasty and stenting, you put this patient on medical management versus endarterectomy for randomization, because these patients could be treated successfully with endarterectomy. The same way, lesions that are long, may not be enrolled in any part because they're usually not very favorable for either. And sequential non-contiguous lesions. So I'm going to show some examples now. So for example, this case here, a patient with like a very heavily calcified and mild, some tortuosity on the carotid, but mostly because of this heavy calcification, of course, should not be considered for CREST 2. A very tortuous arch, very tortuous innominate and proximal carotids should not be done. Patients that have tortuous internal carotid, remember, you need to pass a filter with you unless you do the MOMA device, but you need to pass a filter. And, there's this angulation is not very helpful. Even if you straighten up the vessel, you may cause a spasm. That's a case that you want to do this. You can do in the registry, but you should not do this on the trial. Because if there's a bad complication in this case, that's going to go against the procedure and putting medical management to advantage. There's another, case that, of course, not a good case to put in a trial, a very bad arch, type 3, or again, an angle like a tortuous carotid that is like heavily calcified. Again, lesion in the arch, osteo lesions, very calcified. Remember, like in CREST 1, a lot of the strokes actually happen on the contralateral side of the stented vessel, which means that a lot of those potentially happen during manipulation of the arch. So that's something to keep in mind. So, if you have a bad arch, very calcified, a lot of plaque, maybe that's not a good patient to put in CREST 2. And I'm almost done. Again, I just mentioned this, but severe tortuosity of the carotid arch, common carotid, not a good case. Usually you push this sheath forward, this curve goes up, it all becomes a mess. I mean, why do that in a trial? It's not a good idea. Another case here, again, very tortuous internal carotid artery. Remember, you need to pass a filter. I mean, it's not a good case for it. I mean, I don't need to say that, but it's very clear that this patient should not be in a trial. Long lesions, another problem. Contiguous lesions as well. Remember, like you need to have one focal lesion. The shorter, the better. That's the perfect case for the trial. String lesions, string sign lesions, no case for CREST. So the case that we want for CREST are basically these cases here, okay? Short lesion, straight vessel. We want to potentialize, decrease the risk of stroke on a carotid angioplasty and stenting the most we can by good patient selection and by good training of the interventionists, of competent interventionists. That's how we believe we're going to achieve the best results possible in the angioplasty and stenting arm. So with that, I conclude my presentation. I really appreciate you all for the opportunity, and I'm happy to entertain any questions. Thank you.
Well done, Guilherme. Muy bien, parabéns. As you pointed out, I think the credentialing of the interventionalist is essential, as well as the selection of the patient. I think those are critical points. If you remember the case one, I was really disappointed, not by the result, but probably by the credentials that people need to get involved. So
yeah, I think it's.
Yeah, go ahead.
I think you're absolutely right, Pedro. I mean, remember, like there was, two big studies, like EVA 3S and SPACE, European studies actually, that most European, that really like showed, very poor results, to be quite honest, a very high risk of complications on the stent procedure. And a lot of that, when you look into the protocol, a lot of these patients were not on dual antiplatelets. A lot of the cases didn't have filter used. So, it's important that people understand that every procedure has a limitation, and you need to do it and maximize the chance of having a good outcome of the procedure. How you do that is with good trained people that have experience, that have expertise, that understand what they're doing, and they're selecting the patients right. Listen, there are situations where sometimes you cannot get out of doing a patient that, it's more torturous. I mean, we do that, but should not be done in the trial, right? Because you want to potentialize the chance of the trial being successful. And in real life, if you have another option, maybe that's a good thing. I mean, we have nowadays, I don't know if you've done there in Argentina, if you're doing that, but there's TCAR nowadays. So, some cases are good for TCAR. Some cases are better for carotid angioplasty and stenting. Some patients are still better for endarterectomy. I mean, we have all of that. And I think it's important that we all understand what is the best case for a specific patient. And, believe me, there's going to be patients that also will be good for medical management. We don't know what the result will show. I mean, a lot of that will be dependent on the results of the procedural arms. But, medical management nowadays, with all the medications that we have, understanding better that, the LDL needs to be less than 70, blood pressure less than 130. That's again, statins. That shows promising for some of these asymptomatic patients.
Okay, thank you very much. Obrigado.
Muchas gracias, Pedro.
We have Sakai knocking the door, so we have to go to
Perfecto.
Japan. So we release you. Thank you again for contribution. Thank you for being so kind with Latin America. I know you are the center of training there. You manage training a lot of people there. So we really appreciate that from Latin America. Obrigado.
Muchas gracias, Pedro.
Adiós.
Es un placer. Adiós.
Adiós. So, Professor Sakai, the director of the Department of Neurosurgery of the stroke unit at Kobe City Medical Center, is ready to go with us. They have been performed angioplasty in Japan for many years. Those guys are very well trained, very well equipped. So we are looking forward to hear what's happened today with angioplasty and stenting in Japan. Nobuyuki is there. Please go ahead. Good morning. It's too early in Japan.
Thank you, Chairman. I'm Nobuyuki Sakai. Today, I'd like to present our experience of carotid artery stenting. This is my disclosure. Let me introduce myself. My name is Nobuyuki Sakai, Japanese neurosurgeon and neurointerventionist.
Estamos en el orden.
Now, President of Japanese Society of Neuroendovascular Therapy. Worked at Kobe City Medical Center General Hospital. and I have a chance to host WFITN Congress in 2022 at Kyoto. At first, we announced to you 16th Congress of WFITN will be held in 2021. The COVID-19 pandemic came to us, so we postponed to 2022. Date is August 21 to 25. Please come to Japan and join our Congress. This is total career of my neuroendovascular therapy, including about 1,500 carotid artery stenting. This is distribution. Recently, acute ischemic stroke therapy is growing. I started carotid artery stenting in 1997, and Precise and AngioGuard approved in 2007, and most recent approved device is Casper stent. This is Paramat stent. This is my first case. At that time, I deployed balloon expandable stent without any embolic protection devices. You need to understand, at that time, most of carotid artery stenting have been done with balloon expandable stent without embolic protection. Death stroke rate is about 5%. But as you know, carotid disease is embolic source to brain. As you know, progression of carotid diseases have dangerous plaque. Professor Teron developed his own blocking balloon system to protect emboli. 2002, we introduced pack-surge guard wire for use carotid artery stenting. This is recent device named carotid guard wire. We aggressively use this pack-surge guard wire. This is surveillance of JSNet in 2007. At that time, about 3.4% death stroke rate in Japan. 2007, Precise AngioGuard approved. Indication is high surgical risk, 50% or more symptomatic, 80% or more asymptomatic. But we have many bad cases with filter protection. This 61-year male have tortuous anatomy. I navigate AngioGuard distally and put stent. But just after post-angioplasty, he have major stroke. Filter cannot catch any debris. At that time, distal filter is only approved device. Very famous Argentina vascular surgeon Professor Parodi developed his own embolic protection system named Parodi system. His protection mechanism is making reverse flow during carotid descent. At that time, if I have unstable plaque, we introduce balloon guiding system with distal filter. You can see many debris catched by angio guard and aspirate blood have also debris. This is our surveillance. Professor Miyachi published this data. First period is carotid guard wire mainly used. Second period, we introduce filter protection. And the third period is combined technique. We use proximal balloon protection with distal device. Result is much better than filter period. Probably you know, proximal balloon protection is better than filter protection. Everybody know carotid artery stenting have more stroke, but we have been conducted many national surveillance, including registry and trial. GRNet is nationwide surveillance of neuroendovascular therapy. Over 30 English publications. GRNet 1 to 3 catch 10 years experience. Permanent death stroke rate within 30 days is only 2.7% in Japan. We have now two modalities for carotid revascularization: surgical procedure and endovascular procedure. If efficacy of carotid stenting for stroke prevention is same with surgery, who want to give their neck to the doctor? Interventionists should show safety and efficacy. Current our protection system is combined use of MOMA and carotid guard wire. This is my total experience. Permanent moving mortality is only 2.3%. This is number of cases in carotid revascularization reported by Japan Neurosurgical Society. Carotid stenting reached over 10,000. However, carotid surgery is only 4,000. Japanese neurosurgeon control both surgery and stenting. Vascular surgeons CEA is only 100. Cardiologist carotid stenting is only 500. Neurosurgeon, neurointerventionist is main player. So stenting penetration rate is reached to about 70%. This is United States its data. Stenting penetration rate is about 10% in United States. Japan have more endovascular. Neurosurgeon, neurologist, neurointerventionist is main player. This is very famous trial with stenting versus surgery. As you know, stenting have more stroke at 30 days, mostly minor stroke. This stroke occurred within 30 days. 2 of third occurred in the procedure. However, 1/3 is occurred after procedure. I show you our case. This 78-year male have 3 times TIA, so we treat with stenting. Intravascular ultrasound shows instant protrusion, and he have embolic stroke. Another case, the 78-year male have also symptomatic carotid artery stenosis, treat with stent, instant protrusion with the intravascular ultrasound, and he have ischemic symptoms on day 7. You can see intraluminal plaque protrusions. So we treat long inclination with balloon 2 times, and finally protrusions disappears. This is our analysis. Once instant protrusions occurs, more stroke. And this is another analysis. Stroke after carotid stenting occurred 70% after 48 hours. We have been used 3 traditional stents in the world. We have 3 different next generation stents. This is free cell area. Of course, wall stents have smaller than open cell stent, but next generation stent have very small free area. This is 3 micromesh stent, and this is characteristics of micromesh stent. OCT analysis showed less instant protrusions with micromesh stent. Italian cardiologists showed fantastic result with OCT analysis. Thermomicrovention made Casper stent in Europe. This system named Load Saver. In 2014, I have experience of this stent. This 85-year male have minor stroke at the left carotid, and the MOMA and guardrail system introduced and prep angioplasty, stenting, and post procedures. This is carotid Casper stenting procedure. You can see no instant protrusion. This is third case. Unstable plaque.
Tenemos que hacerlo así, pero bueno, vamos adelante. Me invitaron a hablar de la transferencia directa a la sala de angiografía y del nuevo ensayo clínico, el We Trust, que estamos poniendo en marcha. Lo que hay que hacer realmente para determinar si un paciente precisa o no de tratamiento endovascular en el ictus es descartar que tenga una hemorragia, descartar que tenga un infarto extenso y finalmente confirmar que tenga una oclusión de gran vaso. Y los métodos para hacerlo pueden ser diversos, pero en todo caso no tienen por qué ser siempre los mismos dependiendo del tiempo en el que lleva el paciente desde el inicio de los síntomas. A modo de ejemplo ilustrativo, vean esta publicación de 2013 en la que evaluaban medidas de calidad implantadas en hospitales ingleses y observaron como una medida de calidad realizar una tomografía el mismo día y ven cómo este objetivo se alcanzaba en un 47% de los pacientes. Esto no hace tanto tiempo, y estamos hablando de que aquí estamos realizando la exploración en minutos después a todos los pacientes desde que han llegado al hospital. Es decir, estamos avanzando, evolucionando muy rápidamente y bueno, también a diferentes velocidades. Lo mismo que ocurrió con el tratamiento fibrinolítico hace 20, 25 años, cuando iniciamos pocos pacientes con trombolisis. Tardábamos más de 90, 100 minutos en el indicador de calidad, que era el tiempo desde la puerta hasta la aguja, hasta el inicio del bolus de TPA. A medida que fuimos incrementando nuestra experiencia, se fue capaz de rebajar este tiempo hasta los 15, 20 minutos desde la llegada al hospital. Se podía iniciar el tratamiento fibrinolítico y estamos planteando lo mismo. Reducir drásticamente los tiempos. Lo primero que hay que hacer es motivar a todo el equipo, que sean conscientes de la importancia que tiene la disminución de estos tiempos. Ven cómo haciéndolo se puede disminuir significativamente el tiempo de 105 minutos a 67, aunque de todos modos persiste bastante tiempo, 45 minutos, en lo que es el intervalo desde el angiógrafo hasta la llegada a la sala de urgencias. Es decir, hay algunos circuitos que deberíamos, más que acelerarlos, pensar en evitarlos o saltarlos. Nosotros lo que intentamos hacer siempre es que nos preavise el sistema de emergencia, el servicio de emergencias, de que van a llegar, de modo que estamos esperándoles en la puerta de entrada. Hacemos un bypass del servicio de urgencias, el paciente no pasa por el servicio de urgencias siempre que es posible. Hacemos una exploración neurológica ultra rápida en este punto y pedimos al servicio de emergencias, la ambulancia, que lleve directamente el paciente al tomógrafo, donde tras la adquisición de la tomografía sin contraste podemos iniciar el tratamiento fibrinolítico si es necesario, si el paciente es candidato, y finalizar las pruebas de neuroimagen con contraste para verificar si el paciente es candidato o no a trombectomía. Este intervalo de tiempo, el puerta punción femoral, puede ser muy variable entre los diferentes centros, pero en este estudio, en el que en 2014 ven las grandes diferencias entre centros, el que mejor lo hacía tardaba 75 minutos, pues cosa que hoy podría parecer incluso elevada, pero está directamente relacionado este intervalo de tiempo con peor pronóstico funcional. Cuanto más largo este intervalo de tiempo, menor probabilidad de no tener discapacidad. Y vemos cómo en los grandes ensayos clínicos, pues por mucho que se intentara bajar este tiempo, Swift Prime y Escape tardaron alrededor de 1 hora. No está mal, pero vuelvo a decir, creo que es mejorable. Pongámonos en un caso extremo, un paciente asintomático que viene a nuestra sala de angiografía a realizar una arteriografía diagnóstica y en este mismo instante en el que es transferido a la cama, presenta una hemiplegia súbita con afasia. Probablemente la mayoría de nosotros no sería partidario de sacar al paciente de nuevo de la sala y llevarlo a hacer otra tomografía convencional. Y lo que haríamos es confirmar que no tiene una oclusión, hay una hemorragia con un con-beam CT, con una tomografía adquirida en la sala, y si de hecho no la tiene, pues podríamos proceder inmediatamente en minutos a la punción femoral. Ahora el hecho está en cuánto estamos dispuestos a aumentar, a estirar este intervalo de tiempo sin precisar pasar por el tomógrafo convencional. ¿Es 1 hora, 2 horas, 3, 6 o 12 horas? ¿Cuánto estamos dispuestos a alargar este intervalo pensando que es suficiente una tomografía adquirida con el angiógrafo? En este ensayo o estudio que hicimos en los centros terciarios de ictus de Barcelona, en los que estudiamos 2.770 pacientes con un código ictus que llegaron a estos hospitales, intentamos diferenciar aquellos o las características que diferenciaran a aquellos pacientes que acabaron recibiendo tratamiento endovascular de los que no, y ven cómo pues eran básicamente medidas de tiempo, de gravedad neurológica en las exploraciones de RACE o NIH, el ASPECTS o la situación premórbida, pre-ictus del paciente, mala situación funcional previa. También vemos que la mayor parte de estos pacientes, hasta el 80%, llegan en las 3 primeras horas, pero que en cambio el porcentaje o la probabilidad de que estos pacientes vengan con un ictus isquémico no varía en estas primeras 6 horas o 6 horas y media. También vemos que la probabilidad de que tengan un ASPECS perfecto, un ASPECS de 10, sí que disminuye rápidamente y se queda estable en torno al 60%, pero en cambio la probabilidad de que lleguen con un ASPECS compatible con trombectomía, es decir, un ASPECS mayor de 6 o más, pues es hasta superior al 90% hasta las 6 horas. Es decir, muy pocos pacientes se presentan en esta ventana temporal con un ASPECS que pueda contraindicar la trombectomía. De modo que probablemente no es necesario hacer mucha sofisticación de imágenes con tal de identificar estos pacientes, puesto que son rarísimos y en todo caso probablemente no sea perjudicial hacer una trombectomía en un ASPECS de 4. Finalmente vemos que la probabilidad de tener una oclusión de gran vaso también se mantiene relativamente estable, sobre el 40%. Y la probabilidad de recibir trombectomía pues está sobre el 35% también, invariable en estas primeras 6 horas, y esto es en relación con que no varía, no cae mucho el ASPECS en este tiempo. De modo que finalmente, si podemos asegurar que un paciente no tiene una hemorragia con una tomografía en el angiógrafo, que tiene un NIH mayor de 10 y una buena situación funcional previa, pues solo así ya podemos identificar al 60% de los pacientes que se van a beneficiar de. ¿Cuáles son los circuitos que puede seguir un paciente al llegar al hospital? Pues como hemos comentado antes, podrían ir a la urgencia, pero esto tratamos de evitarlo en todos los casos, puesto que supone un traslado de ida y vuelta al tomógrafo en el que se pierde mucho tiempo. Preferimos, siempre que sea posible y que seamos preavisados, mandar directamente el paciente a la sala de tomografía, y en algunos casos, si estamos en el hospital, estamos listos, preparados y prevenidos de que va a llegar el paciente, y además hemos realizado una exploración neurológica en la puerta que demuestra una alta probabilidad, una sospecha de oclusión de gran vaso, un NIH mayor de 10, podemos trasladar directamente el paciente a la sala. Como pues el sistema de emergencias nos traslada directamente los pacientes a la sala en algunos casos, y donde realizamos en muy pocos minutos desde la llegada. Ven cómo transferimos aquí el paciente, lo preparamos rápidamente, todo el mundo sabe lo que tiene que hacer, todo el mundo está muy bien coordinado. Aquí vamos a adquirir la tomografía, vamos a confirmar que no tiene una hemorragia intracraneal, y en este punto, en menos de 5 minutos desde la llegada a la sala, ya vamos a estar listos para iniciar la punción, iniciar el procedimiento. Es decir, es imposible ir más rápido si se hace este circuito. Ahora lo que tenemos que demostrar es que esto es seguro. Hoy en día, como ven, es capaz de detectar con toda seguridad grandes hemorragias o hemorragias intracraneales, sobre todo aquellas que van a repercutir un NIH mayor de 10, las vamos a observar todas. Incluso hay algoritmos que mejoran optimizan la calidad de la imagen, como ven que es de muy alta calidad, son imágenes obtenidas en la sala de angiografía. E incluso una crítica que se hace a la fosa posterior. En la fosa posterior también ven cómo es muy buena la calidad de imagen y se puede identificar perfectamente hemorragia. Nuestro primer encuentro o estudio piloto con el traslado directo a la sala de angiografía fue hace unos años ya. Desde que empezamos el protocolo observamos que aproximadamente un tercio de los pacientes era posible logísticamente trasladarlos directamente a la sala de angiografía, otro tercio iba directamente al tomógrafo y en algunos casos, en el último tercio, pues no fue posible o porque no nos avisaron o porque no estábamos ahí en ese momento, el paciente acabó pasando por la urgencia. Y aquí vamos a comparar los tiempos y los resultados. Y ven cómo el precio que pagamos por llevar directamente el paciente a la sala de angiografía es que efectivamente trasladamos pacientes sin oclusión, que no van a beneficiarse de trombectomía, trasladamos pacientes con hemorragia intracraneal y este porcentaje va a depender de nuestro porcentaje de pacientes directamente admitidos de la calle o aquellos que vienen desde otro centro donde ya se han filtrado los que tienen una hemorragia, una tomografía, y ese precio que pagamos es con tal de obtener esto, una reducción drástica de los tiempos. Ven cómo alcanzamos tiempos medios de puerta a punción de 15, incluso de 8 minutos en algún caso, comparado con más de 60 minutos o incluso 90 si el paciente pasó por el servicio de urgencias. Es decir, podemos reducir 50, 60, 70 minutos y esto tiene que tener un impacto sobre el pronóstico. De hecho, en este primer estudio ya vimos que de aquellos pacientes que pasaban directamente a la sala de angiografía, habían muchos más que tenían lo que llamamos un dramatic clinical improvement, una caída de más de 10 puntos en la escala NIH en las primeras 20. Existen otros grupos que plantean lo mismo. Algunos plantean hacer el diagnóstico de la oclusión de gran vaso con una angio-CTA en la sala de angiografías, con el angiógrafo. En todos los casos se demuestran disminuciones muy importantes de los tiempos, en torno a 20 minutos desde la puerta hasta la... Aquí ven muchas publicaciones que se están popularizando en estos últimos años. Y para evaluar el impacto sobre el pronóstico, pues en nuestro primer estudio no era muy conveniente hacerlo porque no estaban bien balanceados los grupos en cuanto al tiempo desde el inicio de los síntomas hasta la llegada. Pero nosotros realizamos un estudio de casos y controles en los que balanceamos los pacientes en función de la edad, de la NIH, del tiempo hasta la llegada y de la localización de la oclusión, y ven cómo esta disminución dramática del tiempo, de casi una hora, al ir directamente a la sala de angiografía, repercutía en lo que es el ranking a los 3 meses. Había un 13% más de pacientes que tenían buena evolución favorable sin discapacidad a los 3 meses. Esto nos alentó mucho, nos confirmó que íbamos por el buen camino. ¿Qué es lo que hay que hacer para popularizar, para generalizar una medida? Pues básicamente hay que hacer un estudio randomizado, bien aleatorizado y bien controlado, y es lo que estamos haciendo, es lo que estamos planteando en el estudio We Trust, en el que a la llegada al centro, luego hablaremos un poco más del protocolo, pero es lo que estamos planteando en este estudio We Trust internacional. Aquí ven otro ejemplo, otro paciente que llega directamente, como hacemos rápidamente aquí otra exploración neurológica, una más, hasta confirmar que lo es, pues podamos iniciar el tratamiento. Pero una pregunta que surge habitualmente, ¿estamos negándole el beneficio de poder dar TPA endovenoso, trombolisis a estos pacientes por el hecho de llevarlos directamente a la sala? Y yo creo que la respuesta es no, y basada en nuestra experiencia. Tenemos aquí en esta diapositiva, aparecen 20, pero actualmente tenemos más de 35 pacientes tratados con fibrinolisis pues después en la sala, después de adquirir la imagen con el angiógrafo, y ninguno de ellos ha tenido una transformación hemorrágica sintomática. Las tasas de transformación hemorrágica son similares a un grupo control en el que se administró TPA tras una tomografía convencional. No hay mayores tasas de complicaciones. Creemos que la calidad de la imagen del angiógrafo, del Con-Beam CT, es suficiente para poder administrar TPA. Probablemente es incluso mejor que la de los primeros estudios con TPA en la década de los 90, en los que se administraba TPA basado en los angiógrafos de la época. Y la última pregunta que nos hacemos, ¿hasta cuándo es beneficioso el tratamiento, esta vía de admisión directa a la sala de angiografía? Vemos en este otro estudio de casos y controles cómo en general el pronóstico favorece siempre al grupo que fue derivado directamente a la sala de angiografía, y si se fijan en las horas ven que el beneficio es mayor para aquellos pacientes que llegan en menos tiempo. Es decir, y esto es lógico, aquí ven todos los pacientes, aquí los hemos clasificado aquellos en menos de 3 horas y más de 3 horas. La reducción del tiempo es pues similar entre 45 y 55 minutos, pero 55 minutos van a tener mucho más impacto en las primeras 3 horas, relativamente significan mucho más percentualmente en las primeras 3 horas que hasta en las 6 primeras horas. De modo que reducir 50 minutos en un paciente, en un fast progressor, lo que llamamos un paciente que recluta rápidamente el infarto en las 3 primeras horas, pues va a tener un gran impacto, y en cambio cuando estamos más acercándonos a las 6 horas, pues va a tener menos impacto esta reducción de tiempo, obviamente. De modo que cuanto antes llegue el paciente, más se va a beneficiar de este. Y aquí ven la gráfica mostrando que el beneficio es sobre todo en las 2-3 primeras horas y se va perdiendo a medida que nos acercamos a 6 horas. ¿Por qué realizamos el estudio We Trust? Lo hemos planteado en 16 centros, por cierto, en el centro del Dr. Lilik. Tenemos el placer de contar con él y su equipo. Están ellos y nosotros muy ilusionados con el proyecto. Pretendemos incluir en estos 16 centros en todo el mundo más de 500 pacientes, aproximadamente en unos 2 años. Los vamos a seguir hasta los 3 meses. Y esta es un poco la idea. Queremos evaluar si podemos prescindir de esta imagen que a la llegada del paciente, de la imagen la que se haga habitualmente en el centro, ya sea una tomografía o una resonancia. Y los pacientes se autorizarán a ir directamente a la sala o a ir a la imagen convencional, y a partir de aquí seguirán la práctica clínica habitual, el tratamiento con trombectomías, si hace falta o no. El primary endpoint, el endpoint primario, se verificará en aquellos pacientes con oclusión confirmada, y veremos qué ha pasado con ambos grupos de pacientes en 30 días. Esto queremos conseguir, queremos demostrar que un traslado directo a la sala de angiografía es positivo, tiene un impacto positivo sobre la evolución de los pacientes, y que la tecnología actual está lo suficientemente madura para hacer esta selección de los pacientes rápidamente, y así reducir estos 60 minutos, 40, 50 minutos. Creemos que juntos podemos lograrlo, y estamos listos para empezar este ensayo en las próximas semanas, yo diría. Esperamos que sea en el mes de enero o febrero, ya se pueda reclutar a los primeros pacientes. Y muchas gracias por su atención. Encantado de discutir sobre el tema en esta sesión de preguntas. Gracias.
Ok, muchas gracias, doctor Ribó. Excelente el proyecto y la presentación. Esperemos el año que viene contar con su compañía de manera presencial. Lamentablemente estamos cortos de tiempo para las preguntas, así que continuamos con la última presentación del segmento. Continuamos, Pedro, entonces.
Muchas gracias, Javier. Sí, bueno, llegamos a casi al final, nos faltan los simposios de la industria y ya estamos. Pero antes de eso, hay una sociedad, SWIN, la Sociedad Norteamericana de Neurólogos Intervencionistas, que está empeñado en una gesta que creo que es muy noble y muy importante para todo el mundo. Y mucha gente alrededor del mundo se ha embarcado en esto, es MT 2020. Tenemos el placer de tener acá con nosotros al presidente de esa sociedad, a Dilip Javagal, que es profesor de neurología clínica y neurocirugía, es director de neurología intervencionista, codirector de neurocirugía endovascular, y aparte es director de la plataforma de células madres neurológicas de la Universidad de Miami y del Jackson, que todos conocemos en Miami. Así que lo tenemos aquí a Dilip, que nos va a contar de qué se trata esta iniciativa. We just thank you for waiting for us, Dilip. We have a pleasure to have you with us, ending this symposium about ischemia in Buenos Aires. We thought with Javier and Esteban, and also with our co-chairman of MT 2020, with Ángel Ferrario, that will be a fantastic thing to finish our symposium with your advice about the MT 2020. So please, the platform is for you, and we are waiting for your talk. Thank you for being with us, and welcome to Buenos Aires, virtually.
Thank you so much. Thank you so much. It's such a pleasure to join all of you. I visited Buenos Aires last year in November, and I thought I would come back much earlier to your beautiful city, but at least I'm there virtually. Thank you, Dr. Lilik. Thank you, Pedro, for inviting me. And I won't waste any time, because the topic that you've allowed me to kindly present is very exciting and close to my heart. Mechanical Thrombectomy 2020 Plus initiative, global initiative working together globally for stroke thrombectomy access. So these are my disclosures. I don't own any patents or royalties. I do consult for companies, and I have grants for stem cell research in stroke. So the outline for just the next 15 minutes is going to be fairly straightforward to discuss with all of you the rationale for Mission Thrombectomy 2020 Plus. Why did we do it? What is the mission and vision of this global public health campaign? How are we currently organized? And then the public health interventions that we are pursuing to accelerate access to thrombectomy globally. So what is become very clear is that there is a major burden of stroke globally, and that burden is very geographically disparate. And what do I mean by that? So 80% of this global burden of 17 million strokes that is also quoted to be around 13.6 million. So there are, I think there is a overall decrease in the annual incidence of stroke since these numbers in 2010. 2016 numbers are 13.6 million, which is good, but it's still a staggering burden. And 80% of that burden is in low and middle income countries that have less than 20% of the resources to really attack this global burden. The number of survivors actually is now estimated to be about over 100 million stroke survivors globally. And so this long-term disability burden due to stroke is now substantially modifiable. And why do I say that? Because all of us know that the major burden of stroke comes from large vessel occlusion stroke, and we finally have a highly effective therapy for that subtype of stroke. And so that's why, without going into the details of all the evidence we all know of the multiple randomized controlled trials that showed that mechanical thrombectomy is not only highly effective, but very safe and very cost effective, we now have a blockbuster trial published in New England Journal by our dear friends Sheila Martin and Raul Noguera, showing that this therapy is immensely beneficial even in low and middle income countries. And so this can be implemented virtually anywhere globally. And this is a trial from Brazil, as you know. And this therapy is highly cost effective. So it's while highly costly, it is very cost effective, because if you look at the study from Saudi Arabia, modeling study showed that this implementation of thrombectomy led to a saving of $600 million over 15 years, because the number of disability years that are saved by doing a mechanical thrombectomy and making a patient independent is that outweighs the upfront cost of the treatment. So when we have such a effective therapy, the question that we asked in SVIN in 2016 is, what is the gap in treatment? And we started just even with the US, which is a leader in mechanical thrombectomy, and we found that even the US had a major gap. What we saw was that the number of eligible patients for thrombectomy was a widely ranging estimate. One estimate thought it was between 30,000 and 100,000 patients. But there are other estimates that go up to almost 200,000 patients of LVO in the US. And that is now felt to be the more accurate estimate. And in 2016, we were only performing under 20,000 thrombectomies. So less than 10% penetration. And the worldwide estimate of LVO, if you take the 17 million figure or if you take the 13 million figure, is 1.7 million to 1.3 million LVOs annually, with the total number of thrombectomies in 2016 was less than 100,000. So the gap in implementation of this highly effective therapy is staggering. And this is compounded by the fact that access to stroke treatment is very time sensitive for outcomes. Even in the US, in 2011, only 60% of the population had an access within 60 minutes to a endovascular stroke treatment capable hospital. And even the recent modeling data, almost 10 years later, shows that only 63% of US population would have a 60-minute ground access. And with air, that goes up. But this is still a very humbling figure that we are far away from achieving a high degree of access to this highly effective therapy. And as we know, one of the most effective therapies in medicine with a number needed to treat of 2.5. What we also know is that even in a given continent, such as Europe, there is a major geographical disparity. Western Europe has very good number of units, whereas the Eastern Europe has a lot less penetration of the number of stroke units per million inhabitants. So this geographical disparity is what made us think about a global campaign that could address this disparity that exists globally and try to really decrease that disparity using a public health intervention. When we looked at the numbers beyond 2016, here is what we found. In the US, the numbers went from 10 to 20,000 in 2016, went to 32,000 in 2017 thrombectomies, and to 45,000 in 2018. And the 2019 numbers that just came out that I didn't get a chance to put here are still around, just around 50,000 in the US. And so the question is, by 2020, can we get this closer and to a 50% penetration? Worldwide, the numbers are even more staggering. Staggeringly low is what I mean. And there were 79,000 in 2016, total thrombectomies. 2017, they rose up to 106. 2018, they went up to 156, so a decent increase. And 2019, this is projected, but it's actually a true figure of 192K thrombectomies in 2019. So the goal that we proposed is that we would double these numbers to a goal from 2018 to 2020 of 220,000. 202,000 thrombectomies using public health interventions. That's where Mission Thrombectomy 2020 was born, with that thought in mind, and we announced this in 2016. And the vision and goals were as follows. MT 2020 is a global metric-driven umbrella campaign. So we believe that we are going to be holding hands and joining all parties and societies that are interested in increasing access to thrombectomy to reduce death and disability associated with LVO ischemic stroke by accelerating access to mechanical thrombectomy. And how are we going to do it? We are going to integrate disparate knowledge barriers that we know from different regions. We are going to unify multiple efforts that different societies have. And we are going to use public health interventions and double the access to thrombectomy every 2 years for the next decade so that we can reach to a 50 to 60% penetration. And again, like I said, the goal for 2020 is 202,000 thrombectomies to make it catchy for the year 2020. We have to see, we are in the last month, and we have to see in a few months if we did achieve that. And so how are we going to do it is something that I'll describe in the next few slides. But it's useful to step back and learn about some principles of how do new treatments diffuse. This should actually say, how do new treatments in medicine diffuse? And it turns out that it takes about 30 years for a new treatment to reach about 40%, or about 50% access, And this is constrained by information, by facilities, by trained physicians, by financial access. And so this is actually not something that is only specific to thrombectomy, but this is what happened to STEMI for heart attacks. And turns out that way back in 1962, Everett Rogers figured out this by modeling that new treatments, unless you do active public health interventions, they're going to take a long time to reach the patients that they can benefit. And so what we decided was that thrombectomy was indeed in need of public health interventions. And this is again based on principles of what conditions can be benefited by public health interventions. They have to be a large health burden, which stroke is. The burden is distributed unfairly, and that I told you that's the case globally. The treatment is highly effective and safe. And so we have thrombectomy that's very safe. The treatment is cost effective. And there must be evidence that upstream preventive strategies. What do we mean by that? I'll come tell you in a second. These are political and social strategies that could substantially increase access to this effective treatment are not yet in place. So this is a clear indication that thrombectomy needs public health intervention to increase access. And the upstream strategies are economic, they're political, and they're community factors that are addressed by these strategies that can substantially increase the treatment. And so what we want to do is take this 30 years time horizon in both high income and low income countries and move that to the left and make it in 10 to 15 years rather than this long time in each of these regions. And we are going to do that by arming ourselves with the knowledge of the access pillars. And so these public health interventions will address what we know are the pillars of treatment access. The first pillar is information and diagnostic access. There should be enough information, widespread information about LVO diagnosis and triage. So both specialists and generalists need to know about LVO diagnosis and triage, and therefore allow for a correct triage of LVOs to the right facility. There needs to be the facility itself. So physical access is a second pillar, and the distance to facilities, the availability of angio suites, and the actual availability of stroke teams to manage this flow of patients is all it all falls under physical access. And then, of course, probably the most important is financial access, where this treatment is reimbursed because there is clear agreement that this is highly effective and cost-effective treatment, and it does not fall on the patient at an odd hour to have to come up with this payment out of pocket. So what we have come up with is a scoring for access that is in development that is based on all these three pillars. And what we want to do is accelerate LVO diagnosis and treatment with public health interventions. We want to accelerate physical access, physical infrastructure, and we want to accelerate the financial ecosystem so that this treatment is highly reimbursed. So we put this structure together over the last 4 years that has a core leadership team in the US and a global executive committee that is comprised of all the regional co-chairs that are based globally. This central committee works with several leaders in stroke throughout the globe that are in different parts of the globe. Dr. Demchuk, Carlos Molina, Sheila Martins, Thomas Leong, Osama Mansour, Dr. Miao in China, Dr. Sailaja in India, Dr. Mehari Gabians from representing Africa, work with all of us in the core leadership committee that include my colleagues, Dr. Inoa Jadhav or Santiago Ortega, who many of you know, and Dr. Al Mufti, and we have added 4 more excellent rising stars in stroke and neurointervention, Drs. Kaushal, Nabil, and Asif to this roster. And we all work with regional committees that are based in different, in all over the globe. And this regional committee is comprised of a stroke chair, a neurointerventional chair, and 6 to 8 board members that are distributed between stroke and neurointervention. And we have a country liaison that connects us to the regional committees that is based in the US, is from originally from the country they are liaison for, so that we can use that connection to stay closely connected with the regional subcommittees. The SVN Leadership Committee guides us, and then there is a excellent project management company called Orbis Medical that helps us administrate this very large structure on a day-to-day basis. We have an advisory committee of all the societies that are partnered with us, including AHA, ASA, ESO, Mina Sino, and certainly SIMI would be another society that we could be partners with, and we get advice. And I'm very happy to announce today that we have a total of 82 committees now, or actually 86 now as of this week, that are spread in 6 continents throughout the world. So this has been a amazing growth over the last year, where we have all these regional committees that are carrying out several public health interventions in their regions. We launched 86 committees, as I mentioned. We are starting to communicate to the regional ministries of health and health policymakers the white paper that was published in that was actually developed in 2019, just published this past World Stroke Day, which is a white paper on building thrombectomy capacity, why and how, which is directed towards health policymakers. So it's written in a language that is non-technical, non-medical, and it really informs health policymakers and ministries of health why thrombectomy capacity building is important. We have a regional thrombectomy capacity baseline survey that's ongoing in each region that the regional committees are carrying out. We are asking the regional committees, and they're working very hard to develop and have an implementation plan for top 5 public health interventions customized to their region for 2021. And then we have a very exciting smartphone app that's called a Global Thrombectomy Tracking app that we want to increase adoption for, because what it allows us is to enter a case in about 30 seconds that's de-identified, and that case gets geotagged with the smartphone technology to the institution that the case was done in. And so you can zoom in and zoom out to see in real time, as long as that case is entered, how many thrombectomies were done in the last day, in the last hour, and even in the last minute, both regionally as well as globally. And so this is a app that the regional committees are working on. Now, coming back to the white paper, this white paper is for policymakers, as I said, and there is going to be customization to high income, low income, and very low income countries, as well as translation of this paper. Going forward, the core committee is developing patient education materials. It's developing new payment methods that can new infrastructure and payment methods. We are increasing certification programs that can be adopted quickly in low and middle income countries, and then develop innovative payment methods that can facilitate reimbursement. This is an example of a self-attestation certification that has been developed in India for thrombectomy centers. And we have several white papers in the pipeline for rural access with SNIS, and a global demand and supply of workforce with WFITN. So in conclusion, and I hope I didn't exceed my time by much, MD 2020, and it should be plus because we are going beyond 2020, so the name has been changed to MD 2020 Plus, is a global multi-stakeholder public health campaign to accelerate access to LVO stroke patients with the ultimate goal to lower death and disability from acute ischemic stroke. The campaign aims to see a successful goal of 202,000 thrombectomies by the end of 2020, which is a feasible goal of the near doubling of thrombectomies from 2016 to 2018 of 100,000. So we do hope to see, because 2019 we had almost reached 200,000, that most likely we're going to exceed 202,000 thrombectomies in 2020. But really, it's a forward-looking goal that every 2 years in this decade, we're going to double numbers that will close the gap. And I talked to you about, I've shared with you the interventions that we've already done and what we are in planning for the future. So thank you so much for your attention. And I'm really thankful and happy to take questions.
Well, thank you very much. That was a fantastic end of our stroke meeting in Buenos Aires. I think we really thought that will help really for the initiative and will be help also in every single country, not only in Latin America and around the world. So congratulations for initiative. We are going to help and push a lot from Buenos Aires and from Argentina and from Latin America. Unfortunately, we are running out of time as usually. So we are going to close the day. That has been a very productive day. Thank you for all of you. Thank you for people who were connected in Argentina, Buenos Aires, Latin America. We are going to end it up with the industry symposium. So looking forward to see you tomorrow with us in the morning. I will pass to the guys that will announce the symposium, the evening symposium, I think, actually very late evening symposium. Thank you. See you tomorrow. See you tomorrow. Bye. See you tomorrow.
Bueno, terminando, como decía, cuando hablaba el doctor Ilic, vamos a presentar el simposio de la industria. El simposio de la industria va a estar dividido en dos partes. Vamos a arrancar inicialmente con Philips, que nos estará hablando el ingeniero Alexander Hack, que es uno de los principales científicos en Estados Unidos para el segmento de angiografía. Y va a haber un segundo segmento donde será el simposio Medtronic, donde el doctor Pedro Ilic también nos hablará un poco de la experiencia de Pipeline durante los últimos 13 años. Así que vamos a empezar con el ingeniero Alexander Hack. Vamos primero con la tandita. Okay, Alex. Okay, we will start with the symposium. Alex, I think you are ready.
Thank you, Carlos. Thank you, Dr. Lillig and team, for having me here. It's a pleasure and honor to be here. And, you know, like I have been listening to all the talks for the past 2 days, and yeah, a very impressive program. So congratulations to that. So yeah, I want to talk about like our innovations and what we are working on within Philips, but I figured it would be also good to talk about yeah, our missions and where we came from and where we want to go. So Philips, you know, like changed quite a bit in the recent years. You know, like we are focusing solely on healthcare. You know, like we don't sell light bulbs or TVs anymore. And basically, the health continuum is, you know, like our main focus. You know, like from healthy living to prevention of diseases to diagnostic treatment, and you know, like also to the home care. And within Philips, we have different clusters which, you know, like span or which handle, you know, like different parts of the healthcare continuum. However, you know, like I'm part of image-guided therapies, you know, like the business unit that develops angiographic systems. And we overall in Philips, you know, like we want to achieve a quadruple aim, which is basically improving patient experience, better outcomes, improve staff experience, and also lower the healthcare costs. And if we look at image-guided therapies, you know, like from the early beginnings, you know, like from developing X-ray tubes and angio systems and reducing those, we also switched in this business unit gears, and you know, like focused also on the treatment of patients, which, you know, like started by acquisitions around 2015. IGT system, you know, like one of our pillars that we are working on is really, you know, like improving the workflow. So, you know, like we want to basically improve our systems in a way that they are not, you know, like that you don't have to work around them, that the system works around you. So you can see this, for instance, here with our flex arm systems, which is flexible, you know, like in the position where it is, so that you can work, yeah, from everywhere, and that the system moves out of the way. The same, you know, like from our, you know, like from the technician or from using our systems, you know, like we have parallel working from the workstation, then also with our latest Azurian release, you know, like the focus is really, you know, like how do we improve workflow, you know, like to have the best experience for the physicians, for the people who use the system, but also, you know, like the best experience from a patient perspective. So, you know, like we integrate our, you know, like intra-arterial imaging, you know, like we use more and more the touch screen, you know, like to do yeah, measurements or to mark certain landmarks. So workflow is, you know, like really one of the things that we have been focusing on a lot. If we, you know, like look at these improvements, you know, like we have been conducting studies where we show, you know, like that, you know, like in the preparation or during the procedure, we can save quite some time, you know, like making the system, you know, like work for you, you know, like easy to use, which actually resulted in a 17% reduction in procedure time, you know, like just by you know, like working on the usability of the system. However, you're like looking at workflow also means actually looking at workflow for certain disease areas, and you know, like stroke is certainly a disease area where we have been looking a lot. I mean, I don't have to explain anybody here, you know, like about you know, like the implication of stroke in terms of, you know, like disability, cause of death, and you know, like how many cases there are, you know, like worldwide. And you know, like since 2015, you know, like since all those thrombectomy studies came came out, like it's pretty well established that, like an effective reperfusion for ischemic stroke is a very effective treatment. And the earlier a patient can receive that treatment, the better it is for the outcome of that patient. And we as Philips, like we look at this overall stroke pathway, like holistically, and from emergency care to diagnostic to treatment, how can we improve that? And there certainly several things where you can improve. Like if you look at the stroke pathway, like from onset of the stroke, you're usually picked up by an ambulance, and there you can certainly do improvements, like to basically get the patients into the right hospital, like to a comprehensive stroke center or to primary stroke centers. And like during this conference, we have seen several approaches and technologies that can help. And even if you're once in a primary stroke center, the decision making, or the workup in the primary stroke center to get to comprehensive stroke centers, there's a lot that you can gain. However, we as IGT systems who work on the angio system, we focused on how can we make the workflow better in the comprehensive stroke center. And as already Mark Rebo or Raul Nogueira pointed out, if you skip the CT imaging, the diagnostic imaging, and you go directly to the angio suite, you can save quite some time. And with saving that time, you may be able to improve outcome. And the preliminary studies pointed all in that direction. And we as Philips sponsored a study, a direct to angio study, which we call VTrust, which we are actually very proud of. And so why do we think we can do a direct to angio study? And that also has to do with technology, and especially with innovation in how we acquire cone beam CTs and what image quality we can expect. So we have a new image acquisition, which we call a butterfly acquisition, which basically doesn't just have a circular movement, it also has a cranial caudal component to this. And together with a new reconstructor, we are basically able to improve the image quality by a lot. So there are less beam hardening effects. So here on the left-hand side, you see a standard cone beam CT. In the middle, you see the new cone beam CT. On the right-hand side, you see a multi-detector CT. You have less bleeding of the skull into the soft tissue, but you also have less artifacts from the skull base, which you can actually see here where we slide in truth the volume in axial fashion. So we have done extensive studies clinically, these images you see here, courtesy from Vitor Pereira from Toronto. And we are using this type of technology in the direct to angio study, to exclude hemorrhage. So if we look at all the imaging and the non-contrast CT where we exclude hemorrhage, you also want to give the physician tools to assess the vascular anatomy, and also the parenchyma and the salvable tissue that you may have. So the idea is basically that you acquire your non-contrast cone beam CT, and then that you inject IV contrast, and you watch it on fluoro until the contrast arrives, and that you then acquire an early phase cone beam CT, contrast enhanced, and a late phase. And basically, with the early phase, you can assess, the healthy tissue and the blood clot, and with the late phase, you can assess collaterals and the penumbra. So how does it work? So basically you have a mask, you have an early phase cone beam CT and a late phase cone beam CT. And if you subtract the mask minus your early phase, like you get an idea of, like what's your core volume. If you use the mask, if you use the late phase, and the early phase, like you can get an idea about your penumbra. And in Toronto, like where we ran studies, like we had actually nice correlation between like these penumbra estimates and actually rapid scoring from standard CT.